I am going to present the poster on current trends and future perspectives of non-surgical periodontal therapy. So non-surgical periodontal therapy is an integral part of any periodontal treatment plan, and conventionally it involves SRP along with patient motivation and oral hygiene instructions. However, with advancements in periodontics as well as science and technology, newer approaches in NSPT are being developed. This poster reviews 4 of those advancements in NSPT. So PerioProtect is a customized comprehensive method that helps to manage subgingival and interdental biofilms that are not usually accessible by the patient. It involves a combination of non-invasive chemical debridement therapy in conjunction with traditional mechanical debridement. This chemical debridement involves the use of 1.5 to 1.7% hydrogen peroxide with or without adjunctive antibiotics. And this is placed into a customized tray called Perio tray and can be used by the patient as a part of home oral hygiene maintenance. So Keller et al. In 2017 mentioned that direct delivery of medicaments with a custom tray modifies the biofilm from a more virulent anaerobic to a less virulent aerobic composition and reduces the number of pathogens. Dentrifer robots or nanorobotic dentrifices delivered either by mouthwash or toothpaste are invisible, small, and purely mechanical devices that crawl at a speed of 1 to 10 microns per second and that can safely deactivate themselves when swallowed. They can cover all the subgingival surfaces, thereby metabolizing any trapped organic matter into harmless and odorless vapors, and concomitantly can perform continuous calculus debridement. Triimmunophasic therapy or TIP is a minimally invasive technique that includes bone one-session treatment, control of occlusal forces, oral hygiene reinforcement, and various lifestyle modifications. BOST or bone one-session treatment minimizes damage to the gingiva, bone, and periodontal apparatus during treatment using something called the stretch flap technique. So in stretch flap technique, it allows the access all the way to the deepest areas of the root and the surface of the bone without giving a single incision. So during healing after BOST, 3 phases are seen, starting with the defensive phase wherein there is stem cell migration, regeneration phase, and healing of new attachments. Perio aid helps to clean the area under the gingiva and eliminate the disease-causing anaerobic bacteria, thereby helping in new attachment formation. Guided pocket recolonization, on the other hand, first introduced by Tugels et al. In 2007, involves the administration of probiotics or symbiotics into the periodontal pocket to confer health benefits to the patient. He determined that while the application of beneficial bacteria did not exclude pathogen recolonization completely, it did delay the recolonization process significantly. So commercially available kits like Gum Perio Balance by Sunstar or Bifilac GG by Rhamnosus can be used for this purpose. Shetty et al. In 2020 used Bifilac R, which is a symbiotic, towards guided pocket recolonization. So to conclude, the future of periodontics lies in the convergence of clinical dentistry, genetics, molecular biology, and biotechnology, along with various other fields of science and technology. So this results in the emergence of novel therapeutic approaches that can offer a more efficient, safe, and less traumatic alternative in the treatment of periodontitis. Thank you.
So Priya ma'am, any questions?
Hello Shruti.
Yes ma'am.
Can you shed some light on other novel agents that can be used in non-surgical periodontal therapy apart from what you have presented?
Yes ma'am. So laser is very common, can be very commonly used for pocket therapy nowadays. Along with that, photodynamic therapy is also coming into mainstream of non-surgical therapy now.
Any anabolic agents which can be used as in NSPT?
Anabolic agents, I'm not sure.
Okay, fine.
Dr. Shruti?
Yes, ma'am.
Your post is about non-surgical periodontal therapy.
Yes, ma'am.
Right? This can be this non-surgical therapy, the protocols what you mentioned right now, can be used as an adjunct. What do you advocate? Can be used as an adjunct?
Ma'am, currently none of these procedures have come into the mainstream, and large-scale studies have not been conducted for any of these procedures. So for now, it is being advised that this will be, all these procedures can be conducted as an adjunct to scaling and root planing rather than alone.
There's a vast arena for more research work in this area.
Yes, ma'am. More research has more large-scale studies and randomized studies are required to elicit the correct methodology, and even for the correct dosage that is required for hydrogen peroxide or any antibiotics that is required in PerioProtect also. Most large-scale studies are being recommended by the authors.
Thank you, Dr. Shruti.
Thank you.
Our next presenter, Dr. Nilima. Dr. Nilima, am I audible? Dr. Nilima?
Hello.
Yes, doctor. Good morning. Please start.
Good morning, ma'am. This is Surbhi, Dr. Surbhi.
Your poster number is
046.
Are you co-authoring the paper?
Yes, I can see that, ma'am.
Yes, yes, yes. Please start.
Very good morning. So today's poster is about the magnification periodontics. As we all know, microsurgery means the surgery performed under the optical microscope. So as a patient awareness has increased and every dentist has a desire to provide, to encompass the elimination of the disease, to provide an ideal therapy with the restoration of aesthetic and function with the minimal trauma and discomfort, the magnification system has it has gained a lot of popularity. So in comparison to the conventional technique, magnification system, it treats in a wider range. So microsurgery, it revolves around three elements: your magnification, illumination, and precision or instrumentation. When we come to the magnification system, there are two types of magnification system that are available, which is your dental loops and your surgical operating microscope. So where the dental loops provide us a magnification from 2 times to 2.5 times to the 10 times in prism loops, your surgical operating microscope can provide from 4 times to 40 times of magnification. So there are different kinds of instruments that are available for the microsurgery, which is your micro scissors, micro needle holder, micro forceps. These instruments are basically designed with made up of titanium, and because of their lightness and their handling and their non-magnetic characteristics. So these instruments can help in as we use the thumb, the index finger and the middle finger for the revolving of the, for manipulating the instrument. These instruments are, the handles are made rounded for proper revolving of the instrument or proper use of the instrument. Now, these microsurgery has been used in the various different procedures, like your, from diagnostic procedures, it has been used in your crown lengthening, in connective tissue grafting, scaling and root planing, and also in the smile designing. Now, if various studies has been performed, like by the Cortellini and Tornetti, where he used a microscope for the surgeries and found there was uneventful wound healing, there was less edema, less hematoma formation. And another study by the Cairo et al., who did the treatment of the periodontal pocket and found there was, the result gave that there was minimum recession and minimum discomfort. And now the future perspective of the surgeries is that the operating microscope has revolutionized the periodontics, the dentistry from 1970s, and now the robotic microsurgeries are at the verge of creating a new era. So the new robotic surgeries like your Da Vinci robotic surgical microscopes are available, which are now FDA approved. So basically, the microsurgery provides us with a proper wound healing, less trauma, and it is mostly acceptable by the patient. Thank you, ma'am.
Thank you, Dr. Surbhi. Dr. Supriya, questions, please.
Hello, Surbhi.
Good morning, ma'am.
So what do you think, which is better, magnifying loops or operating microscope?
Ma'am, dental loops are available in the 2 times and 2.5 times and 3.5 times of magnification. So if we are using in the periodontal surgery, from 2.5 to 3.5 times of magnification is good. But if we look for the surgical microscope, that provides us with a better posture, better ergonomics, and it is actually better because it is provides us from 4 times to 40 times of the magnification. If we treat a patient in a wider view, it is better than what we are viewing with the unaided eyes.
Okay, so what is the operator ergonomics when using a surgical operating microscope?
Ma'am, we get a straight posture and precision, and there is a less physiological tremor hand controls. These all are provided with your use of the surgical microscopes.
Okay, fine.
Dr. Surbi, what are the disadvantages you look at?
For now, ma'am, I would say the disadvantage is it is very cost effective.
Yes.
And yes, you need you have to have that control. You have to have that hang of using a microscope. So basically, more of surgeries has to be performed to get that kind of precision. So it's you have to use it for a long term because you doesn't get it easily.
Yeah,
So
I think the clinician has to be trained before using
yes,
this
they
kind
have
of
to be
equipment.
trained.
Yes, definitely, this is the future. That's what we are looking at.
Yeah, we look for the robotic microsurgery.
Thank you, doctor. So we'll move on to our next presenter.
Thank you very much, ma'am.
Poster 47. Dr. Hanisha.
Yes, ma'am. Hello.
Good morning.
Good morning, ma'am.
Please start.
Yeah. Ma'am, am I audible?
Yes, you are. Please start.
Good morning to everybody. Today's my topic of poster presentation is the antimicrobial peptides. The antimicrobial peptides constitute an important component of the innate immunity response that protects the host from a broad range of pathogens, according to a study done by Castro and Potts in 2005. Generally, humans often require a multi-layered defense mechanism to function smoothly and combat the microbes. AMPs generally bridges the innate and acquired immune systems to combat both innate and acquired immunity to combat the microorganisms. AMPs contain both hydrophobic and hydrophilic side chains that enables these molecules to be soluble in the aqueous oral environments. The tooth structures often encompasses a layer of pathogenic biofilm called the dental plaque that includes the surrounding epithelium by exposure to the oral microorganisms. The oral epithelium acts as a physical barrier to counter the microbes by the production of chemokines, cytokines, and antimicrobial peptides, which enhance the inflammation and immune response in the oral epithelial tissues. The production of the epithelial antimicrobial peptides are considered to be the paramount for the innate immunity. AMPs are generally classified broadly into 4 different groups based on their structures. They are the alpha helical AMPs, the beta sheet AMPs, and the extended structure AMPs, and the cyclic AMPs. Of these, alpha, beta, and extended structure AMPs are utmost important in humans. The alpha helical AMPs examples are the catholicidins, and the beta sheet antimicrobial peptides are further classified into alpha defensins and beta defensins. Out of these, alpha defensins are available on the neutrophil granular membrane, and the beta defensins are generally present in the oral cavity, example in the gingiva or in the buccal mucosa. And the examples of extended sheet structure antimicrobial peptides, they generally do not lack a structural motif. That's why they are given the name extended structure AMPs. They are generally lack of specific amino acids which are present in higher antimicrobial peptides. Moving on to the mechanism of the action. Mainly, the mechanism of action is broadly classified into 3 categories, out of which is step one is the attraction, followed by attachment, followed by the modes of insertion. Attraction is the initial step with the action of the antimicrobial peptides. The electrostatic interaction between cationic antimicrobial peptides and anionic bacterial cell membrane is known to cause the attraction. Further is followed by the attachment, where the antimicrobial peptides get transformed into a secondary structure, which causes them to orient either parallel or perpendicular to the membrane. This is followed by the subsequent pore formation, with the peptides getting oriented in a perpendicular fashion. Moving on to the models of insertion, there are basically 3 models of insertion. The first one is the toroidal pore model, where the antimicrobial peptides are oriented vertically to the bacterial cell membrane. Second is the barrel stove model, where the antimicrobial peptides are oriented in a ring-like manner along the lipid bilayer of the bacterial cell membrane, and the carpet-like model, where the antimicrobial peptides are arranged parallel to the cell membrane. Their hydrophobic end faces the solution, and the hydrophobic faces the phospholipid bilayer. AMPs cover the cell surface like a carpet and destroy the cell membrane in a detergent-like manner. And next is the action of antimicrobial peptides on host innate and adaptive immunity. They exert the anti-inflammatory activity by preventing the interaction between the microbes and host cells and stimulating the secretion of cytokines. AMPs binds with CD14 and lipopolysaccharide secreting binding protein to impair the binding capacity of the components on the bacterial membranes to host cells. CD14 is broadly classified into two types: membrane available CD14 and serum available CD14. Casually, we see the membrane available CD14 on immune cells and on the bacterial lipopolysaccharide, and the serum available CD14 mediates the binding between lipopolysaccharides and the cells involved in immune system like the neutrophils that do not have a membrane bound receptor, such as the epithelial cells of the oral cavity. And up to date, the human saliva and GCF contains 45 different forms of antimicrobial peptides. And the advantages of the antimicrobial peptides are they are highly wide spectrum. They have a very wide spectrum of activity of bactericidal action, and they provide the immediate action. They have an anti-biofilm and anti-cancer activity, and they provide very low risk of developing resistance. And they are highly biological, and they are not causing any damage to the host. But at the same time, there are certain disadvantages for the antimicrobial peptides, like they are highly cost effective, and they are poor in absorption, secretion, and metabolism, and they are highly unstable inside the host system. Further studies are needed, and further antimicrobial peptides must be coming to the action for providing efficient antimicrobial molecules which help the humans fight against the several microbes. Thank you.
Supriya ma'am.
Can you name any topical AMP that has been marketed and used successfully as an adjunct to NSPT?
Yes, ma'am. Xoma is a commercially available topical antimicrobial peptide, but currently it is not available in India, ma'am. It is available in US and Europe.
Okay, so what are the most abundant human AMP?
Most abundant among these are the natural antimicrobial peptides. Examples are the human beta defensins and the alpha defensins, and the histatins, and the cathelicidin LL37, which is more prevalent and more available in studies conducted by the researchers.
Okay, fine.
So the development and progression of the biofilm, how does the AMPs influence this?
Ma'am, hello?
Can you hear me?
Yes, ma'am. Now I can hear you, ma'am.
Yeah, just throw some light on how does exactly the AMP control the development and progression of the biofilm. That is where it is relevant to us, right?
Yes, ma'am. Actually, these how they develop anti-biofilm activity is that they actually bind to the bacterial lipopolysaccharide membrane, which is generally present in both gram-positive and gram-negative bacteria, where the lipopolysaccharide acts as an attractant for in gram-negative bacteria, and teichoic acid acts as an attractant for gram-positive bacteria. They bind specifically to the bacteria, and lesser chances of developing resistance because of they are selectively bind to only the cells which are damaged or being damaged, and they secrete certain proteins and cause pore formation and destroy the biofilm and cause leakage of the molecules like sodium or potassium, and also causes and disruption of the bacterial DNA and the disruption of their cell membrane. That's how they cause the anti-biofilm activity.
Clinical trials you're aware of where they've been used as mouthwashes? Any study?
Sorry, ma'am.
They've been used as a mouthwash in an article. Can you put some studies regarding this?
Yes, it is available in US, ma'am. It is commercially available in US.
Thank you, doctor. We'll move on to our next presenter.
Hello.
Yes, doctor. Thank you for the session. We'll move on to the next presenter now.
Thank you, ma'am.
Hello.
Good morning, Dr. Aishwarya.
Good morning, ma'am.
Yes, please start.
Today my topic of presentation is on computerized implant dentistry, advances toward automation. Surgical navigation systems are made possible by motion tracking technology referred to as micron tracker camera.
There are two types of optical motion tracking systems. One is active and other is passive. Currently, most commonly utilized is a passive tracking system. And active tracking system arrays emit infrared light that is tracked to stereo cameras. And passive tracking system arrays use reflective spheres to reflect the infrared light emitted from a light source back to the camera. And dynamic navigation systems track the position of the tip of the implant drill, map it to a pre-acquired CBCT scan of the patient's chart to provide the real-time drilling and placement guidance or feedback. When the drill approaches a pre-planned implant location, the system provides the crosshair a bull's eye display to help the surgeon navigate precisely to the planned drill entry point position, adjust the drill orientation to the planned angle, and navigate the osteotomy site along the planned trajectory to the planned depth. Coming to the components of dynamic navigation systems, it includes 5 components: a notebook computer, a patient jaw attachment, a handpiece attachment, optical positioning sensor, and a compact mobile cart. There are 3 fundamental steps which together enable the real-time mapping of the drill tip to the patient's jaw, CBCT image volume, or registration, calibration, and tracking. Calibration occurs approximately 60 to 80 centimeters from the camera. And performing the dynamic navigation surgery involves the navigation system screening allows viewing of a virtual drill with demonstration of the depth, drill orientation, angular deviation of the drill bit, and the implant timing. And the depth is indicated by 3 colors: yellow, green, and red. As implant drilling occurs, the depth indicates changes in color from green to yellow when the drill is 0.5 mm from the targeted depth, and the yellow will turn to red, indicating when to stop the depth of the osteotomy. And during the implant surgery, the implant size, width, type, and location can be adjusted based on the intraoperative factors necessary for a stable and appropriately restorable implant. Coming to the advantages of dynamic navigation system are: it allows the intraoperative changes in the implant position. Bird tracking allows the drill to be continuously visualized on a computer screen in all the 3 dimensions. And it overcomes the limitation of guided implant surgery like secondary thermal injury and displacement or fracture of the guided template. And the limitations of navigation system are: it is sensitive to reflections and interference with line of sight between the sensors and the cameras, and it is more expensive, requires an expensive hardware, and requires the rigorous intraoperative referencing and significant learning curve. With this, I conclude that natural progression from analog 2D imaging and diagnostics to 3D imaging and diagnostic has led to increased understanding of the complex nature of the implant surgery and prosthetics. The increased utilization of these digital 3D diagnostic and therapeutic modalities allows the surgical team to see the limitations of freehand surgery. Computer-assisted surgery allows the implant team to overcome the limitations of human stereo vision and increases the accuracy and precision of the implant placement. And dynamic navigation allows the surgeon to implement the digital implant treatment plan in an efficient fashion. This efficiency and flexibility allows the team to utilize the computer-assisted surgery on every implant in every patient. High-level statistical evidence clearly illustrates the improved accuracy and precision of computer-assisted surgery over the freehand surgery. Thank you.
Ma'am, any questions?
Hello, Aishwarya.
Hi, ma'am.
That was a nice topic.
Thank you.
Can you tell me any other computerized system apart from dynamic navigation system?
Yes, ma'am. Computer guided implant surgery can be used using guided templates to place the implants.
Okay, so what are the advantages of dynamic navigation system over computer guided implant system?
It allows the intraoperative changes in the implant position and can be visual on the computer screen. We can change the implant position according to the targeted position where we before pre-planned implant.
And what are the limitations of dynamic navigation system?
It is sensitive to reflections and interferences with the line of sight and between the sensors and cameras, and it is more expensive compared to the other systems available.
Okay, fine.
Why is three-dimensional image considered as a gold standard, Dr. Aishwarya?
We can visualize the implant osteotomy site in all the 3 dimensions, ma'am. So we can evaluate the anatomical landmarks, radiographic landmarks, and the clinical landmarks which were on the osteotomy site.
Okay. What is beam hardening artifact?
Ma'am?
What is the scatter process that you see here?
While taking the CBCT, we can see the artifacts, ma'am.
Is that a disadvantage, limitation?
Yeah, ma'am.
Fine, doctor. We'll move on to our next presenter. Thank you, Dr. Aishwarya.
Thank you, ma'am.
Hello, ma'am.
Good morning, Dr. Sanket. Please start.
Ma'am, am I audible?
Yes, please. Yes, you are. Please start.
Good morning, ma'am. Good morning, everyone. So my topic for poster presentation is three-dimensional printing, a new dawn in the era of periodontics. So starting with the introduction, it is a term used to describe additive manufacturing approach that builds material layer by layer. It uses information from the CAD software that measures thousands of cross sections to build the exact replica of each product. So as it is a highly efficient and technique sensitive method, it has certain merits and demerits. So one of the prime advantages is that it provides thorough pre-operative planning, and demerit is that it is very costly and time consuming. So some of the technologies are used and taken into consideration, and that the first one is the stereolithography printer. It is one of the first technique to be commercialized. It uses beam of laser light to trace the first slice of the object on the surface of the liquid, causing thin layer to harden. The second one is the direct light processing printer. It is an optical technique which uses light projector operating at UV wavelengths to project voxel data into photopolymer, which causes a resin to cure and solidify. The third one is the fused deposition modeling printer. It is based on the material extrusion in which a semi-liquid material is typically a heated thermoplastic and is deposited by computer-controlled printhead. The fourth one is the inkjet powder printer. It involves selective bonding successive layers of a powdered material together. Glue or binder is applied from an inkjet style printhead to bond successive powder layers together. The most frequently used powder is a gypsum based composite. The next one is the selective laser sintering printer. This uses heat rather than a binder to bond powdered materials together and produces objects by laying down a fine layer of powder and using a laser selecting to fuse some of its particles together. Now, there are several materials used which vary as per object to be printed. Now, some of these are polymers and hydrogels. Now, synthetic polymers are most commonly used for 3D printing. Hydrogels are also used, which are highly biocompatible. Some of the ceramics are also used. Ceramic scaffolds are used, which are composed of calcium and phosphate mineral phases, such as hydroxyapatite and beta tricalcium phosphate. Composite materials are also used, that is printable composites which are usually in form of copolymers. Polymer to polymer mixtures or polymer ceramic mixtures allow for a combination of several advantageous properties. Polycaprolactone is also used, which is hydrolytically biodegradable polyester and is easily manufactured into a variety of shapes and porosities, which with variable mechanical properties, and it is also the material of choice in multiphysics scaffolds. There are also a wide variety of periodontal applications. Now, some of these are 3D printed bioresorbable scaffold for JTR and JBR procedures. Now, by primary scaffold, primary scaffold, it promotes formation of bone, periodontal ligament, cementum, and re-establishment of connection between two surfaces. So, in that, polycaprolactone is widely used as a scaffold material. It is also used in the socket preservation techniques. So, during extraction of tooth, it leads to the loss of height and width of the alveolar ridge. So use of 3D printed scaffold can be used in the socket preservation techniques. It is also used in sinus and bone augmentation techniques by replicating the bone architecture and form macroporous internal structure of the graft with minimal wastage of the material. So it is also used in the implant placement also. So during implant placement, there can be surgical complications. So they can be overcome by the fabrication of surgical guides with the help of 3D printing. So in conclusion, 3D printed models has a promising role as an education tool. So the only limiting factor is it is very costly and time consuming. Hence, it can serve as a effective tool in the future periodontics. Thank you, ma'am.
Thank you, Dr. Sanket. Ma'am, any questions?
Good morning, Dr. Sanket.
Yes, ma'am. Good morning, ma'am.
Okay, so can you tell me what are the advantages of these 3D printed scaffold over the conventional scaffolds which we use in GTR and
Ma'am,
GPR?
ma'am, actually, these scaffolds provide a bony architecture in which we can place implants, and we can also do bone augmentation techniques. We can fabricate that alveolar ridge over there. So, yeah.
Okay, so how does it help in peri-implant maintenance or in peri-implant education? As you told that it can be used as an education tool. So how does it help in maintenance and education?
Ma'am, surgical guides are fabricated during the implant procedure. So, with the help of that, we can also plan for the peri-implant on all those procedures for that.
Okay. Okay, thank you, Dr. Sanket.
Thank you, ma'am.
Thank you, Dr. Sanket. Move on to our next presenter.
Thank you.
Am I audible?
Yes, Dr. Adi, you're audible. Please start.
I'm here to present my review poster on title Lasers, a light of love for periodontal regeneration. So lasers are light amplification by stimulated emission of radiation, and regeneration is defined as the reproduction or reconstruction of a lost or injured part in such a way that the architecture and function of the lost or injured tissues are completely restored. And we are here to discuss briefly about the 4 laser procedures that helps in periodontal regeneration: the low-level laser therapy, the LANAP, LAPIP, and LCBT. So low-level laser therapy works with the principle of photobiomodulation, that is the biostimulation, and it increases the cell proliferation and helps in release of growth factors. And low-level laser therapy stimulates the fibroblasts for faster regeneration of soft tissue, mainly the basic fibroblast growth factor. And coming to LANAP, LANAP is laser-assisted new attachment procedure. So the rationale behind LANAP is a cementum-mediated new attachment to the root surface in the absence of long junctional epithelium. So laser parameters that we use during LANAP was as a free-running pulse NDR laser with a wavelength of 1064 nanometer and pulse duration 100 to 650 microseconds, and with a frequency of 10 to 50 hertz and amplitude 300 to 400 microjoules, and power of 0.3 to 6 watts with a fiber diameter of 0.3 to 0.4 mm. So coming to the uniqueness and advantage of LANAP, it's negligible. There is a negligible intraoperative trauma and post-operative discomfort and minimal gingival resistance compared to conventional flap techniques, and faster wound healing in coronal direction rather than the apical direction by the release of the pluripotent stem cells from the pedial and alveolar bone. And it's being extremely fatal to the pigmented periodontal microbes, and with a minimally invasive flapless pocket therapy. LAPIP is a similar procedure on par with LANAP, which is used on a diseased implant surface. Coming to LANAP has a six-step protocol. The first step is proper anesthesia and bone smoothing for determining osseous morphology, and the second step is laser troughing with first laser application, then removal of the calculus with piezoelectric scaler, and the second laser application with long pulse duration, which gives a closed system of fibrin clot, and compression of the gingival tissues against the root surface, and followed by occlusal adjustment. LCBT is also on par with LANAP, where we use it with RBM lasers, and the main steps that differ are biostimulation during blood coagulation. That's it. And moreover, these procedures have advantage of no cut and no suture and no fear of pain. Thank you.
Ma'am, questions, please. Supriya, ma'am.
So what are the disadvantages of lasers over conventional procedures for periodontal regeneration?
Mainly the cost, treatment cost is a disadvantage. And many more advantages are more than disadvantages compared to conventional techniques.
So you should be knowing about the disadvantages also, no?
I'll let it know.
See, it's lasers. They are used at present. Also, they are used as an adjuncts only, no?
Yes.
So there should be some disadvantages also. Anyway, so do you think that it really results in periodontal regeneration, laser
Yes, ma'am.
therapy?
Yes, ma'am. LANAP, I think LANAP is registered procedure with some commercially available product like Periolase MVP7. They have published on articles also that it helps in periodontal regeneration, both soft tissue and hard tissue bone regeneration.
Do you think that cellular cementum or acellular cementum is formed by LANAP?
It's LANAP produces a new attachment. So basically, there will be cementum formation, and acellular cementum will be formed.
Okay. Okay. Thank you, doctor.
Dr. Adi, can you mention the lasers that are used in periodontal surgeries?
Laser, ma'am. Here, in LANAP, ma'am.
Yes.
A free running pulse NDR, ma'am, with 1064 nanometer wavelength. But commercially available one, registered one is Periolase MVP7.
And what are the disadvantages of lasers? What is the main disadvantage here over the conventional surgery?
And I'll read it.
I think you should know there are limitations of the laser, if you can. Okay. Thank you so much. We'll move on to our next presenter. Poster number 51. Can we have the next presenter, please?
Good morning, ma'am. Am I audible?
Yes, doctor. Dr. Snigdha?
Yes, ma'am.
Yes, please start.
Good morning, respected teachers. Good morning, everyone. Today I shall be presenting on the poster topic as PAOO, that is Periodontally Accelerated Osteogenic Orthodontics, a periodontal engineer's bone activation novel perio-ortho interrelationship, a combination of selective decortication facilitated orthodontic technique. It is first described in 1893 by L.C. Bryan in textbook of Odontia. In 1959, Dr. was the first was the repeat tooth movement by alveolar corticotomy. In 2001, Wilco, that is Thomas Wilco, a periodontist, and William Wilco, a orthodontist, patented this technique, which is also known as Wilcodontics by their name. Technique, I have shown there are 5 pictures. First one is pre-operative pictures. After taking the picture, clavicular incision has given under local anesthesia. Full thickness flap has reflected. Debridement and curettage has done. And in second number picture, alveolar bone activation and selective decortication, which is a surgical technique where the bone is cut and perforated using 1-2 round burr and piezoelectric knife. Vertical groups are placed in interradicular spaces extending from 2 to 3 mm below alveolar crest and up to 2 mm beyond the apices of the root. In picture number 3, activated bone is layered with particular bone grafting material. We can use DFDPA and autogenous bone deproteinized bovine bone, etc. In picture number 4, orthodontic adjustment has done with heavy ortho forces following flap repositioning with interrupted loop suture for 2 weeks. And in picture number 5, I have posed the post-operative picture with required arch expansion. We can see in 60% reduced time compared to the conventional orthodontics. Few advantages are there. That is, first one is rapid tooth movement, lesser relapse than orthodontic treatment, and then minimal requirement of appliances and healthcare. facilitate slow orthodontic expansion and instability after orthodontic treatment. Indications are class 1 malocclusion with moderate to severe crowding, mild 3 class 3 malocclusion, class 2 malocclusion requiring expansion, severe bimaxillary protrusion, molar uprighting, related eruption of impacted. At the end, there are few disadvantages also. We can't use the patient who is having active periodontal disease. And in the end, I will conclude that the present poster manifested the biologic benefit, profound enlargement in the envelope of motion, reducing the need of extraction and eliminating the need of aggressive intervention of surgically assisted rapid maxillary expansion. This technique has maximum advantage compared to the disadvantage and can be a win situation completed with a great result of increased alveolar bone volume, degree of facial remodeling, increased bone support for teeth, thereby augmenting gingival and facial aesthetic. Thank you.
Thank you, Dr. Snigdha. Any questions, ma'am?
Hello, Snigdha.
Yes, ma'am.
Can you describe about the modified periodontally accelerated osteogenic orthodontics?
Yes. Yes, ma'am. We can use laser as modified periodontic osteogenic orthodontic treatment. We can use laser in this treatment also. This is the advanced technique that has shown till
now. Okay, any limitations of POW technique?
Yes, ma'am. Limitations are this is not applicable in class 3 malocclusion, and with this we need some additional surgery required, which can possibly cause pain and swelling, which is unnecessary. And all any other limitations are patients having active periodontal disease. We can't use this technique on them. We should exclude a patient having osteoporosis or any other bone disease.
Okay, thank you, Snigdha.
Dr. Snigdha, what is a regional axillary phenomena seen here? Can you describe that?
Yes, ma'am. This is the bone pattern we are using in this technique, PAOO.
No, it is a state what is seen in this healing phenomena. What is that? What happens in a localized area? That is the one which causes, that is responsible for the rapid tooth movement, right? So what is regional axillary phenomena?
Ma'am, basically regional axillary phenomenon is a tissue reaction to an oxygen stimulus that increases the healing capacities of the affected tissue.
Yes, which tissue are we talking about? What happens there? What is the mechanism of action? And what are the two main features of RAP, regulatory acid process? What is that in the bone?
Basically, it's a pattern which reduces time.
Yeah, but there are two main features of RAP in bone, right? Bone healing. Are you aware of that?
Not yet, ma'am.
Okay. Fine, Dr. Sinha, thank you. So we'll move on to our next presenter.
Thank you so much, ma'am.
Thank you. Poster number 52.
Yes, ma'am. Can I start the presentation?
Good morning, Dr. Kugrino. Please start.
Good morning, ma'am. Today, my poster presentation is on ligaplans, which is tissue engineered ligament in implant dentistry. Over the past few decades, the replacement of missing teeth is done by the dental implants and mostly the osseointegrated implants, and which has got various shortcomings. And the most prominent one is the lack of the periodontal ligament. And to overcome this, implants with the periodontal ligaments can be procured, and this can be possible by the application of tissue engineering concept along with the suitable implant material. Tissue engineering has become an integral part of the periodontal therapy, and its use has opened various gates in the field of dentistry. Tissue engineered periodontal ligament around the dental implant has been introduced in the past few years and is called as ligaplant. And these ligaplants has become a promising option that can provide good biological performance, leading to an increased life of the prosthesis. The rationale behind this ligaplants is that usually the osseointegrated implant leads to the direct contact between the tooth and the bone, which leads to the lack of periodontal ligament, which can lead to severe bone loss than the natural tooth in case of inflammation around the implant. And this introduction of ligaplants facilitated the micro movements in shock absorption, and which also induced the proprioception and the regenerative capacity. And by using tissue engineering technique, both in vitro and in vivo, we can procure these ligaplants. And advantages of this ligaplants is that it can be placed in the bony defects where the osseointegrated implants cannot be placed, and which is identical to the natural insertion of natural tooth roots in the alveolus, and it also induces the bone formation with the intimate tissue communication and reduces the peri-implant bone loss, and they are firmly coordinated with bone with no bone contacts and no interlocking. Precautions that should be taken while using ligaplants is a small mechanical movements with the medium flow is necessary, and there should be optimal space in between the implant and the culture, and adequate sterilization is necessary, and the culturing of the cells should be optimal to prevent the growth of non-periodontal ligament cells. Coming to the disadvantages of ligaplants, we can't predict the factors that may affect the acceptance of implant by the host and also the growth of periodontal ligament. And well, it's a technique sensitive procedure, and the other non-periodontal cells can also grow, and high cost also. And coming to the conclusion, ligaplants give a better long-term stability by stimulating the optimal functioning of natural tooth. And more human studies need to be done to evaluate the successful outcome of the strategy, as ligaplants has various advantages in comparison with the conventional implants. These can emerge as a new revolutionary addition to the implant industry. Thank you, Manu.
Thank you, Dr. Gukina. Supriya ma'am.
Hello, doctor.
Yes, ma'am.
It is a nice topic that you have chosen for your poster presentation. Can you tell me what are the guidelines that should be followed to obtain successful ligaplants?
Firstly, the donor tooth should be there, madam. Extracted tooth before. I mean, when you are planning for a ligaplant, donor tooth should be taken, madam. Before, I mean, before the extraction only, we should plan the ligaplant procedure, madam.
Any other guidelines? Okay. Any human studies that has been done on ligaplants?
The pioneer study itself has a human study, madam, but that is the only study on humans, in which 8 ligaplants were placed, and only 1 is successful, madam.
Okay, only 1 was successful. So what do you think, what could have been the reason for not getting successful?
I mean, in that study, they quoted that 3 ligaplants they couldn't follow, and the others were mobile, madam. I think it's because of, I mean, more of the other cells must have grown, and well, it's a pioneer study, and more studies have to be done.
Okay. So how does culturing of periodontal ligament cells done for ligaplants?
From the extracted tooth, the cells were taken, and they were cultured in culture dishes, madam, and then they are humidified in their humidified.
You should be knowing that in detail, no?
Yes.
That is the main thing that has to be done, and proper precaution should be taken for proper culturing of periodontal ligament cells, right? So you should be knowing that thing. Okay, fine. Thank you.
Dr. Gukina, I have a question for you. What are the risk factors of ligaplants?
I mean, the other periodontal ligament cells, where the periodontal ligament should grow, it may lead to another growth of cells like bone can be grown, bone also can be grown, madam. And so.
What are these mediated because of?
Madam?
What mediates them? You said other cells, other type of tissue can grow, right?
Yes, madam. Signaling molecules like bond morphogenic proteins and all, madam. And also the cells. I mean, in the tissue culture, we have three principal constituents where the cells, stem cells, osteoblasts, fibroblasts, and cementoblasts.
Okay. So this is something that you cannot control, right? The factors affecting the growth of PDL, basically. Right? Like ma'am said, this is a very culture sensitive process. Okay. Fine, Dr. Sita. We'll move on to our next presenter, Bukina. Thank you. Poster 5.3. Next presenter.
Good morning, ma'am. Am I audible?
Yes, Dr. Naren. Good morning. Please start.
This review poster, I'm going to talk about sticky bone, its current concepts, preparation protocols, procedures that it is used, and its properties and its regenerative potentials. Sticky bone can be produced by various methods, like using autologous fibrin glue and IPRF. And the concept of producing sticky bone using IPRF was given by Monroe et al. In the year 2015. In the preparation protocol, 10 ml of autologous blood has to be drawn from the patient without any use of anticoagulants and centrifuge for 3 minutes for 700 RPM. All the clotting factors and the platelets reaches the upper layer under the centrifugation force. These separated plasma and the platelet together situated in the upper layer appears as a light yellow color, right, orange yellow color, and it can be used in an injectable form known as IPRF. This can be taken with a syringe and can be mixed with a desired bone graft of choice. And it takes about 10 to 15 minutes for this IPRF to polymerize with the graft. Polymerization in the sense means it forms a fibrous network with the graft material, and it forms a well-agglutinated stick of bone known as sticky bone, which can be used in regenerative process. In this regenerative procedures, you can see pre-op and post-op, in which the sticky bone is placed, and in the post-op after 9 months, you can see a significant amount of bone growth, and it can be also used in various regenerative procedures in 3-wall defects or 2-wall defects, and class 2 furcation defects, alveolar ridge augmentation procedures, osseous fill defects around implants, and repair of osseous defects around failing implants. Other procedures, it can be used in oral and maxillofacial surgeries. After cyst removal, it can be placed, and for sinus floor augmentation procedures, and even in orthopedic procedures. Its unique properties is the sticky bone has its own body, and it can be molded into a required shape, so it can be adapted into the specific area of the defect. And compared to PRF, sticky bone produced using IPRF releases a growth factor for over 10 to 14 days, and it's an advantage. And the graft has been stabilization of the graft has been improved because of the sticky consistency, and it's a homogeneous mass. To conclude, sticky bone is very easy to make and very effective material for reconstruction of bony defect. It has been hypothesized that utilization of sticky bone leads to a promising result and reossification of this alveolar bone. Thank you.
Thank you, Dr. Narendran. Ma'am, any questions?
Good morning, doctor.
Good morning, ma'am.
So, you told there are other methods apart from IPRF to produce sticky bones. So, what are those other methods?
One more method is autologous fibrin glue, ma'am. Actually, its preparation protocol is different from method. Mostly, it's a centrifugal force of about 2,300 to 3,300 RPM for around 2 minutes. It's a different procedure. It is given by Sean in the year 2010, ma'am. And IPRF, even IPRF has a different protocols. This protocol of 300 RPM for 700 RPM for 3 minutes was given by Myron, and Moron et al. has given a different protocol like that.
Okay, so can you tell me some studies which has shown successful results using sticky bone?
Yes, ma'am. It has been used in various studies, ma'am, like intra-bony defects and furcation defects. But it has to be followed for about 10 months, and many studies have shown a significant amount of bone growth.
Okay. Okay, thank you, doctor.
Thank you, ma'am.
Dr. Narendra, can you tell me what is the advantage of the second generation platelet concentrates?
Second generation platelet concentrate is PRF, ma'am. PRF is basically produced.
Anything else other than PRF? And?
I think the second generation is PRF, ma'am. It forms a scaffold of growth.
I know there is PRF. Anything else other than PRF you know about?
IPRF is third generation, ma'am. So,
what are concentrated growth factors? Can you throw some light on that?
Concentrated growth factors are the after a centrifugation, this platelet has alpha granules, ma'am. It contains a significant amount of growth factors. When we are doing a centrifugation force, under the centrifugation force, these growth factors are released, and it can be used. These growth factors can be used in a concentrated manner. So, that's it.
What is the mechanism of action of this accelerating process when you use a growth factor? You said it accelerates tissue healing process, right?
Yes, ma'am.
What is the mechanism of that?
This growth factor helps in signal transduction and like a cell migration, differentiation, and proliferation. This helps in healing, faster healing.
Okay, fine, doctor. So we'll move on to our next presenter.
Thank you.
Thank you. Poster 54.
Am I audible?
Yes, doctor. Good morning. Yes,
okay, I'll start. A very good morning to esteemed members and everyone present in the group. The topic for the poster is Goffey-Osseous in subantral augmentation, a review. Goffey-Osseous is a French word for bone graft. Maxillary sinus augmentation procedures have played a pivotal role in clinical practice for the management of atrophic posterior maxilla. Typically, periodontal disease and bone resorption after tooth extraction result in loss of alveolar bone height, especially in posterior maxilla. In 1970, Tatum developed lateral sinus lift procedure, and in 1980, Boyne and James first described a procedure to graft the maxillary sinus floor with autogenous marrow and bone for placing an implant. Access to the maxillary sinus was gained through a Caldwell-Luck procedure. It is generally considered a highly predictable surgical technique for posterior maxillary site development and implant reconstruction. The maxillary sinus has a horizontal pyramidal shape consisting of a base, an apex, and 4 sides, and is generally 0.3 to 0.8 millimeter thick. Radiographic assessment of the sinus with CBCT is critical for proper sinus grafting. Sinus augmentation procedures are routinely classified into either lateral wall, also known as direct sinus lift, or crestal approaches, also known as indirect sinus lift. In the poster, the top left picture depicts the lateral wall technique where a number 8 round burr has been used, along with other conventional instruments in order to outline and remove the bony window. This is followed by elevation of the membrane. The top right picture in the poster depicts the same procedure using the piezo-surgical equipment where the membrane has been raised with a piezo surgery EL1. The bottom left picture is the poster that depicts the same. The bottom left picture depicts the antral membrane balloon elevation technique where the antral flow is elevated with the help of inflated balloon. The second means for sinus elevation is crestal approach, where socket former instrument is used to prepare the implant site, leading to a controlled green stick fracture of the sinus flow that moves it in a more apical direction. Summers coined the term osteotome technique, whereby a set of osteotomes with varying diameters is utilized to lift the bony structure of the residual bone. Minimally invasive antral membrane balloon elevation technique, also known as MIAMBE technique, is a form of crestal approach where a deflated balloon is introduced below the sinus flow through the void created in the crestal area. This balloon is then inflated to lift the Schneiderian membrane. Another crestal approach is hydrolift technique, where the sinus lining is elevated through the dental implant osteotomy by water jet and the use of safe drills for avoiding sinus perforations. The insertion of dental implant will result in dented sinus lining which will eventually result in the ossification to form bone. The bottom right picture depicts intra-lift technique, where crestal approach is made with the help of ultrasound-based hydrodynamic pressure lift kit. The kit is also used for lifting sinus membrane through microcavitation. If perforation of sinus membrane is observed during a crestal approach, then a lateral approach is performed and the collagen membrane perforation technique is utilized to repair the tear. All the sinus augmentation procedure gives a better result when implant placed along with xenograft and allograft. Now coming on to the conclusion, while it is difficult to provide clear indications for which crestal or lateral sinus flow elevation procedure should be selected first, according to each clinical situation and the surgeon's experience, priority should be given to surgical interventions that are simpler, less invasive, and carry less risk of complications and patient morbidity. And that concludes my presentation. Thank you.
Thank you, Dr. Zigme. Ma'am?
Hello, doctor. So basically, what is the topic of your presentation? It is bone graft and sinus lift and subantral augmentation.
I've used the word Goffey osseous. It's a tricky word because it's a French term.
You used a French word, no?
Yes, ma'am.
Yeah. So just tell me which is the bone graft material which is considered to be the best for subantral augmentation?
Ma'am, a combination of allograft like DFDB bone and xenograft like beta TCP.
So why not autograft? Why can't we use autograft in subantral bone augmentation?
After going through various articles, the result that was noticed when xenograft and allograft combination, when grafts such as xenograft and allograft were given, the result is similar to what the results we get when we give autograft. That's why the clinician prefer the combination of allograft and xenograft bone graft.
Okay, so you told about different techniques of subantral bone augmentation, right?
Yes, ma'am.
Okay.
Yes,
okay,
ma'am.
But you didn't mention about the bone graft materials, no? Because the topic, what I understood is that it is like a bone graft and subantral bone augmentation, or whether it is the different techniques which you wanted to tell.
Yes, ma'am.
Because your topic is not like what I understood from the
yes, ma'am.
Topic,
the headline is bone graft.
That is a different thing, and what you told is a different thing, right?
Yes, ma'am.
Okay, fine, no problem. It was a good present. It was a nice presentation, but just that.
Thank you, ma'am.
Topic doesn't matches whatever you wanted to tell in your poster, right?
Yes, ma'am.
Dr. Zigme, what I understood is you spoke of the conventional approach and the piezo approach, right?
Ma'am, lateral conventional approach and crestal approach, ma'am.
Crestal. What is the advantage of the crestal approach? Can you tell me that?
Ma'am, it is a more conservative approach. Patient morbidity is not as compromised as is often seen in case of conventional approach. Whereby bone healing is not compromised as we see in case of conventional lateral approach.
Okay, fine. Thank you, doctor. We'll move on to our next presenter.
Thank you, ma'am.
Ma'am, can you hear me?
Yes, ma'am. We can hear you. Please start.
Okay. A pleasant morning to everyone. My poster presentation is a review about a CRISPR gene in advanced periodontics. At this 21st century, it has yielded a great extraordinary technological advancement in the field of genetic engineering. One of that is a CRISPR gene. What is CRISPR gene? It is an acronym of a clustered regularly interspaced short palindromic repeats which is a DNA sequence that is found in the genome of prokaryotic organisms, or it is a programmable protein that can edit, turn on or turn off the specific targeted gene. And this CRISPR is derived from the bacteriophages that had infected the prokaryotes, whereas they work by the utilizing proteins, that is the Cas proteins. There are several types of Cas systems that have been engaged to the CRISPR gene therapy. That is, main one is a CRISPR-Cas9. This CRISPR-Cas9 was first used by the Hong et al. In the year of 2018 in the reduction of pro-tumorigenic behavior in the human oral squamous cell carcinoma. And this CRISPR-Cas9 is a naturally occurring enzyme that is found in the bacteria, and they can provide the first line of defense against the specific competitor pathogens. And this can directly modify the interleukin-8 gene that is potent chemoattractant and of cytokines, and they are the activator of the neutrophils in the inflammatory conditions. The main disadvantage of this CRISPR-Cas is they can alter the complete sequences permanently. So overcome this disadvantage, the several CRISPR systems have been developed. That is the CRISPR-Cas system, Cas3 and CRISPR-Cas13, CRISPR-R and CRISPR-I have been developed. Mainly, the CRISPR-3 is used to be a genetic tool to deliver the antimicrobials via engineered bacteriophages, and they can moderate the microbiome of the chronic periodontitis. And they have administered via the liposomes and through the plasmids. And the mode of administration is with the engineered the Cas systems have been delivered into the diseased sites, and once it is delivered, it allows the stains to become resistant to the known set of bacteriophages. And once it is targeted the mutants, they wipe out the susceptible pathogenic biofilm, and it favors the growth of resistant health promoting biofilms. Mainly in the plaque formation, there is a study by Kong et al. In the year of 2018. He designed a self-targeted CRISPR arrays and cloned it onto the plasmids and transferred the acquired desired mutants, and which can significantly reduce the extracellular polysaccharides, and that reduction of extracellular polysaccharide formation eventually breaks down the biofilm formation. And so it is delivered by the polymeric materials and the cell-penetrating peptides also. And the CRISPR edited mesenchymal stem cells could be the tool in correcting the periodontal defects and the craniofacial defects. And with this, I conclude that the CRISPR gene is known to be a promising tool in the preventive periodontics and to provide a proper therapeutic approaches to the change the nature of biofilm from disease causing to the health promoting one. Thank you.
Thank you, Doctor. Ma'am.
Hello.
Hello.
Am I audible?
Yes, ma'am, you are.
Okay. As you told that CRISPR-Cas9 system, it can cause permanent damage to the genome sequences. Fine.
Yes.
So how much ethical would it be if it causes this permanent damage to the genome system? Is it ethical?
No, ma'am, it is not ethical. So that only they have developed with the Cas13 and the Cas3. So those Cas13 and Cas3 doesn't give a permanent change to the complete sequence. It gives only the changes to the genome alone, the targeted genome alone, ma'am.
Okay. Okay, fine. Thank you.
Thank you, ma'am.
Thank you, Doctor. We'll move on to our next presenter.
Hello, ma'am, am I audible?
Yes, Dr. Abhishek. Good morning. Please start.
Good morning, ma'am. I am Abhishek Hirwani going to present a poster on a topic, a new definition of attached gingiva around teeth and implant in healthy and diseased sites. According to American Academy of Periodontology and Glossary of Periodontal Terms 2012 updated, the attached gingiva can be defined as the part of gingiva that is bound to the tooth and or alveolar bone, extending from the extending from the free gingival groove to the mucogingival junction. Because of the instability of its coronal and the apical limit during disease condition around teeth and implant, it is not always possible to define the attached gingiva correctly in health and disease. There are two problems with current description related to the attached gingiva definition. First is coronal limit. According to Ainimo and Low, 1966, the free gingival groove is seen only in 1/3 time on the external surface of gingiva, and the apical limit, that is mucogingival junction, that is not always bound to the bone. It may also bound to the tooth surface also. So a new two-part definition for attached gingiva has been proposed by Dennis Tarnow, Mark Hockman, Stephen Chu, and Fletcher P. et al. In 2020. They describe a two-part definition, part A, where the biological width is supracrystal, and part B, where the biological width is subcrystal. Part A definition will be applicable for the healthy teeth, healthy tooth, or healthy tissue level implants, and part B will be applicable for the healthy bone level implants and intrabony or infrabony defects associated around the teeth, tissue level implant, and bone level implant. Coming to the next problem associated with current description is the apical limit of attached gingiva, that is mucogingival junction. Hockman et al. In 2014 describes two types of mucogingival junction, that is type 1 and type 2. Type 1 mucogingival junction is apical to the crest of bone level, crestal bone level and bound to the bone surface, and type 2 mucogingival junction is coronal to the crest of the bone and bound to the tooth surface. Coming to the clinical significance of new definition, when part A definition is applicable along with type 1 and type 2 mucogingival junction, then width of attached gingiva can be measured from the base of the sulcus to the mucogingival junction. But part A definition is when the part B definition is applicable along with type 1 mucogingival junction, then a new dimension should be incorporated like crest of alveolar bone while defining the width of attached gingiva, and this dimension should be measured from the crest of alveolar bone to the mucogingival junction. While part B definition along with type 2 mucogingival junction is applicable, then the width of attached gingiva is absent in this condition, and only keratinized mucosa around the tooth or implant surface on the external surface of gingiva will be present. So while defining the attached gingiva, it is important to take care of periodontal health around the tooth and implant, level of biological width, base of the sulcus, free gingival groove, and the mucogingival junction. So we can conclude, while defining the attached gingiva, there is need to modify the current description, and this new definition allows the clinician and the researcher to define correctly the width of attached gingiva in health and disease condition around tooth and implant. Thank you, ma'am.
Thank you, Dr. Abhishek. Supriya, ma'am.
Hello, Dr. Abhishek.
Good morning, ma'am.
Okay, so what is the need of this new definition?
Ma'am, because because the current description defines attached gingiva in health condition only, but we cannot apply the same dimensions or same coronal and apical limit in disease condition around teeth and implant, because the current description of attached gingiva shows the biological width is supracrystal, but in periodontal disease condition, when the biological width is subcrystal, the base of sulcus goes apical to the crest of the alveolar bone. So it is not practically possible. It is not always practically possible to determine the width of attached gingiva from the base of the sulcus to the mucogingival junction. That's why there is need to modify the current description of attached gingiva.
Okay, so which is more relevant, the width of keratinized gingiva or width of attached gingiva? Clinically,
Yes, ma'am. Ma'am, it depends upon the health around teeth and implant. In healthy condition, the width of attached gingiva is more relevant, but in some situations, the keratinized mucosa is more relevant when compared with width of attached gingiva.
So what happens to the attached gingiva in type 2 cases?
Type 2 mucogingival junction?
Yeah, sure. Yes.
Yes, ma'am. Ma'am, in type 2 mucogingival junction, when the biological width is supracrystal, then we can measure the width of attached gingiva from the base of sulcus to mucogingival junction. But in type 2 situation, along with the biological with subcristally, then it is not practically possible to determine the width of attached gingiva. Only keratinized mucosa will present on the external surface of gingiva.
Okay, so there will be no attached gingiva in those.
Yes, ma'am. Yes, ma'am.
So, is there any importance, clinical importance of that thing?
Yes, ma'am. Generally, bone level implants, there are keratinized mucosa present, but there is no width of attached gingiva present around the bone level implant most commonly. Only keratinized mucosa surrounds the implant. Hello, ma'am, am I audible?
Yes, doctor, you are.
Okay. Okay, Dr. Abhishek, thank you.
Yes, ma'am. Welcome, ma'am.
Thank you, Dr. Abhishek. I think ma'am has asked the questions that what I wanted to know. So we'll move on to the next presenter. Can we have a next presenter, please?
Ma'am, I'm audible.
Dr. Christy?
Ma'am, good morning to everyone present here. Today, my poster topic is about the role of teriparatide in periodontal regeneration. It is a review. Introduction. Pericuetics are the use of the pharmacological agent in the management of periodontal disease as an adjuvant with mechanical debridement. This teriparatide is the biosynthetic human parathyroid hormone, which consists of first 34 amino acids of parathyroid hormone, and it is an anabolic agent, host modulating agent in periodontal therapy, anti-protease, anti-inflammatory drugs, bone sparing drugs, and bone forming drugs. This teriparatide is a bone forming drugs. Mechanism of action: this parathyroid hormone acts in the osteoblast cells and inhibit the expression of rankle, and which will promote the osteoblast cells, and it will lay the new bone formation. Teriparatide and the bone remodeling. Osteoclast cells will remove the damaged bone matrix, and this osteoblast cells will refill and lay the new bone formation. Clinical studies, Bossi et al. In 2012 had administered this teriparatide with the adjuvant with periodontal surgery and showed a result in clinical and radiographic outcomes, and that has been sustained for 4 years. Mode of administration is systemic and local drug delivery, and it indication in osseous defect, osteoporosis, osteogenesis imperfecta, osteoarthritis, and fracture repair. And it is contraindicated in anaphylaxis and angioedema, and adverse effect is hypercalcemia, headache, hypertension, angina pectoris, and syncope. Conclusion that the introduction of this anabolic agent has widened the treatment in the management of periodontitis, and using the systemic teriparatide in adjuvant with this periodontal surgery has promoted the osseous regeneration, which gives in long-term results. Thank you.
Thank you, Dr. Christy. Supriya, ma'am.
So there are so many drugs which are being used as a host modulating agent and as an adjunct to non-surgical periodontal therapy. So what is the uniqueness in this drug? Any new thing?
Ma'am, it can be used as a systemic administration in a monthly, and it shows a result only after 1 year. And it is mainly used in osteoporosis cases.
Okay, fine. It is used in osteoporosis cases, but any advantages over other FDA-approved drug in case of periodontitis patients?
Ma'am, an osseous defect, it has shown a result that the main advantage, it is been sustained for next 4 years and shows a long-term results.
Okay, so is it used?
And mainly it is an anabolic agent.
Okay, fine. So
Which
it is
build
a
the bone formation.
bone forming agent. Okay, so is it used systemically or topically?
Ma'am, systemically.
Systemically, no topical application.
No, ma'am, no topical application.
So what is the dosage and what is the duration of
The
using?
dosage is 20 microgram, ma'am.
Systemically 20 microgram.
Monthly once.
Monthly once. Okay. And for how many days or months?
2 years, ma'am.
2 years.
Yes.
So patient has to take that medicine for 2 years every
Yes,
month.
Yes.
So will the patient be compliant?
Yes, ma'am.
So you think that patient will
Because it
take
is
the drug for 2 years, 2 long years?
Once in a month, so that.
Oh, okay, fine. Thank you.
Thank you, ma'am.
Dr. Christy, like you said, this is systemically administered, right?
Yes, systemically.
Yes. What are the disadvantage of that? For 2 years, you said once in a month. Yes. But what are the long-term side effects of this drug?
Long-term side effect, it has been injected in abdominal, so it leads in a backbone pain. Ma'am.
And what else are you aware of? Any other side effect other than this?
Any other side effect is that hypercalcemia can be.
Okay. Any studies you can quote on this drug being used as a modulatory? Any studies you can quote, Dr. Christy?
Studies by Basic et al. Has shown in 2012. In osseous defect, yes, in adjuvant with the periodontal therapy, that is open flap debridement, he has done. In that osseous defect was there. So he has seen that there is clinical and radiographically improved bone regeneration for the last 4 years.
It is a 4-year follow-up study. Dr. Christy, am I audible?
Not.
Fine. Thank you, Dr. Christy. We'll move on to our next presenter.
Thank you.
Thank you. Poster 57, please. Can we have the next presenter, please? Dr. Shalini. It's poster 57. Can we have the presenter, please? Dr. Shalini, you need to unmute yourself. You're muted. You need to unmute. No problem. We'll wait. Can you unmute your audio? We can see you, but we can't hear you. Dr. Shalini, are you able to unmute yourself? Yes, Shalini. Dr. Shalini, we'll move on for the next presenter. You can join in later. So you can sort it out in the meanwhile. Okay. So we'll come back to you later on. We can move on to the poster 58. Can we have the presenter, please?
Ma'am, it's 5/9. Morning, ma'am.
1 second, hold on. Dr. Shreya, right?
Ma'am, Prachi Chandra.
But you've named yourself as Shreya
Yes,
Haider, right?
yes, ma'am.
Sorry?
Yes, ma'am. I've logged in with another laptop, ma'am. That's right.
Okay. It's fine then. Yes, doctor. Please start.
Good morning, one and all. My topic for poster presentation is on precision dentistry, periodontal microsurgery. Microsurgery is an advanced surgical technique by which visual perception is increased using a microscope at magnification exceeding 10 times. Periodontal microsurgery helps in improving the outcome of basic periodontal surgical procedures by enhancing normal vision through magnification and micro precision. Microsurgical triads include illumination, magnification, and combined result of illumination and magnification, and microsurgical instrumentation. In illumination, fiber optic technology is used to improve the methods of focusing light on surgical areas and is a main feature of surgical operating microscope. Magnification, achieved by using the simple loops to prism telescopic loops and the operating microscope, which can lead to enhance and clear a surgical area. Microsurgical instrumentation must be smaller in size and so that more improved, more precision and improved vision can be obtained. Microsurgical instrument should be slightly top heavy, circular in cross section and approximately 18 centimeter in length for proper handling. It should be lightweighted and not be more than 15 to 20 grams. The advantages of periodontal microsurgery is automatic tissue management and primary wound closure. Because of the smaller instruments, we can achieve clear or clean incision, which can lead to proper primary wound primary healing intention, and minimal the surgeries can be minimally invasive, increase the surgical quality. The disadvantages include a long adjustment period for clinical proficiency, initial increased surgical time, high patient costs, and limited surgical access. The application of microsurgery in periodontal fields include root debridement, crown lengthening, implant surgery, sinus lift procedures, mucogingival surgery, periodontal regeneration. In root debridement, we can see more clear and proper tooth anatomy, which can so that we can do the root debridement or root planing in a more concise way. With this, I like to conclude that periodontal microsurgery show improved clinical results as well as increased clinician and patient compliance, and this can also this can maybe the future of the periodontal treatment of treatment standard. Thank you.
Thank you, doctor.
Hello, Prachi.
Morning, ma'am.
So, can you tell me the limitations of performing periodontal surgical procedures under loops?
Yes, ma'am. Loops, while using loops, the operating area becomes smaller, and the visibility, the operating area is comparatively concise, and
any other limitation? So can it cause fatigue to your eye? Can it cause eye strain?
Yes, ma'am. If we use it for a longer time duration, it can be more fatigue and exhausting for the eyes, ma'am.
Okay. Okay, fine. Thank you.
Okay, Dr. Prachi, we'll move on to our next presenter.
Am I audible, ma'am?
Dr. Shrivani?
Yes, ma'am. Good morning, ma'am.
Please start.
A very good morning to all the respected chairpersons. Today I'm going to present my poster on the topic treatment of periodontal sites with horizontal bone defects by enamel matrix proteins, a systematic review. Vertical bone loss has 7.8% of prevalence rate with 96.8% of treatment options. But horizontal bone defects being more prevalent with 92.2% prevalence rate has only 3.2% treatment modalities. Hence, regeneration of horizontal bone defects has always been a dream come true and challenge for the periodontist, as horizontal bone defects have less support and retention due to no bone walls, less graft stabilization, less vascularity to the graft, and decreased residual periodontal ligament cells. Hence, our aim in this review is to review the effectiveness of the enamel matrix derivative in the treatment of the horizontal bone defects. According to the PRISMA statement, the study protocol was designed prior to the start of this review, and based on the PRISMA guidelines, the PICROS criteria, that is the population, intervention, comparison, outcome, and the study design was used for the search strategy. And here we have used the search engines, the Medline by PubMed, Google Scholar, Embase, Cochrane, and Scopus, and the search was done till September 2021. And we use the mesh terms as mentioned here. And in the population trial, we have included the patients from the chronic periodontitis patients with horizontal bone defects. And the intervention included the guided tissue regeneration, the periodontal regeneration, amelogenin, enamel matrix derivative, access flap surgery, and open flap debridement. And the comparison is as here. And in the outcome, the primary outcomes were the tooth survival and the clinical attachment level gain. And the secondary outcomes were the potted probe depth reduction and the change in the gingival recession. Then in the study design, only the randomized clinical trials were included till September 2021 using the mesh terms as mentioned from the search engines written here. And here we have identified 199 articles by electronic search and 2 articles by hand search. And in total, there were 201 articles where in the final in-text analysis, we have excluded 197 and we included only 4 RCTs for this systematic review. And we have found the results that there is very low risk of bias, and the primary outcomes were no tooth loss and trial gain was seen, and the secondary outcomes were the decrease in potted probe depth and increase in bone level was seen. So both the clinical and in vitro studies have demonstrated that EMD can act positively on the inflammatory response of the dentogingival unit, and it will enhance the osteoblast and periodontal ligament cells proliferation and differentiation also. It will modulate the soft tissue healing by the activation of the WNT signaling pathway and the TGF beta expression. And it will also have some antibacterial effect on the dental biofilm activity. And the various evidence-based research according to the literature that shows the horizontal bone regeneration were here the EMD is there, as well as the DPM putty matrix, the PRF, the metronidazole plus collagen sponge, they also show good results. And so due to the time constraints and the space constraints in this poster, we couldn't include the meta-analysis part. So I would like to conclude by saying that the EMD can be a great biomaterial for the regeneration of horizontal bone defects as it shows the increase in bone regeneration, decrease potted probe depth, increase in Karl gain. So with low risk of bias and with low heterogeneity, this is a promising tool for the horizontal bone regeneration. Thank you.
Thank you, Doctor. Ma'am, questions?
Hello, doctor.
Hello, ma'am.
So This systematic review you people have performed.
Yes, ma'am. This is my library dissertation topic, so I have started the systematic review.
Okay. So why do you think that regeneration is extremely difficult in horizontal bone defects?
Ma'am, because there is a less, if we see in the case of intra-bony defects, there is a contained wall where we can place the graft so that the graft will have a proper stabilization, and also the periodontal ligament cells will help in the vascularity. But in case of horizontal bone defects, there is no proper bone support wall, so that the graft stabilization is the main problem, and the transmission of the growth factors, the angiogenesis and neovascularogenesis is less than that of intra-bony defects, as there is no containment.
Okay, so you have found a positive result by
Yes,
using. So you have included only those articles like OFD with EMD.
Yes,
right?
ma'am. Yes, ma'am.
Not any other material along with EMD, no?
No, ma'am. In this systematic review that I'm presenting the poster, we have included the articles where the comparison between open flap debridement or access flap surgery versus EMD along with the access flap surgery or open flap debridement. But the library dissertation that I'm going to do, there I'm going to include all the bone grafts or any biomaterials that have been used till now for the horizontal bone defect regeneration.
Okay. Okay, thank you.
Thank you so much.
Thank you, Dr. Sivani. We'll move on to our next presenter.
Hello, good morning. Is I audible?
Yes, Doctor, you're audible. A very good morning, please.
Good morning, everyone. Topic for my poster presentation is Bone One Session Treatment, a new concept of treating periodontal disease. It's a part of tri-immunophasic periodontal therapy that is developed by William Hoisington for the treatment of periodontal disease without invasive procedures. It works by influencing the disease etiological factors and aiding the healing by 3 immune phases: vigilant readiness, defense phase, and repair and regeneration. So it included this therapy, that is tri-immunophasic periodontal therapy, included 5 steps. That is, first is bacterial DNA testing. So it can identify exactly which bacteria are causing periodontal disease or infection. Such prior detection can prevent unnecessary usage of antibiotics. And the second is bone one session treatment, that is BOST treatment. Is an aerobic treatment that eliminates bacteria that causes periodontal disease in the deepest pocket, and it uses the technique called stretch flap technique. In this, the steps included that the procedure is universal curates inserted into the pocket and the working end facing the tooth. Then slightly pressure is applied on the tissue to begin stretching. And after that, the direction changes to circumferential motion to mobilize the tissue and avoid pulling of the papilla, in essence, creating incisional flap. Hence, the curates are allowed to plaster the surface of the bone and remove any attached granulation tissue. The idea and the goal is to achieve smooth, regular bone surface and fresh bleeding to flush out bacteria and toxin from the porosities. And the third steps in the tri-immunophasic periodontal therapy is the controlling occlusal forces so that equal force are distributed and no direct force to further weaken the periodontium. So the procedures like coronoplasty, enameloplasty, or splinting should be done. Aerobic oral hygiene regimen to reduce biofilm formation and to prevent the epithelial migration from coronal to apical direction. A special aid called perioaid is used. And last, adequate and appropriate nutrition, that is, plays an adjunctive role in it. And the phases of healing after BOST is the defense phase, regeneration phase, and the healing with new attachment. So the defense phase is the phase of self-migration, which acts as a scaffold and helps in primary healing. And the regeneration phase is the phase of maturation of attachment. That is, as the healing progress, the pocket is filled with very dense mineralized connective tissue in 4 to 6 weeks, and healing with new attachment. So the advantage of this bone one session treatment is that it is non-invasive, no incision and suture is required, quick, reliable method, and healing is faster less complications, no bone necrosis, and less sensitivity. With this, I would like to conclude that is the both sets of conditions where the body can get out of the defense phase against bacteria and other microorganisms and into a regeneration phase to heal back to a new attachment. Thank you.
Thank you, Dr. Shahrukh. Supriya ma'am.
So how a bone one session is different from a conventional curettage technique?
In curettage, we remove the granulation tissue and pocket lining without stretching the flap. But in bone one session procedure, the flap has been stretched slowly to get rid of granulation tissue to provide the stimulation of cells with for the attachment.
Okay. So is it a surgical technique or it comes under non-surgical technique?
Ma'am, no, it comes under non-surgical technique.
Why not in surgical technique?
Because we are not giving any incision, or it only reflects the flap. It's like an incisional flap.
No.
Yeah, Yelma.
Okay, fine.
Dr. Shahrukh, what are the steps involved in bone one session treatment for periodontal procedures?
Ma'am, the procedures.
Yes, what are the steps? I think there are 4 steps that is mentioned.
Yeah, ma'am. The first procedure is
5. Yeah, 5.
Hi, ma'am. The 5 step is of ma'am tri-immunophasic periodontal therapy. Ma'am, that is TIP, in which the bacterial DNA testing and bone one session, control occlusal forces, aerobic oral hygiene regimen, and adequate and appropriate nutrition. And the ma'am, bone one session procedures involve only 3 steps.
And why is this DNA test necessary? You do bacterial DNA testing, right? That's the first step.
So, ma'am, to identify exactly which bacteria is causing the periodontal infection, so we can give ma'am selective antibiotic, so prevent unnecessary usage of the antibiotics to create the resistant strain of any bacteria.
Okay. Right. Thank you, Dr. Shahrukh. We'll move on to the next presenter.
Thank you, ma'am.
We have poster 63. Can we have the next presenter, please?
Good morning, ma'am.
Good morning, Dr. Arun. Good morning. Please start.
My topic of presentation is injectable biomaterials for dental tissue regeneration. Biomaterials play an important role in the dental tissue engineering to interface with surgical procedure and cell biology, which include injectable biomaterials that can serve as stem cell carrier and in situ gelling hydrogels. This modern design provides biodegradability, biocompatibility, and improve biological responses. Hydrogel based on different properties, they are categorized under responsive categories: biochemical responsive, antigen responsive, enzymatic responsive, and ligand responsive, physical responsive, temperature, pressure, light, electric field, magnetic field, physical properties, smart hydrogels, conventional hydrogels, copolymeric hydrogels. According to preparation, copolymeric hydrogels, homopolymeric hydrogels, and interpenetrating network, ionic changes, cationic hydrogels, anionic hydrogels, non-ionic hydrogels, degradability, biodegradable, non-biodegradable, and cross-link, physically cross-link, chemically cross-link, and responses, pH responsive, glucose responsive, and oxidant responsive. So, these hydrogels are categorized by bioactive scaffolds hydrogels for dental tissue regeneration. There are various hydrogels are present, like fibrin, which increase fibrin growth factors, vascular endothelial growth factors, platelet derived growth factors, increase regeneration in wound healing, cytosan, osteoconductive, antibacterial, ability to blend with other materials, alginate, delivers growth factors, increase dentin matrix secretion, dental pulp differentiation, DNA protamine, repair defective tissue, GTR, GBR, delays growth rates of SRS and P gingivalis, chitosan, hyaluronic, periodontal tissue regeneration, regulates inflammation, responses cell angiogenesis and migration, non-toxic degradation. Endogame, infrabony periodontal defects, new attachment, proliferation, differentiation of collagen in pegylated gel, enhances wound healing, hemostasis and degrades easily, calcium phosphate semen, regeneration, mobility, osteoconductivity, and injectability. On this image, last one showing the dental tissue regeneration using polycarbonate, electrospun nanofibrils, scaffold biomaterials, new technique, which is injected with high voltage and towards the collector site and with opposite charges, and it will convert it into the electrospun nano fibrous structures, and which will further placed into the applicable site which will place in the applicable site like pulp dentin complexes and periodontal ligament, alveolar bone, and oral mucosa, and for the regeneration and repair of the tissues. Thank you.
Thank you, Dr. Arun. Supriya ma'am.
Hello, Dr. Arun. Dr. Arun?
Yes, ma'am.
Okay, so you told about hydrogels, right?
Yes, ma'am.
So what are these hydrogels?
These hydrogels are three-dimensional polymers, which hydrogels means which absorbs the water. So it comes as hydrogel, and it's usually hydrophobic in nature, and it is used in the dentistry and other field as well, and it absorb. We can use it. It is available in synthetic form and in natural form too. So we can mix with the. It is like a carrier for the drug. So in periodontal tissue regeneration, we can place these hydrogels for the regeneration repair process.
Okay, so basically in your poster, you are talking about the various types of carriers which can be used to deliver the regenerative materials, right?
Yes, ma'am.
So you're talking about the carriers, right?
Yes, ma'am.
Okay. Yes. Okay. So how does Emdogain acts as a carrier for different types of materials?
Emdogain is derived from the unerupted tooth bud. Usually 90% of amylogene is used in the field of dentistry for the in acellular cementum for regeneration of the acellular cementum, and
okay, thank you, Dr. Arun.
Thank you.
Dr. Arun, I just have one question for you. We know about the classical tissue engineering approach, right? In periodontal regeneration, what is cell sheet technology? That is a non-invasive method, right?
Yes, ma'am.
There is in periodontal regeneration in tissue engineering approach, there is something called as cell sheet technology. It's a non-invasive method.
Yes, ma'am.
What is used there? What material is used there?
Ma'am.
It's natural synthetic. What is used?
Ma'am, engineering, several success primary clinical trials of regenerative medicine using biodegradable scaffolds.
Yeah, but what is the polymeric material that is used here? Can you name that?
Yes, ma'am. The polymeric material, which is poly N iso polycarbamide.
Amide, yes. Thank you, Dr. Arun.
Thank you.
So we'll move on to our next presenter.
Am I audible, ma'am?
Yes,
Hello?
Dr. Ganati. Yes, you are audible. Please start.
Okay. Good morning, everyone. Today I'm going to present my poster on the topic endothelin-1, a futuristic biomarker for periodontal disease. Endothelin-1 is a cytokine which is first identified Yangisawa in the year 1988, and it is of three subtypes: endothelin-1, 2, and 3. And endothelin-1 is commonly seen in human, and endothelin-2 and 3 are seen in animal studies alone. It plays an important role in development of various systemic and periodontal disease. And it is made up of 21 amino acid peptides and act as a potent, powerful vasoactive agent which act as both vasoconstrictor and vasodilators. But it is predominantly a vasoconstrictor agent, and it is secreted by endothelial cells, epithelial cells, mast cells, and fibroblasts. In case of systemic disease, endothelin-1 is elevated in case of cardiovascular disease, bone disease, hypertension, liver disease, and respiratory disease. In periodontal disease, it is only elevated in case of chronic periodontitis condition and drug-induced interval overgrowth. Coming to the correlation between endothelin-1 level and periodontal disease, chronic periodontitis, which is defined as host-mediated inflammatory disease, which is provoked by pathogenic bacteria and characterized by elevated level of pro-inflammatory cytokines and various inflammatory mediators. And it depends on three main criteria, which is P. gingivalis, nitrous oxide, and angiopoietin. And the influence of endothelin-1 over periodontal disease is coming to P. gingivalis. It is a gram-negative anaerobic bacteria, and according to the study conducted by Avona et al., they have been found that it has a novel endopepsidase gene, which is also known as PG-PEPO, which is similar in structure and function to ECE1, that is endothelin converting enzyme 1, which helps in cleaving the endopepsidase into big ET, that is big endothelian cells. These endothelian cells are responsible cytokines like angiopoietin and nitrous oxide, which has inhibitory or anti-inflammatory action over endothelin-1, and nitrous oxide, which is seen in chronic but due to repetitive or relapsing inflammation, it could stimulate the endothelial cells to express and stimulate more amount of endothelin-1, causing vessel wall constriction and thereby damaging the vascular vessel wall and increases the endothelin-1. And in case of drug-induced gingival enlargement, phenytoin and nifedipine are commonly causing the drug-induced gingival enlargement, which inhibits the accumulation of calcium in renin in extrajugular epithelium, thereby increasing the amount of angiopoietin-1, that is a hypertrophic agent, which thereby increases the endothelin-1 level in periodontal condition. And in conclusion, according to various studies conducted in relation to periodontal and endothelin-1 levels, it has been found that endothelin-1 has been a potential role in pathogenesis of periodontal disease, but further studies are required to establish
Dr. Vanity?
Yes, ma'am.
Yes, please continue. I think there was an interruption in between. Please continue.
Should I start again, ma'am?
No, please continue from where you left.
Am I finished, ma'am?
You finished? Okay.
Yes.
Supriya, ma'am? Because there was
Should
no audio in between.
Okay, ma'am. Should I present again, ma'am?
No, doctor, I think we got what you wanted to speak about. Supriya, ma'am, any questions?
Yes. Okay, Dr. Vanati, how does endothelin-1 is a futuristic biomarker?
Studies conducted by Khalid Walid and Avano has been studied according to the endothelium level and chronic periodontitis patient, ma'am. And they have been found that endothelium 1 level has been increased in case of chronic periodontitis and gingival overgrowth condition. They have taken the endothelium 1 level pre and post operative to any surgical periodontal therapy, ma'am. And after surgical periodontal therapy or non-surgical periodontal therapy, the endothelium 1 level has been reduced. So it can be considered.
Okay, you told that it is a potential biomarker in cases of gingival overgrowth.
Yes, ma'am.
So what type of gingival overgrowth?
Ma'am, drug-induced gingival overgrowth, ma'am.
Drug-induced.
Drug-induced.
So in which drug-induced?
Ma'am, their studies have been shown phenytoin, nifedipine, and amlodipines are the main drug causing the drug-induced gingival enlargement, ma'am, in endothelium 1 levels.
Okay. Okay, thank you.
Thank you.
Thank you, Dr. Vanity. We'll move on to our next presenter.
Thank you, ma'am.
Can we have the poster 6.5, please?
Ma'am, am I audible?
Dr. Aishwarya, good morning. Yes, you are audible.
Good morning. Okay, ma'am. Tired of not getting the best healing after a flap surgery? It is time to switch to TIP. Good morning, everyone. I shall be presenting a review poster on tri-immunophasic periodontal therapy, a step towards non-invasive era. The prime concern of any periodontal treatment is to control the microorganisms and resolution of soft tissue inflammation and restoration of lost alveolar support. William Hossington developed TIP, which is a non-invasive microscopic periodontal therapy which allows practitioners to go up to the crest of the alveolar bone and destroy anaerobic bacteria. Philosophy: the human body has the capacity of healing and repair by itself after any injury. TIP acts by influencing the disease etiological factors and aiding healing by 3 immune phases. These phases are vigilant readiness, defense phase, and repair and regeneration. TIP sets up all the conditions where the body can get out of the defensive phase against bacteria and other microorganisms and enter into a regeneration phase to heal back a new attachment. TIP periodontal therapy methods are bone one session treatment, controlling occlusal forces, new oral hygiene routine, lifestyle modification, and enhancing nutrition and exercise. BOST is an aerobic treatment which uses stretch flap technique that allows access to the deepest areas of the roots and the surface of bone without giving incision. The goal is to achieve smooth regular bone surface and fresh bleeding to flush out bacteria and toxins from the porosities. After BOST, the clot that is firmly attached to the clean bone, it serves as a scaffold. Pockets gradually fill in from the bottom. Second is controlling the occlusal forces. With weakened periodontium, normal occlusal forces become traumatic, and these forces need to be balanced. Methods like coronoplasty and splinting are used for this, and this prevents tooth mobility and further tissue damage. There are new oral hygiene modalities present, such as PerioAid, which cleans the area where brush and floss cannot reach. Lifestyle modification, nutrition, and exercise are also a part of TIP. Now, coming to the benefits of the aerobic treatment, it is a non-invasive method. It is a quick, reliable method. There are no incisions or sutures. It has faster healing, no bone necrosis, lesser complications. It is comfortable to the patient, more aesthetic, and less sensitivity is experienced. With all the advantages, we can safely say that TIP has led to the rise of a new variation in treating periodontal diseases. Thank you, ma'am.
Supriya ma'am, question?
Hello, Dr. Aishwarya.
Good morning, ma'am.
So any studies which you can quote regarding it?
Yes, ma'am. There are studies conducted. There is a study by Dr. Parekh et al., P.Y. Kumar, and S.K.S. Bawa. They have done a review article, and there is a doctor by the name of Dr. Greb Nava. He has practically performed TIP in his patients and seen that it is more aesthetic and it is a non-invasive procedure.
So are you performing this technique in your clinics?
No, ma'am, not right now. We are first year PG, so this has not been performed in our college yet.
Okay. Okay, thank you.
Yes.
Dr. Aishwarya, you're not performing as of now, but would you advocate this procedure?
Yes, ma'am. I would, ma'am. Because it's more aesthetic. There is no incision. It is more comfortable. So I would definitely give it a try.
So patient acceptance is better.
Yes, ma'am.
Thank you, Dr. Aishwarya. We'll move on to the next presenter.
Thank you, ma'am.
Can we have the next presenter, please?
Yes, ma'am.
You have to put your audio on.
Ma'am, can you hear me?
Yes.
Good morning, respected staff. My topic for today is soft tissue augmentation and root coverage procedure using bioengineered living cellular therapy. The cultivation of human living cell into scaffold matrix. Ma'am, can you hear me? Hello?
Yes, Aishwarya, we can.
Yes, sorry, ma'am. The cultivation of human living cells into scaffolding matrix has progressively gained popularity in the field of periodontal wound healing and regeneration. Living cellular construct based on fibroblast, keratinocytes alone or in combination have been developed and used as an alternative to autogenous soft tissue graft in keratinized tissue augmentation and in root coverage procedure. The rationale of using the living cellular based technology is the ability to communicate with the host by modulating the cytokine expression. It acts as a local wound healing agent and not as a graft, guiding the patient's own cell to develop a new tissue which matches the surrounding gingiva. As you can see in figure 1, that is soft tissue augmentation using evopum. Evopum is a ex vivo produced oral mucosal equivalent which is obtained from an autogenous keratinocyte by a punch biopsy. As we can see in figure 1a, it is immersed into a cell culture media with a necessary signaling molecules, and then it is cultivated onto a cellular dermal matrix which serves as a scaffold for a full thickness tissue engineered construct. Now, the advantage of this evopum is that it accelerates the differentiation and proliferation by proliferating cell nuclear antigen and Ki67 biomarkers, and differentiation by filigrin and cytokines 10 and 13. So now these markers are considered as for early stage of keratinization and for keratinization and proliferation. Also on like in figure 1b, you can see there this figure is of day 4, where a mono layer of keratinocytes can be seen on the acellular dermal matrix. As the day progresses, like figure D and figure E, there you can see a increased cell stratification which can be seen. Now a clinical scenario where they have in figure 2, that is soft tissue augmentation using a evopum. In figure 2a, we can see a inadequate limited band of keratinized tissue in the anterior mandibular area. Then figure B, where a punch biopsy was taken and cultivated immediately before grafting, and it was grafted to the periosteum using an interrupted suture. And when figure 2D, you can see an outcome after 6 months. Similarly, we have similarly tissue engineered cell construct using human fibroblast derived dermal matrix for increasing the keratinized tissue width. Now this human fibroblast derived dermal matrix, it is like it is a three-dimensional cultivation of a neonatal human fibroblast on a bioresorbable polylactin membrane. So this scaffold, it degrades by hydrolysis, leaving only the extracellular content and the fibroblast, which secretes growth factors and growth factors such as fibroblast growth factor and vascular endothelium growth factor and proteins such as glycosaminoglycans, fibronectin. Now this process results in a formation of a living metabolite active dermal structure, which results in colonization of the wound by the adjacent cells, revascularization, and angiogenesis. So all this together leads to an increased width of keratinized tissue. So to conclude, that the soft tissue augmentation and root coverage procedure using a bioengineered living cellular therapy improves the clinical, aesthetic, and patient related outcomes. Thank you, ma'am.
Thank you, Dr. Aishwarya.
So which is considered as the gold standard for root coverage procedures?
Ma'am, we can use a FGG, but there was a clinical study by McCurran et al., where he compared FGG with respect to tissue engineered cell construct. So, the clinical results were similar, but the biopsy, which was taken after 6 months, showed that the tissue engineered cell construct, the cells were better organized as compared to FGG. And aesthetically also, the FGG will retain the characteristics of the palatine tissue. So when we compared it with the tissue engineered cell, the color, the texture is with the comparing adjacent tissue is better.
Is it FGG or is it subepithelial connective tissue?
Ma'am, it is FGG, which the study where they have taken is FGG, and the tissue engineered cell construct.
Okay, thank you.
Thank you, ma'am.
Just talk a little bit about, you spoke about human-derived fibroblast dermal matrix. What is the advantage of this?
Ma'am, the advantage of this is that now the scaffold, like it is a three-dimensional human derived fibroblast. So when it is applied, the scaffold, it degrades by hydrolysis, leaving only the extracellular content and the fibroblast. Now, this will secrete growth factors such as fibroblast growth factor, vascular endothelium growth factor, and proteins such as fibronectin and glycosaminoglycans. Now, this process results in a living metabolite active dermal structure. Now, this structure, it acts as what it does is that it colonizes the wound by the adjacent cells. It helps in angiogenesis and reepithelialization.
Is this has an advantage over FGG and subepithelial connective tissue graft?
Sorry, ma'am.
Does this have an advantage over FGG or a subepithelial connective tissue graft?
Yes, ma'am. It has an advantage of that the healing which is seen with before the very first study where they have used this was in a nephrotic diabetic foot. They have used this, and it was compared with respect to the skin graft which are used in the diabetic foot. So the healing was very faster, which was seen with respect to the human derived human fibroblast dermal substitute.
Fine, Dr. Aishwarya. We will move on to our next presenter.
Good morning, ma'am. Am I audible, ma'am?
Dr. Harini?
Yes, ma'am. Am I audible, ma'am?
Please start, yes. Please start.
Good morning, everyone. Today, I'm going to give my paper presentation is on emerging trends and concepts in periodontics. Coming to the etiopathogenesis part, a new concept which was evolved is the microbial dysbiosis and the role of the pathobionts. Pathobionts are nothing but the normal commensals in the oral cavity, but in conditions like immunodeficiency conditions, these pathobionts can transform themselves into the pathogenic microbial flora. So this imbalance between the pathogenic and the non-pathogenic organisms is called as a microbial dysbiosis, which is also called as a microbial shift. And coming to the diagnostic part, as we know, saliva and gingival clavicular fluid are a basic reliable medium for the presence of markers which are responsible for the periodontal disease. So keeping this in mind, some rapid chairside diagnostic test kits have been developed, which includes this point of care diagnostics. These include some electronic test chips, import, which is integrated microfluidic platform for oral diagnosis and prognostic. These are the biomarker test kits which helps in the detection of matrix metalloproteinases enzymes like mainly elastases. And Omnigene is it consists of some species-specific DNA probes which helps in identification of some microorganisms like Porphyromonas gingivalis, Pravitella intermedia, bacteroids, Fusobacterium, etc. And Perio 2000. This is a device which helps in the detection of the volatile sulfur compounds in the subgingival area. This device, when the tip is inserted into the subgingival area, this device can show the amount of the volatile sulfur compounds onto the screen. Coming to the treatment therapeutics part, periostitics is another emerging another emerging concept in the management of the periodontal diseases. This parasitics involves the usage of some pharmacological agents like host modulating agents, which consists some sub-antimicrobial dose doxycyclines, chemically modified tetracyclines, some anti-cytokine drugs, bisphosphonates, usage of statins and vitamin D. Main advantage of these drugs is we can prevent the development of resistance of microorganisms to the regular antibiotics. And periowave, it is a non-surgical photodisinfection therapy which mainly destroys the gram-negative microorganisms. Unlike regular thermal diode laser, which is used in photodisinfection therapy, this periowave uses the non-thermal cold diode laser, so there will be less chances for the prevention of damage to the soft tissues, adjacent soft tissues. So next one is the LICA plants. Though traditional osseointegrated implants are agreed to be the most accepted implants, they do cause some problems in future like peri-implantitis and causation of alveolar bone loss. So in order to prevent this, LICA plants have been developed recently. It is nothing but combining the periodontal ligament cells to the titanium biomaterials. As periodontal ligament cells have a capacity for regeneration, so there will be less chances for the occurrence of the peri-implantitis in the future. Next is the nanorobotics. With the help of the nanotechnology, recently nanorobotics have been introduced in the dentistry to perform some basic surgical procedures like induction of local anesthesia and treatment of the dentinal hypersensitivity. And recently, these nanorobotics have also been incorporated into the mouthwashes, which contain these nanorobots contain selenium microparticles. These selenium microparticles, they can directly attack the volatile sulfur compounds and can reduce the halitosis. Next one is the 3D printing. 3D printing in periodontology have been used for the production of a biomembrane, bioresorbable membrane scaffolds for periodontal repair and regeneration. They are also being useful for the ridge preservation procedures and region sinus augmentation and guided implant placement surgeries. Main advantage of this 3D printing technology is this 3D architecture. It closely resembles the extracellular matrix of the periodontia. So there will be better results in the outcome of the treatment plan. And last but not the least is the perioprotect. After thorough scaling and root planing also, there are high chances for the recurrence of the microbial flora in the subgingival areas. So in order to prevent this, a custom-made trays have been fabricated for the patients, and the patient is advised to use this periogel, which contains this 1.7% of which contains 1.7% of the hydrogen peroxide. With the help of this trace, the hydrogen peroxide can help in the deeper penetration into the subgingival areas, and it can disrupt the reactive oxygen species and helps in the prevention of the recurrence of this microbial flora in the subgingival areas. Thank you, ma'am.
Thank you, Dr. Harini. Supriya, ma'am.
Do you know about AMMP8 as a point of care diagnostic in periodontal therapy?
EMMP, ma'am.
AMMP8 point of care diagnostic.
Yes, ma'am. It is a device which helps in detections of the matrix metalloproteinase 8, ma'am.
Any study you know? Recent study?
Recent studies. No, ma'am. I have no idea.
Okay, fine. Thank you. It was a nice presentation.
Thank you, ma'am.
Thank you, Dr. Harini. We will move on to our next presenter. We have two more posters presenting, pending right now. Can we have Dr. Shalini, poster 5.8?
Yes, ma'am. Am I audible now?
Yes, doctor. You are audible and visible both. Please start.
Thank you, ma'am. Sorry for the delay.
No
Due
problem.
to the hierarchical structure of the periodontium, successful regeneration remains a major foreseeable challenge till date. One of the major tenets of tissue engineering is the biologics, including cells, proteins, that is delivered via a scaffold, which provides a suitable microenvironment for recreated cells and enable the controlled release of growth factors. However, the precise delivery of growth factors was difficult due to their short lives, which paved the way to cell-based and gene-based therapy. Directly placing the harvested stem cells into the defect reduces the lag phase for progenitor cells recruitment. Nevertheless, several obvious disadvantages like need to harvest the stem cells, weak mechanical stability, and unpredictable outcome led the researchers to develop new therapeutic modalities capable of temporal spatial recruitment of cells such as multiphasic scaffold, 3D printings, bioinspired gels, and hydrogels. Now, multiphasic scaffolds are particularly suited for tissue engineering of complex structures such as periodontium, as they allow spatially compartmentalized bone, periodontal ligament, and cementum formation. Thus, it helps to recapitulate the native tissue architecture. Another interesting ongoing advancement includes computer-aided biomaterial 3D printing. 3D printing is the process in which multiple layers of material are added one by one under computer control to create three-dimensional objects. Scaffold modeling using CBCT has allowed to extract the specific dimension and topography of the defect and to design a customized polyprolactone scaffold. Many key advancements have occurred over the last 10 to 20 years in the field of periodontal tissue engineering. The 21st century appears to represent a time in history when there is convergence between human genetics and clinical dentistry, molecular biology, bioengineering, and bioinformatics. At this convergence is the opportunity for tissue engineering, a filtered bio-inspired byproduct. The holy trail of periodontal therapy is the regeneration of attachment apparatus. However, our perspective on the current evidence is that the regenerative periodontal therapies to date can only restore a fraction of the original tissue volume. Thus, complete periodontal regeneration may still be regarded as an illusion. What is striking to realize is that how little biology is considered. Thus, the answer to the question, does periodontal tissue engineering, tissue regeneration really works, is hidden in the biologics. Henceforth, biological remedy to biological problem is emerging a new paradigm in dentistry. Thank you.
Thank you, Dr. Shalini. Supriya ma'am.
Yes, ma'am.
Dr. Shalini, nice presentation.
Thank you, ma'am.
No questions from my side.
Okay, ma'am.
Can we have the poster 6-9?
Ma'am, we haven't any 69 number ready for this session.
Dr. Peham and Dr. Apurva Salve, you will be presenting your posters in the next session. Dr. Sheikh and Dr. Apurva.
Yes, ma'am.
Okay, I'll be concluding the session. You'll be presenting it in the next session after I finish this.
Okay.
Okay. I take this opportunity on behalf of the organizing and the scientific committee of the 45th ISP National Conference to thank each and everybody, and my special warm extended gratitude to Dr. Supriya Mishra, who has taken a time out and has agreed to judge the session. Thank you, Supriya ma'am. It was a pleasure having you. And I thank all the participants. Thank you so much. Now it's just a request to fill in the evaluation sheet as soon as we conclude this session.
Okay, thank you. Thank you so much. Thank you all.
Thank you, ma'am.
Okay, good morning, everyone, and welcome to the 45th ISP National Conference Virtual 2021 Pune. I, Dr. Magesh Kumar, on behalf of the Organizing and Scientific Committee, welcome all the participants for the review poster today. It's my privilege to invite and introduce the judges for today's morning session, Dr. Lakshmi Tejaswin and Dr. Bhageshri Vanaki. A brief intro about the judges. Dr. Lakshmi Tejaswin graduated from CKS Teja Institute of Dental Sciences and postgraduated from Sibar Institute of Dental Sciences, Guntur. He has a fellowship in implantology from Nobel Biocare. He has published several papers in national and international journals. Currently, Dr. Tejaswin is working as Associate Professor at Sibar Institute of Dental Sciences, Guntur. Next judge for today's morning session is Dr. Bhageshri Vanaki. Dr. Bhageshri Vanaki completed her BDS and MDS from PM Nadegoda Memorial Dental College, Bagalkot. She is currently pursuing her PhD from SDM College of Dental Sciences, Dharwad. She has presented papers and posters in national level conferences and also has several papers in national and international journals to her credit. Currently, she is working as Associate Professor at PM Nadegoda Dental College, Bagalkot. I wish all the participants good luck, and I would like to instruct the candidates or the participants to please maintain the time limit of 3 minutes. Okay, right? So can we have the first participant for today's morning session? That is poster number 114. Are you there? Presenter for poster 114. Presenter for poster 114, are you there?
Yes, sir.
Yeah, please go ahead.
Warm greetings. My topic for today is placenta-derived membrane, a boon in periodontal regeneration. So the goal of periodontal regeneration using regenerative technique is to recreate the supporting tissues. With supporting tissues that is destructed due to the periodontal inflammatory disease. So bone grafts along with membrane increases the predictability of periodontal regeneration. Amnion and chorion membrane is one such membrane. So the amnion membrane is basically the inner membrane that surrounds the embryo and is filled with amniotic fluid and holds the embryo in suspension and includes the ectoderm. Whereas chorion is it surrounds the embryo and the amnion and acts as a protective barrier during embryo development and includes the trophoblast and the mesoderm. So the amnion and chorion membrane, they are separated by a spongy intermediate layer, and the amnion membrane, it consists of the following layers, that is the basement membrane, compact layer and fibroblast layer, and the chorion, it consists of reticular layer, basement membrane and trophoblast layer. The amnion and chorion membrane, they consist of collagens mainly type 1, 3, 4, 5 and 6, and proteins like fibronectin, laminin, nitrogen, proteoglycans. They have the amnion and chorion membrane. They are basically considered as surgical based, so they are available in large quantity. They are low cost and ethical issue does not raise. They help in reepithelialization and wound healing. Also, they are antimicrobial, antifibrotic, and anti-inflammatory in nature, and they have low immunogenicity properties. The amnion and chorion membrane, they show in clinical applications, the amnion and chorion membrane, they have shown better results for the treatment of furcation involvement and also in the treatment of periodontal pockets as compared to conventional periodontal surgery. Also, they have shown effective, they are effective in gingival recession in terms of root coverage, increased gingival thickness, and increased width of attached gingiva. They're available in various forms, mainly fresh, cryopreserved, lymphocytes, and decellularized. Also, there are certain limitations, like they are fragile to handle. There is also always a risk of infection transmission, and handling these membranes can be technique sensitive. So, to conclude, the diverse properties of amnion chorion membrane make them a unique biomaterial for repair and regeneration of periodontal repair and regeneration. Thank you.
Nice presentation, Doctor. What is the added advantage of amnion and chorion membrane when compared to any PRF membrane? Because those are the PRF membrane is the second generation PRF, which can be most commonly used. What's any added advantage of these amnion and chorion membranes? Did you follow my question? Dr. Aishwarya, did you follow my question?
Dr. Aishwarya?
I think she's gone offline. She's lost the connectivity, I suppose.
Okay.
We'll wait for 1 minute till the time concludes, sir.
Okay, fine. Thank you for that introduction, sir. It was a nice introduction. Thank you very much for introducing us.
Thank you, Magesh Kumar, sir.
Okay, I think so. I don't think so. She's getting any connection. So can we move on to the next presenter?
Yes, sir.
Poster 115.
Okay, sir. Okay.
Yes, am I audible?
Yeah.
Good morning, everyone. I'll be presenting on 3D scaffold, transforming the old in periodontal regeneration. So periodontitis, as we all know, is a multifactorial inflammatory disease of the periodontium, affecting about 20 to 50% of the world's population in less severe form and about 10% of the world's population in more severe form. Due to the complexity of the periodontal tissue, that is comprising of the hard tissue, that is the alveolar bone, and the soft tissue, the periodontal ligament, functional regeneration of periodontium still persists as a challenge. Here, we can see the triad of regeneration, which comprises of cells, growth factors, and scaffold. To overcome these challenges, a recent advancement was made towards 3D scaffolds. 3D scaffolds are basically structures which provide physical support during tissue regeneration, and they can be broadly classified as fibers, films, hydrogel, and 3D printed scaffolds. Various biomaterials have been tried and tested in manufacturing of these scaffolds. These include both the natural materials as well as the synthetic polymers. The natural materials includes hyaluronic acid, collagen, fibrin, gelatin, and chitosan, while the synthetic polymers includes PGA, PLA, PLGA, and PCL. Further advancement was made into composite scaffolds, which includes liposomes and polymeric nanoparticles. So moving on to the evidence-based animal study, here in the histological picture below, we can appreciate the dense connective tissue in the treatment of intrabony defects in dogs. And in the image C, we can appreciate the perpendicular arrangement of PDL fibers in the areas of new bone and cementum. So, hence giving it the histological evidence of true regeneration. Hence, to conclude, 3D scaffolds are transforming the field of regenerative periodontics, and they are providing a promising future approach, while further efforts will still be required to translate this technology from the laboratory to the clinic. Thank you.
Namaskar, we are audible. Hope you can hear to us.
Yes, sir. Yes, sir. You're audible.
What is the main disadvantage of natural 3D scaffolds?
Sorry, sir.
What is the main disadvantage of natural 3D scaffolds? Like what you said, hyaluronic acid. What's the main disadvantage of it?
Disadvantage of natural 3D scaffolds, is it, sir? So basically, sir, natural 3D scaffolds, the stability is the main problem, sir. The 3D structure, it's main problem, sir. And even in the sterilization process, like in hydrogels, initially it was tried and tested for sterilization. So it was breaking down during sterilization. So further additives were added, like chitosan, to improve the ability of sterilization of hydrogels to make it as a better natural scaffold. So that is the main disadvantage.
Okay.
Can you hear me?
Yes, ma'am, I can hear you.
Yeah, how do you sterilize these 3D scaffolds or any type of scaffolds?
Mainly, ma'am, it depends on the material, ma'am. Natural and synthetic scaffolds, like they are sterilized in a different way, ma'am. They can be like gas sterilization can be done, and other methods of sterilization can UV light can be used. So various materials they undergo different methods of sterilization, ma'am. There's no one specificity.
Okay, can you tell me the basic mechanism behind these scaffolds?
Basic mechanism of scaffold, ma'am.
How do they
Basically,
act?
scaffold, ma'am, it actually acts as a 3D structure, ma'am. It mimics the extracellular matrix, ma'am. So it helps the cells cells to incorporate in it as well as to differentiate in it. So basically, acting as an extracellular matrix for the growth of tissue and in any other material.
What is mucosal adhesions?
Hydrogel exhibit mucosal adhesiveness, ma'am, in the natural scaffold. So it is basically hydrophilic, ma'am. So in that we can add various other materials to incorporate and make it a bit.
It's a good presentation.
Thank you, ma'am.
Can we have the next poster? Poster 116.
Okay, sir.
Yes, sir.
Yeah, go ahead, Dr. Arden.
Okay. Good morning to the respected juries. I'll be presenting my poster titled as Potential Stem Cells in Regenerative Periodontics. So in today's day and age, different types of treatment modalities and a lot of researches have been conducted in order to regain the lost periodontal tissues and its functionality to an extent. So one such topic where researchers have been constructed and concentrated upon is stem cell therapy. Now, what is stem cell therapy? So stem cell therapy is the type of technique where it induces repair response from the diseased and injured tissue by the utilization of stem cells. So stem cells can be defined as clonogenic, undifferentiated cells that have self-renewal capability and have multi-lineage differentiation. So these can be classified on the basis of origin as adult stem cell and embryonic stem cell. Then based on their differentiation potential, they can be classified as totipotent, pluripotent, multipotent, and unipotent. Now, I'll be just listing out some of the stem cells that they have derived from oral cavity. Mainly, it is dental stem cells and bone marrow stromal stem cells. So under dental stem cells, there are dental pulpal stem cells, then periodontal ligament stem cells, then stem cells derived from apical dental papilla, and gingival derived mesenchymal stem cells. Now coming to their applications, I'll be talking about the studies conducted in regarding periodontal ligament stem cells, bone marrow stem cells, and dental follicular stem cells. So in case of periodontal ligament stem cells, Liu et al. In 2008 conducted a study on guinea pig, and Takeharu Inukoi et al. In 2013 conducted a study on the jaws of bone where they demonstrated formation of cementum and new bone formation. Now, when it comes to bone marrow stem cells, so Hasegawa et al. In 2006 in guinea pigs, and Shaiste et al. In 2008, and McAllister et al. In 2009 conducted studies on human in case of sinus augmentation procedure where they demonstrated new bone formation. And in dental follicular stem cells, Kuo TF et al. In 2008 utilized this stem cell to regenerate dentin pulp complex along with cementoblasts and periodontal tissue cells. So coming to the recent advancements such as bio-root regeneration and cell sheeting has been introduced in stem cell therapy. So I would like to conclude that with so many researchers going on in stem cell therapy, along with the introduction of mechanisms like bio-root regeneration, stem cell therapy holds a potential in regenerative periodontics. Thank you.
Are you able to hear my voice?
Yes, sir. Yes, sir.
Yeah. Who is the American president who introduces veto power on the stem cells? Do you have any idea?
I don't know the name of the president, sir.
Fine, fine. Just casually ask any general knowledge question you have regarding stem cells. That's it. Why is stem cells, especially totipotent stem cells, banned in research?
Sir, totipotent stem cell is a zygote, sir. So this can give rise to any kind of embryonic based organ or placenta itself, sir. The totipotent stem cell.
Yeah, other than PDL stem cells, what
Yes,
other kind of stem cells can be used for periodontal regeneration, especially for bone regeneration?
For bone regeneration, ma'am, bone marrow derived stromal stem cells can be used, and also, ma'am, stem cells derived from exfoliated deciduous teeth have also been used, ma'am, for the regeneration of bone, and as it has both odontogenic and osteogenic differentiation capabilities, ma'am. Currently, I have this much knowledge, ma'am.
Oh, thank you.
Thank you.
Can we have the next presenter? Poster number 117.
Yes, sir. Good morning, sir. Am I audible?
Yes.
Good morning, sir. My topic of presentation is a review on management of multiple recessions. Gingival recession is the displacement of gingival margin apical to the cemento-enamel junction. It is a frequent periodontal finding.
Yes, sir.
Sir, am I audible?
Yes.
It is often associated with aesthetic complaints, tooth hypersensitivity, and difficulty in maintaining optimal plaque control. Multiple gingival recessions, when compared to gingival recessions, treating them is more challenging because of the anatomical variations of each tooth and the defect size variations of each tooth. Though it is challenging to treat multiple gingival recessions, many root coverage procedures can be considered to treat them. The following are the flap designs which are most commonly considered. Coronally advanced flap, where two vertical incisions are given, which are joined by intracircular incisions. Then the flap is made mobile and is placed coronally over the CEJ and is sutured. Modified coronally advanced flap or Zucchelli technique is coronally advanced flap technique devoid of vertical incisions. Tunneling technique is a minimally invasive technique by Allen where no vertical incisions are given. Only the intracircular incision is given, and a specific set of instruments, tunneling instruments, are used to make the flap mobile and is placed at CEJ and is sutured. Vestibular incision subperiosteal tunnel access technique. Vista technique is also a minimally invasive technique where only one vertical incision is given along with the intracircular incision. Along with these and many other flap designs, many grafts, membranes, and bone substitutes can be used to gain desirable properties. Amongst all the grafts, autologous connective tissue graft remains the gold standard, though it has a disadvantage of having a secondary surgical site, donor site morbidity, and low availability. Membranes such as platelet-rich fibrin and concentrated growth factor can be used in flaps, which enhances the wound healing of the flap, and collagen membrane can be used to gain the long-term stability of the treatment. Bone substitutes such as enamel matrix derivative and acellular dermal matrix can be used to gain root coverage requirements. In conclusion, with all the literature, modified coronally advanced flap along with the connective tissue graft or tunneling technique with connective tissue graft is ideally used to gain near ideal root coverage requirements. Thank you.
Nice presentation, doctor. Which is the gold standard procedure for most commonly the multiple gingival ratio? What procedure is the gold standard procedure?
The gold standard for multiple gingival recessions.
Yes.
So modified coronally advanced flap along with connective tissue graft can be used. So.
What is pouch and tunnel technique?
Pouch and tunnel technique is void of vertical incisions, and the tunnel intracircular incision is given, and the flap is elevated, making a pouch in the pouch, ma'am. Then it is debrided, and the flap is displaced from the periosteum and is placed over the CEJ.
Are there any advantages over other techniques?
There's no vertical incision, ma'am. That's why it is minimally invasive.
Especially healing. When you compare the healing.
Healing.
Yeah? Okay. Okay, sir.
Thank you. Okay, thank you.
Can we move on to the next poster 118? Presenter for poster number 118, are you there? Presenter for poster number 118, are you there?
Yes, sir.
Yeah, please. Could you keep your video on?
Yes, sir. Good morning, everyone. Today I am presenting my review poster on perio detective. As we all know, forensic odontology is an anatomy and science of to establish the identity through various procedure that solves and will continue to solve many crimes. Human identification during mass disaster using a stereotypes techniques like a fingerprint analysis is cumbersome task, and thus forensic odontology is playing interestingly increasing role in maintaining the records and identification of victim and the unique nature of the dental anatomy and time plays a role to ensure the accuracy when the techniques are appropriately employed. The dental professional and student need to be made aware of available data related to highlight the periodontal association with forensic science and to look forward to the potential association. The prime focus of this review poster will be to unravel the crime scene and how periodontists can contribute to the knowledge by associating parameters of his domain. As we can see, many factors like gingival tissue, pulp tissue, teeth, saliva, cementum, implant may help in determine the gender, age, and the with the help of implant we can identify the victim as gingival tissue after PMI, that is postmortem interval. After within the 0 and 8 hours, there will be many histological changes like nuclear changes in superficial layer, and then there is homogenization of collagen bundles. Within 8 to 16 hours, there is supravasal split, and there is a fibroblast vacuolation and moderate inflammation infiltration. Within 60 to 24 hours, there is complete epithelial loss of complete epithelial architecture and nuclear degenerative changes can be seen. With the help of pulp tissue, the DNA analysis for sex determination, then age can be determined by the pulp and teeth tooth ratio. Then with the help of teeth, as we know, third molar eruption average age, which is 15 to 22. Then the post-eruptive and degenerative changes can determine the age of the victim. Then saliva with the help of DNA analysis, we can determine the sex. Then as we know, even gingival clavicular fluid and saliva has many enzymes, contain many enzymes. So with the help of biochemical analysis, we can exactly determine the time of death. With the help of histological examination, then the cementum to find out the estimate age. There is average age required for the eruption plus incremental.
Sorry to interrupt. Your time is up. Need to conclude.
The conclusion is with the help of histological changes and biochemical analysis, we can accurately tell the exact human identification and exact time of death.
Mr. P. presenter, I think Dr. Ankita,
Yes.
why didn't you include the lip marks and bite marks in the forensic odontology? Because that is the most important part in aesthetic and periodontal point of view, which you are going on more on histological aspects and endodontic point of view.
As I was mainly focusing on periodontal.
Yeah, lip marks is one of the most important criteria rather than went on pulpal and histological identification. An odontological process which we most commonly use is not only that, one of the, you didn't include few of the points, which in forensic odontology. I felt like this. Ma'am, anything from your side?
Hello. Hello. Dr. Ankita,
Yes, ma'am.
can you name some biomarkers for the identification of these things?
So, ma'am,
You can name the salivary biomarkers, or you can quote one study. Just
recently, 2021, Mr. Sridharan has did the study on histological changes and biochemical analysis with the help of amino acid phosphate and ammonia in present in gingival tissue. They said that with the time passes gradually, the acid phosphate increases and ammonia decreases. So that can be correlated with the histological changes, and we can determine the exact postmortem interval, which is a date of time.
Okay. That's an interesting.
Thank you. Can we move on to the next presenter? Poster 119.
Yes, I present, sir.
Can we have the poster on the screen, please? Go ahead, doctor.
Good morning, respected all. Today I shall be presenting the poster. It is a review on the topic Reclaiming the Lost Papilla with the main focus on hyaluronan filler techniques. Now, although it is a small from anatomic perspective, the interdental gingiva has a very large significance from an aesthetic perspective because almost universally it is displayed during the smile. It is very vital for interpersonal relationships and strongly affects the person's self-esteem. In fact, a black triangle defect, that is when the interdental papilla is lost, the loss of 3 mm is clearly visible and noticed by a layman and is considered to be unattractive. Apart from aesthetic concerns, it also leads to food impaction, which can lead to bad breath, root caries, and gingivitis. It allows for space for air and saliva, which can cause many phonetic problems. So here in the poster, we see there is a very simple classification given by Nordland and Tarnow, which classifies the height of the papilla based on the location of the tip of the papilla with respect to 3 identifiable anatomical landmarks, which is the interproximal contact point, the interproximal extent of the CEJ, and the facial extent of CEJ. So a lot of techniques have been employed in order to reconstruct the papilla. There are non-invasive and invasive techniques. In non-invasive techniques, we have the orthodontic technique, which helps to mask and reduce the interproximal loss of papilla, or we have the restoration techniques. And then in invasive procedures, we have the surgical procedures, such as papilla reconstruction using pedicle flaps and autogenous grafts, and papilla preservation techniques. However, despite of the very sophisticated and elegant surgical and microsurgical procedures, it is not very predictable because it's a very small area, very difficult to access, and causes morbidity. So we will see the very novel recent technique of hyaluronan filler techniques. So here I have considered 4 articles, 4 studies which have been compared. So the first one to introduce this technique was Becker et al. In 2010, where he used Restylane, and less than 2.2 ml of hyaluronan was injected 2 to 3 mm apical to the tip of the papilla at a 90 degrees angle, administered up to 3 retreatment times in 3-week intervals. So he saw mean complete papilla refill in 57 to 100% of the cases with a stability of 6 to 25 months. Avartani et al. Used a cross-link. So the cross-linking increases the viscosity of the hyaluronan And he used a similar technique. Bertel et al. Used a hyaline barrier membrane, and he injected it at 3 different places. That is at the mucogingival junction, the attached gingiva, and the and apical to the tip of the papilla. However, it was seen that this particular technique was associated with a burning sensation and pain, which could be attributed to multiple site administration and also the increased viscosity of the product. The best results have been seen in the study conducted by Lee et al., where he used the product Teosil, and he injected it at a 45 degrees angle with a bevel up technique, and he repeated the injection techniques up to 5 times in 3-week intervals. And the mean papilla complete fill was found to be in 92.5% of the cases. So in a comparison and in an average of all of these studies, we see that hyaluronan helps to reduce 88 to 91% of the black triangle defects and achieves an increase in the papilla of 47.33%, which is stable up to 6 months. Advantages of hyaluronan include the fact that it is very biocompatible, it is biodegradable, it is natural.
Sorry, you need to conclude. Time's up. You need to conclude your poster.
Okay, sir. Yes, sir. Thank you, sir. So, sir, in conclusion, I would like to say that hyaluronan acid injections, fillers can be a very non-invasive or a minimally invasive technique for reconstructing the papilla.
That was a nice presentation, doctor. It was really very nice actually. You presented. What is the other applications of hyaluronan other than your filler? There are various applications in periodontology.
So it is considered to be a gold standard in dermal fillers. So it can be used in high lip line in cases where there is more maxillary show, and lip repositioning can be done using hyaluronic fillers for the lip. Also, it can be, this is an off-label use where it is used in TMJ. So it is used in knee arthritis, but it can also be used in TMJ arthritis or in cases where lockjaw is present.
I'm saying in dentistry. In dentistry, you are saying other applications in medical field. I'm asking dentistry other than your filler.
So in TMJ cases, or it can also be used in gingivitis and periodontitis cases also. Any
famous person who has done extensive work on this hyaluronan in mouthwashes and in other intraponal pocket lips? Who is that who has done this from Harvard? Madam has done this.
So I'm not actually aware of that.
Dr. K.L. Vandana and Dr. Mahada sir has done extensive research on this hyaluronan. Both are very fine. You can see number of articles on them.
Okay, sir.
Nice.
Thank you, sir.
Are there any other techniques other than this injection technique?
Yes, ma'am. So
administrative techniques, yeah.
In administrative, we can use PRF also. PRF with stem cells also can be used. So there have been studies where they've combined both hyaluronic acid, stem cells, and PRF. And however, most of these studies were conducted on very small percentage of the population. There was also another study which tried to compare saline injections with hyaluronic acid, but that was not.
No, I'm asking only injection technique is available or any other?
Ma'am, there are surgical, we have non-invasive and invasive. So as to fill the interdental papilla loss, we can do non-invasive techniques where orthodontic tooth movement can be achieved so that the contact point is shifted more, there is a broader contact area. Or we can do papilla reconstruction technique where pedicel flaps are used or autogenous grafts are used. Then there is semilunar coronally repositioned flaps or envelope flaps which can be used to fill the papilla defect.
Okay.
Thank you.
Thank you.
Can we move to the next presenter, poster 120? Can we have the presenter for poster number 120? Suvida, Ms. Suvida, can we have poster 120? Is the presenter for poster 120 present?
Sir, sorry to interrupt you. Here we are seeing poster 69, sir. I don't know why.
Yeah, that I will, sir. I will get back to you regarding that actually, sir. Because can we have poster presenter 120? If it's not there, then poster 121. Can we move on to poster 121? Presenter for poster number 121,
Yes,
121.
sir. Yes, sir. Am I audible?
Yeah.
Good morning, respected teacher and my seniors and my juniors, colleagues. The topic of my presentation is the extracorporeal shockwave therapy. What is the meaning of the extracorporeal? Extracorporeal means the outside of the body, and the shockwave is a single high amplitude sound wave that is generated by the electrohydraulic, electromagnetic or piezoelectric methods that propagates in the tissues, causing high rise in the pressure and followed by the decreased pressure. There are two types of the extracorporeal shockwave therapy, one radial and one is the focused. Radial shockwave therapy is targeted over the superficial tissues, and the focused shockwave therapy targets the deeper tissue. It's more commonly available. The first use of the extracorporeal shockwave therapy was in 1980s in Germany for the treatment of the kidney stone lithotripsy. How the shockwave acts in our body. The shockwave pressure front zone creates the cavitation bubbles behind the mainly is the empty spaces that collapses and creates the resultant forces. The mechanical energy translates into chemical signals that induces the physiological response of the tissues, causes cell stimulation and release of different growth factors. This way, the ESWT induces the cellular proliferation and new vascularization causes the tissue regeneration. There are different clinical application of ESWT has been shown here, and available literature supports the evidence that the ESWT induces bone regeneration at the doses of 250 to 500 impulses at the energy level 0.16 millijoule per millimeter square. It has got also an anti-inflammatory and analgesic effect, and the release of growth factor has seen in the dose of 500 impulses at the energy level 0.12 millijoule per millimeter square. The significant role of ESWT has been seen in the periodontics for different studies. Novak et al. In 2008 conducted and studies and reported that the ESWT has a selective bactericidal effect on some microorganisms such as Streptococcus mutans and Porphyromonas gingivalis, and also had caused an effect on the disruption of the bacterial biofilm. Santosh Kumar et al. Conducted studies in 2008 and observed that the alveolar regeneration can be done by the treatment with the ESWT. It may be used as an adjunct to the treatment of the non-surgical treatment of the peri-implantitis. To conclude that this non-invasive treatment therapy can be used because of its effective properties against the periodontal pathogens, as well as it induces the alveolar bone regeneration, fast periodontal remodeling with minimal or no such as documented side effects. Thank you.
It was a nice presentation, Doctor.
Thank you, sir.
So, what are the organisms which is most commonly affected by shockwave therapy? Most commonly affected organisms.
Most common effect in periodontics, sir?
Yeah. Most common affected. Which complex of bacteria are commonly affected by this?
The red complex of bacteria is most commonly affected by the extracorporeal shockwave therapy.
Any other bacteria other than red complex?
Any other than red complex, the studies reveals that mainly on the two bacteria such as Streptococcus mutans and Porphyromonas gingivalis. Other bacteria as such no mention.
So Streptococcus mutans is which complex?
Oh, sorry, sir. Sorry, sir. It's a complex.
Okay. Nice.
Can this technique be used for calculus removal? Are there any studies?
Yes, ma'am. This technique. Yes, ma'am. This technique can be used for calculus removal, but studies have shown that its efficacy is less than the ultrasonic instrumentation.
Okay, what frequencies can be used for different periodontal techniques?
And for the alveolar regeneration, the pulses will be 250 to. Am I audible? Ma'am, am I audible?
Yeah.
Oh, ma'am, for alveolar bone regeneration, it's almost 250 to 500 impulses in energy level 0.16 millijoule per millimeter square. And for the bactericidal effect, the pulses are the 100 pulses in 0.3 millijoule per millimeter square energy level is required.
That you have included, but I'm asking the different techniques which we are going to use it for periodontal treatment. Okay. No.
So can we have the next poster number 121 on the screen?
Yes, yes, sir.
Yeah, can we have the presenter for poster 121?
Yes, sir. Am I audible?
Sorry. Yeah. No. Presenter number, poster number 122. Sorry. Can we have the presenter for poster number 122?
Yes, sir. I am here. Can I present, sir?
Yeah, please.
Okay. Good morning, everyone. My topic for today's presentation is menace of black fungus. Mucormycosis is an angio-invasive necrotic fungal infection, predominantly infect the immunocompromised patients. Clinically, it manifests in 6 forms. Pulmonary and rhino-orbital cerebral are the 2 common forms. Remaining are cutaneous, gastrointestinal, renal, and disseminated form. Rhinomaxillary is a subtype of rhino-orbitocerebral mucormycosis involving sphenopalatine and greater palatine arteries, resulting in thrombosis of the turbinate and necrosis of the palate. The main purpose of this presentation is the periodontal manifestation of oral mucormycosis, that are multiple periodontal abscess, tooth mobility, especially the maxillary teeth, palatal discoloration, ulcer, and necrosis of the palate, halitosis. And other symptoms include pain, headache, nasal discharge, paresthesia, facial swelling, periorbital swelling. Pathophysiology, it mainly infects patients with predisposing factors like uncontrolled diabetes and immunocompromised patients through direct inoculation or inhalation of the fungal spore, which has an affinity towards the blood vessel at the site of inoculation, resulting in the formation of a fungal thrombi in the blood vessel. Ultimately, it leads to the compromised blood supply and necrosis of the tissue. Coming to the diagnosis, confirmation of the clinical diagnosis requires microscopic examination of the biopsy tissue. Potassium hydroxide wet mount can be used for the direct microscopy. The histopathological examination of the tissue shows broad non-separate type of hyphae with a pathognomic branching at right angles. Radiographic examination such as CBCT, MRI is helpful for the early diagnosis of the mucormycosis, but biopsy being the gold standard. Coming to the treatment, first and foremost is the systemic antifungal therapy with the liposomal amphotericin B initial dose of 5 mg per kg body weight as the treatment of choice and has to be continued till a favorable response is achieved. Meanwhile, underlying systemic disease should be controlled, and following which extensive surgical debridement should be done to remove all the necrotic material such as affected gingiva, tooth, and palatal ulcers. Hyperbaric oxygen also found to be an agent. Last but not least is the rehabilitation of the perforated tissue using a graft or a prosthesis. Hence, to conclude, successful treatment of mucormycosis lies in the prompt diagnosis and meticulous management. A vigilant periodontist could play a crucial role in its diagnosis and treatment, reinforcing a multidisciplinary medical approach to address this menace, which has seldom proved to be fatal. Thank you.
Nice presentation, Ashley.
Thank you, sir.
Other than what are the different treatment modalities of mucormycosis?
So mucormycosis, the first antifungal treatment has to be done, sir. Mainly the liposomal amphotericin B is found to be effective. There are 2 forms, lipid-based amphotericin and liposomal. But the main disadvantage of amphotericin is the nephrotoxicity, sir. So lipid-based are is more safe, but the coming to the effectiveness, the liposomal amphotericin B is more effective, so it has to be done until the the disease is stabilized. After that, you can can be switched to the posaconazole, fluoroconazole, the other antifungals, sir. And meanwhile, the systemic condition of the patient has to be managed, sir. It has to be under control, and after that, the surgical debridement of the necrosed part should be done, sir. Finally, the prosthesis has to be given for the rehabilitation of the necrosed part, sir.
Okay.
Yeah, Dr. Khadija, what is the prognosis of these patients, especially periodontally involved and What is the rate of spread of this disease from one part to other part of the body?
Ma'am, this has a rapid spread. That is the main disadvantage, or we can tell, the black fungus or the rhizoporus. So if we find it at the early stage, we can the disabilities what the patient undergoes will be less. It is the prognosis good only with the treatment. We can treat the patient and the prognosis is good, but the disability will be there. That has to be like rehabilitation has to be done later. And the mainly from the rhinus, it can goes to maxilla palate, and it can go to orbit, and after that through cortical cribriform plate to the cavernous sinus. If it reaches there, it will be it will be little difficult. I mean, the case will be until then the prognosis will be good only, ma'am, if it doesn't reach there. So the early diagnosis is the main thing.
Okay, good presentation.
Thank you.
Okay, can we have the next poster on the screen, please? 1, 2, 3. Presenter for poster 1, 2, 3. Are you there? Presenter for poster number 1, 2, 3. Are you there? Presenter for poster number 1, 2, 3. Okay, can we go to the next poster 1, 2, 4?
Sir?
Yeah, you're presenting poster number
1 to 4.
Okay. Wait, please. Ms. Suvida, can we have poster 1 to 4 on the screen? Yeah, go ahead.
Good morning. Here I'm going to present review poster titled Recent Breakthroughs in L-Prospan Nanofibers, a Silver Lining to Periodontist. Introduction. Nanofibers have played a versatile role in the field of dentistry due to their interesting structural features such as high surface area, surface functionalization, and porosity, which mimics the natural extracellular matrix. L-Prospinning was first observed in 1897 by Rayleigh and patented by Formas in 1934. In this method, electric charges are applied to the fluid to create a tensile force towards the collector plate. These produce nanofibers from electrically charged jet polymer solution or polymer melt. In short, L-Prospinning utilizes a polymer solution or melt to generate the nanofibers in high electric field. L-Prospinning techniques divide into 6 categories: basic L-Prospinning, blend L-Prospinning, coaxial L-Prospinning, emulsion L-Prospinning, melt L-Prospinning, and gas jet L-Prospinning. L-Prospan nanofibers have certain unique properties such as high surface area to volume ratio and low density. It generates interrelated porosity and improved cell-favored responses. It has high drug encapsulation efficiency and stabilizes the drug of proteins towards acid degradation. Periodontal application of L-Prospan nanofibers it plays an important role in tissue engineering, that is periodontal regeneration, and it accelerates periodontal wound healing, and it acts as a drug delivery system. In periodontal regeneration, functional L-Prospan fibers can be obtained by blending with polymer matrices, inorganic components, carbon-based or metal components, and with growth factors and proteins. For periodontal wound healing, hybrid nanofiber membrane using tinidazole and functionalized biodegradable chitosan or polycaprolactone, scaffolds based on gelatin and low molecular weight chitosan are also used in this wound healing. For drug delivery system, metronidazole-loaded L-Prospan polylactic membrane could significantly inhibit the viability of periodontal pathogenic species. Non-steroidal anti-inflammatory drugs such as ibuprofen and piroxicam incorporated in nanofibers used in this periodontal therapy. Conclusion: the progress of L-Prospan nanofibers for various periodontal applications has gained popularity in recent years, mainly for periodontal regeneration, periodontal wound healing, and drug delivery system. Thank you. Sir?
Yeah. That's nice, actually. No questions for myself.
It was a nice presentation, Ashni. Yeah, can you put some advantages of these nanospinners over other nano materials?
It has high surface area volume ratio, and it's at low density. It generates intercalated porosity. Its size ranges from micro to nano scales, and it is essential for the requirement of tissue regeneration. And it has a high
what is the rate of release the sustainable release of these materials when compared to other materials, biomaterials?
Sorry, ma'am, I will need. Hello, ma'am.
Yeah. It was a good presentation.
Thank you, ma'am.
So, can we have the next
Yeah.
presenter?
Yeah. Can we move on to the next poster 1 to 5? Presenter for poster 1 to 5, are you there?
Yes, sir. Good morning.
Yeah. Go ahead, please.
Good morning to all. The preferred material for dental implants have been the pure titanium, but pure titanium lacks the antibacterial property. Therefore, researchers have recently developed many antibacterial strategies to protect the implant against the microorganism. So the name of the topic for my poster is Implant Raksha, the modified strategies in guarding dental implants against the microorganism. Among that, the first strategy is anti-adhesion strategies. As we know that for the biofilm formation, the first step is bacterial adhesion. Therefore, it is wise to create the surfaces which prevent this adhesion. In that, the first is polymers. Polymers forms the coatings around the bacteria, which will prevent its adhesion. Nanostructures. These nanostructures penetrate the bacterial cell wall and cause the cell death. Coming to the release killing strategy, this strategies overcomes the limitations of the anti-adhesion and contact killing strategy. This here we have hollow implants where there are voids, large voids which are filled with the antimicrobials. In drug-loaded nanofibers, we have the different carriers such as nanotubes, nanopores, in which the drug will be loaded, such as vancomycin can be loaded. Then we have trigger responsive coatings where the drug will be released only when there is change in the microenvironment. That is when there is decrease in the pH and when there is increase in the temperature. Coming to the contact killing strategy, in the contact killing strategy, we have here the antibacterial is immobilized on the implant surface, which kills the microbes without causing the release of the drug. Therefore, here in the photoinduced coatings, whenever there is exposure to the sunlight, these will release the reactive oxygen species, which will cause the degradation of the bacterial cell wall through the release of carbon dioxide and water, which in turn cause the bacterial cell death. Ions has the similar mechanism, whereas antimicrobial peptides reacts with the negatively charged cell membrane through electrostatic interaction and causes the cell death. In intrinsic antibacterial materials, we have alloys such as silver and copper. Titanium have shown great antibacterial effect. Ceramics, zirconium has shown great antibacterial effect when compared to the pure titanium. Hence, to conclude, these above-mentioned strategies have shown great antibacterial effect, but when used in combination, they have shown excellent effects with minimum side effects. Therefore, researchers need to concentrate more on these strategies and try to implement these strategies in the clinical practice. Thank you.
So your mic is muted, sir.
Sorry. I think now it is audible.
Yes, sir.
Yeah, sorry. So, as you said, what is the advantage of titanium over other metals? You said you want to use zirconium or you want to use cobalt chromium. Other than antibacterial property of zirconium, what is the main advantage of titanium, first of all?
Hello?
What is the advantage of titanium material in implants?
Sir, titanium has best anti-corrosion ability, and it has a good biocompatibility. That's why it is.
There are many uses other than that. If you want to compromise on that and you want to have only effect on antibacterial by using zirconium and cobalt chromium, what's the main disadvantage of zirconium in using in implants?
Sir, zirconium mostly we are using because of the aesthetic.
That is okay. I'm saying the disadvantage.
My strength.
Okay, fine. Find out.
Yes. Thanks.
Dr. Nasima, my question for you is, So, which of this antimicrobial method is safe, or which has a better healing property? Are there any studies?
Ma'am, actually, all of these strategies have not proven clinically. They are all in vitro studies. So, but if we use combined together, one among these strategies like anti-adhesion and contact killing or anti-adhesion and release killing strategy, if we use combined together, they may have better effect. But no clinical studies have shown any effect of this.
None of these techniques are in use.
Clinic, no, but in vitro studies are there.
Oh, yes. Thank you.
Okay, thank you. Can we move on to the next poster?
Yes, sir.
Yeah. Can we have the presenter on the screen?
Am I audible, sir?
Yeah, you're clear. Go ahead.
Jai Hind and good morning to all the dignitaries, members of the panel, and my dear colleagues. Let us take a moment to realize how much technology has influenced our life today. With the help of technology, distance is not a distance anymore, and today we can be a part of this wonderful conference even though we are far apart. One such gift of technology from the mankind, by the mankind, and to the mankind is the laser. Today, I would like to present you a poster based on the laser technology in the field of dentistry entitled Laser Bandage, a Deal to Heal. LASER is an acronym for Light Amplification by Stimulated Emission of Radiation. Introduction of laser to the field of dentistry has been proved to be a boon to the dental professionals. It can be used for a variety of treatment that ranges from simple procedures to a more complex surgeries. In the previous years, lasers has been used for hemostasis, in which a char layer or an ester is formed. But with the advancement of the laser technology, the term laser bandage has been proposed, in which the laser is used in the lowest settings, which puts a coating on the tissue, and that helps with hemostasis to decrease the post-operative pain and to make small alterations to the soft tissue surgery. The parameters for which is given at the lower right corner of my poster. It uses the wavelength of 670 to 950 nanometers with a power in the range of 5 to 500 milliwatts with a frequency of 30 Hertz with no air and no water. The term laser bandage is somewhat similar to photobiomodulation or low-level laser therapy. Hence, mechanism of action also remains similar. The molecular and cellular mechanism of laser bandage suggests that photons are absorbed by cytochrome C that is present in the mitochondria of the cell, which in turn stimulates more ATP production and production of low levels of reactive oxygen species, which are basically responsible for the beneficial effects of laser bandage. Sometimes, when conventional techniques are used with scalpel, like harvesting a graft from the donor site, there is excessive bleeding at the site, which then causes discomfort to the patient, and it impairs the operator's visibility. The first image on the right-hand side, it depicts one such procedure, whereas the second image, it depicts application of laser bandage at the same site. As we can see, laser bandage application for local hemostasis after harvesting the graft from the donor site, it promotes better healing, and it also protects the underlying tissue from getting contaminated. Laser bandage can also be applied after various periodontal procedures like operculectomy, depigmentation of rhinoptomy, as it is being portrayed on the left side of the poster. The first row images of the 4 treatment column, it represents the preoperative images, whereas the second row image represents the laser bandage application following the operative procedures. And as we can see, there was an improvement in the clinical outcome following the laser bandage application, which is represented in the third row. Few other advantages of laser bandage, it also includes enhanced revascularization with no pain, no suture, and no pack requirement, decrease in the operator time, and better clinical outcome. So, to conclude, laser bandage is an evolving technology which has really proved to be a real deal to a painless and quicker heal. Thank you.
Fine, doctor. What is the laser used in this laser bandage?
So we can use lasers like a laser, diode laser. We can also use carbon dioxide lasers. So there are various articles which has quoted the use of these lasers in laser bandage.
Okay. What is the usage of this laser bandage in surgical procedure?
Sir, actually, after performing any surgical procedure, it creates one layer layer on the tissue, so it prevents it promotes better healing. It also decreases the post-operative pain, so the healing is basically enhanced. Initially, it was called as an Easter because the lasers in the older time, it had increased fluency, but now with the new laser machines, the fluency of laser is decreased. That's why this has been proved to be beneficial.
Okay.
Dr. Darsha, can you hear me? That's a
Yes,
nice
ma'am.
presentation.
Thank you, ma'am.
Okay. So the same type of laser can be used for the procedure.
Yes.
You told that it can be used after the procedure.
Yes, ma'am.
The same type of laser can be used for the same procedure.
Ma'am, actually, when we perform a surgery, the parameters or the settings what we use are higher. But for application of laser bandage, we use lower settings with low power per second with low fluencies. So the tips will be different.
Yeah. How do you classify the lasers?
Ma'am, lasers are classified as class 1, class 1A, class 2, which is further classified into class 2A and class 2B, class 3A, class 3B.
No, depending on the frequency, the level of frequency used.
Ma'am, we use high power lasers and low level lasers, which is also called as soft tissue lasers or photobiomodulation. Thank you.
Can we move on to the next poster, poster 127? Can we have the presenter for poster 127 on the screen?
Yes, sir. So am I audible?
Yeah, clear. Go ahead.
Good morning, everybody. The title for my today's poster is CUSA, a new angle to pocket therapy. So first, let us understand what is CUSA. CUSA stands for Cavitation Ultrasonic Surgical Aspirator. It is a device that has been used in the field of medicines since the early 1980s. It functions exactly as its name suggests. It functions the principle of cavitation with the help of ultrasonic waves within the range of 23 kilohertz, and the vibrations are transmitted through a hollow metal tip, which goes on to fragment the tissue, granulation tissue and the tumor cells, which is then aspirated through a separate portal on the same surgical tip. Now we all must be wondering as to why, where and how do we use CUSA in periodontics. So first, let us understand why. We all know that surgical exposure of an area has been the conventional technique to treat deep infrabony pockets for pocket debridement. But this can lead to extensive soft tissue manipulation, leading to post-operative complications such as loss of crestal bone height, loss of interdental papilla. This can be minimized by using techniques such as minimally invasive surgical and non-surgical procedures. Minimally invasive non-surgical technique aims at thorough subgingival debridement with minimum soft tissue trauma. CUSA can be used as an adjunct to this, where it can be used to treat deep infrabony pockets, and how Gazy et al. In his article has mentioned two approaches, that is an intracellular approach for a 3-wall defect and a transgingival approach for 1 and 2-wall defects. The primary outcomes 6 months post-operatively was increased pocket closure, decrease in probing depth, and increase in clinical attachment levels, and decrease in gingival recession. The additional benefits that were seen was greater patient compliance and acceptance due to minimal discomfort during and post the procedure, convenience for the operator, and no post-surgical complications. Coming to its use in medicine, it has been used extensively in the field of neurosurgery for resection of brain tumors, as it does not affect the adjacent brain, normal brain tissue. It is also used in procedures such as liver resection, splenectomies, and renal resections. It is also used in oncosurgery for procedures such as debulking of ovaries and removal of carcinomas in intestinal cancer, as it does not affect the blood vessels, leading to minimum blood loss. So to conclude, we can say that CUSA has shown promising results in the field of periodontology, as it can be applied to debride difficult to access areas. It can be also extended in the field of dentistry to other procedures such as endosurgery, and also in the field of oral or maxillofacial surgery for removal of cysts and tumors in the oral maxillofacial region. Thank you.
That was a nice presentation, Doctor.
Thank you, sir.
Any commercially available kit is there with the CUSA? Any
Sir?
commercial device is there? Any
Sir,
commercial device is there? Which you
yes,
said
sir.
right now, or is
Yes,
it
sir.
in experimental phase?
Yes, sir. It's a commercially available device. Cavitron is one company that makes our device. It has been extensively used in the field of medicine. It is not a new device. It has been used and it is being continuously used in the field of medicine for a variety of surgeries, sir. So it has shown promising results, not just in not just in medicine, but also in perio, sir.
Dr. Anisha, can you hear me?
Yes, ma'am.
Yeah,
Yes,
it was
ma'am.
a good presentation and
Thank you.
New topic also. So, what is the added advantage of this technique over the other like lasers and all photodynamic therapy, especially in
Ma'am, we
periodontics?
can access. First of all, it gives us better access to the area, and just because not just the tip, the mechanical vibrating tip, but it also includes irrigation and suction in the same tip. So it fragments, it debrides, and it suctions it out, which leads to area for a better clot formation, which can lead to better wound healing. And it is also the accessibility is the best advantage, ma'am, with all the added functions in one single tip.
Okay.
Sir, to answer your question, sir, commercially the tip size was 3 mm. For this study, they had modified the tip to 0.8 mm for better insertion and access.
What's the disadvantage of cavitation actually?
Sir,
What's the main disadvantage of
heat, sir,
cavitation?
heat generation, sir. Sir, heat generation, sir. Thank you, sir.
Okay, thank you. Can we move on to the next poster, poster number 128?
Yes, sir. Am I audible, sir?
Yeah, clear. Go ahead, please.
A very good morning to one and all. I'm here to present the review poster topic, Artificial Intelligence, the Hope Beyond the Hype. Moving to introduction, as we all know, the periodontal disease diagnosis, prevention, and treatment plan depend upon precision and accuracy of respective diagnostic methodology. The term artificial intelligence is the technology that utilizes machines to mimic intelligent human behavior and is basically concentrated on making strong systems to facilitate dental professionals to make decisions as well as to help patients understand the disease and prognosis. The main components of artificial intelligence is the genetic algorithm, that is of neural network and learning system, whereas neural network is of intelligent agents and vision system. Learning systems like deep learning, machine learning, natural language processing. Moving to application, there are various applications in other fields of dentistry, where in periodontics, this occur in various levels, like in multi-level data integration. When we input the data, so of detailed medical history and dental history, like environment factors, genotype, microbiota, diet, toxin, oral phenotype. These data get interpreted using algorithms, molecular mechanism, subject segmentation, and we get AI-assisted diagnosis, prognosis, and treatment. In diagnosis, it's a help of cephalometric analysis, identifying the lesions, transform clinical clues, and AI-assisted prognosis for predicting outcomes by prioritizing the risk factors, gene analysis, and biomarker analysis. Then we'll get the output. There is a treatment with CAD/CAM, distinguishing normal structures from abnormal, bridge data acquisition, and powered voices. The main benefit of the artificial intelligence is the enhanced precision periodontics, reduction of errors in diagnosis and treatment plan, support diagnosis, tracking, and administration. The main limitation is the complexity, costly setup of the software, time-consuming, adequate training also is required. The evidence-based studies is that by Lee et al. 2008 aims that algorithm is an efficient method of diagnosis and predicting periodontally compromised dentition. Also by Marta et al. 2021, it's a predictive tool in implants also. I conclude by saying that the field of AI is relatively young, but has still come a long way in the field of dentistry, and also supplemental tool and potentially augment the precision-based periodontal treatment strategies. So also will be the future in the dentistry. Thank you.
No questions from my side. Nice presentation.
Thank you, sir.
Sir, your mic is muted.
No questions from my side. You can carry on.
Okay, how far they are used nowadays, like in only in the diagnosis part, or the treatment also they can be used?
Treatment also
This,
can be used, madam.
Like
Diagnosis, prognosis, and treatment outcomes.
Periodontal treatments. Are there any studies?
Yes, ma'am. Yes, ma'am. In Lee et al. 2018, it has said that algorithm is an efficient and powerful tool in periodontally compromised conditions to identify the abnormal lesions in the oral diseases.
Okay, it was a nice presentation. Thank you.
Thank you, ma'am. Thank you.
Thank you, Doc. Can we move on to the next poster? Poster 129. Can we have the presenter on the screen, please? Dr. Imaja, are you there? Poster number 129, presenter, are you there?
Yes, sir.
Yeah. Go ahead, please.
Am I audible, sir?
Yeah, clear. Please go ahead.
Good morning. Today is my poster presentation on the topic membrane vesicles and the role in periodontal disease. Introduction. Periodontium is an ordered ecological system where a dynamic equilibrium exists between oral microorganisms and the host defense system, and the periodontal disease occurs whenever the balance is broken. Periodontitis has a sophisticated microbial ecosystem that colonizes in the periodontal pockets, primarily represented by the red complex bacteria, which comprises of Porphyromonas gingivalis, Tannerella forsythia, and Treponema denticola. Emerging evidence has shown that the Agricadibacter, Actinomycetin comitans, and Fusobacterium nucleatum and other gram-positive species such as Streptococcus species and Filifactor alosis and many others are also involved in the periodontitis. These bacteria possess abundant virulence factors, among which vesicles exfoliated from bacterial membranes are getting increasing attention. The membrane vesicles are spherical nanostructures with size ranging between 20 to 400 nanometers and are secreted by diverse bacterial species, that is both gram-positive and gram-negative bacteria, and also pathogenic and non-pathogenic bacteria. These vesicles enclose sorted cargo molecules and serve essential biological functions such as toxin transport, immunomodulation, biofilm formation, gene transfer, and intercellular interactions. The membrane vesicles are of three types. They are outer membrane vesicles, outer inner membrane vesicles, and cytoplasmic membrane vesicles. The gram-negative bacteria secrete outer membrane vesicles and outer inner membrane vesicles, whereas gram-positive bacteria secrete cytoplasmic membrane vesicles. Outer membrane vesicles are released from the outer membrane of living cells during normal growth with intact inner membrane and which are free of cytoplasmic components. The outer inner membrane vesicles are the results of endolysin triggered cell death model in which a cell explodes and the double bilayer membrane encloses the cytoplasmic proteins and nucleic acid contents. The cytoplasmic membrane vesicles are the fats derived endolysin which weakens the peptidoglycan cell wall, and the cytoplasmic membrane protrudes to envelop the cytoplasm. Coming to the composition of periodontal membrane vesicles, the membrane vesicle consists of the membrane components such as lipids and cytoplasmic components and other genetic materials and proteins, and accounts for the majority of membrane vesicle elements such as parcels and cargos. The proteins present in the membrane vesicles are of three types. They are gingipains, leukotoxins, and peptidyl arginase. Whereas coming to the lipids are of lipopolysaccharides, phosphatidyl, ethanolamine, and cardiolipin. The genetic materials are of DNA and RNA. Coming to the role of membrane vesicles in the periodontal disease, the membrane vesicles carry multiple pathogenic factors and toxins of bacteria, and they actively participate in the periodontal inflammation and tissue destruction. The membrane vesicles can also be used as vaccination, since they could be used as immunogenic substances to prevent pathogenic invasion. They interact with various oral epithelial cells and immune cells and trigger innate immunity, which is similar to that of the live bacteria. A membrane vesicles can also be used as a drug delivery system since they invade the oral epithelial cells effectively compared to the other drug delivery systems. To conclude, the membrane vesicles are secreted from both gram-positive and gram-negative pathogens, but this newborn field needs more exploration to transfer the theoretical knowledge into the practical. The membrane vesicles based approaches are expected to be applied in the management of various periodontal diseases and other general diseases also. Thank you.
What is on gingivitis, no? What is gingivitis and what's the role of gingivitis? Can you say what is gingivitis? Can you say anything about gingivitis?
So,
What is the role of gingivitis?
sir,
Dr. Renuka, are there any commercially available kits for this?
no, as of now, there are no many available in the market now. Still, research is going on now.
Okay, thank you.
Okay, thank you. Can we move on to the next poster? Poster number 130.
Hello, sir. Hello. Am I audible, sir?
Yeah, you're audible.
Can I start, sir?
Yeah, please go ahead.
Jai Hind and very good morning to the respected dignitaries and to all the co-PGs who are participating in this conference virtually from over all the places of India. So moving forward with my poster presentation, listen, the fingerprints are speaking. Oh my dear, by listening to this statement, we all can feel that the fingerprints are here with us today to make a strong point. So for the next 3 minutes, let us all hear to them and see what they want to convey us. So, sir, I'm having some disturbance. Someone is speaking. Himaja has not. Hello. Hello. Sir, sorry to say you. I'm getting a lot of. Himaja has not. The last participant who has presented her poster has not unmuted her mic.
Yeah, go ahead, Dr. Harish.
Sir, can I start it?
Please go ahead. Go ahead.
Yes, sir. Yes, sir. So, Jai Hind and very good morning to all the dignitaries and to all the co-PGs who are participating in this conference virtually from various parts of India. So, with my poster presentation, listen, the fingerprints are speaking. Oh my dear, by listening to this statement, we all got a feeling that the fingerprints are here with us today to make a strong statement. So for the next 3 minutes, let us all hear to them and see what they want to convey us. Dermatoglyphics. What is this dermatoglyphics? Dermatoglyphics is a science and also an art of surface markings and the dermal disconfigurations that are present on our palms as well as on our digits. It is not new to us. We are using these dermatoglyphics from past many years in the field of forensic for solving the many mysterious crimes. By this time, some of our participants might have got a doubt that it is necessary for me as a dentist to know about these dermatoglyphics. Yes, my dear friends, it is very necessary because nowadays this dermatoglyphics has drawn attention into the field of dentistry because of its ability as a diagnostic tool for many diseases like dental caries, bruxism, malacism, OSMF, etc., etc., etc. And it is considered as an effective diagnostic tool because of its simplicity, versatility, and the faster interpretation of the findings. Now, does this particular dermatography has got any importance related to our department in specific? Yes, my dear friends. This particular dermatoglyphics has got an ability of separating the healthy individuals from the chronic periodontitis patients, and it also got ability of distinguishing the aggressive periodontitis patients from the healthy individuals. Now, you people can ask me a doubt, sir. There are many papers, there are many articles released by many authors from past many years on this particular topic. Then why you are highlighting this particular topic with the help of this poster in this conference at this time? Is it necessary? Yes, my dear friends, it is very necessary, because in this pandemic situation where the doctor-patient interactions are mostly virtual, even though this virtual interaction between the doctor and the patient has got many advantages, it has got a the major drawback of the trust issues, which will seriously affect the doctor-patient relationship. So, in order to rebuild the healthy doctor-patient relationship and also to protect ourselves from these common infections, myself, Dr. Harish Gandha, and my co-PG, Dr. Soumya, will strongly recommend and also request you all to promote the clinical use of odontoglyphics as an alternative diagnostic tool in the field of periodontology and also in dentistry. And trust me, my dear friends, when the pandemic situation like this, life-threatening pandemic situations like this attack the world, never wait for the future to give you the solutions. On the other hand, what we can do is just sit back and go for the history, which will give you a beautiful solutions like this. And this particular statement will also give you the justification for the title, and the caption which I had given to my poster, which is as follows: the dermatoglyphics, which is revealing the mystery and reliving the history. So thank you everyone. Jai Hind.
What is the correlation between Pan-Europeans and periodontitis? What's the correlation between these two?
I'm not able to listen your voice, sir. It's not clear. Can you please repeat the question?
What is the correlation between dermatoglyphics and periodontitis? How can you correlate these two?
Yes, sir. Actually, there are different types of patterns, sir. We call them as loops, arches, and holes, sir. So when we collect the samples, fingertip patterns from the patients, and when we study it under the magnifying glass, we got severe details like this, sir. The details are like this: when the fingertip patterns of the chronic periodontitis patients were compared with those of periodontally healthy individuals, an increased frequency of concentric walls and the transverse ulnar loops on all fingers were observed. Whereas in aggressive periodontitis patients, when they are compared with the healthy individuals, we had got a decreased frequency of double loops on all the fingers, and also an increased frequency of radial loops on especially on the right second digit of the patients we had observed in the chronic aggressive periodontitis patients. This is a correlation between.
Yeah, Dr. Harish, it looks like an interesting presentation and very rare
Thank
presentation.
You so much,
so how can we rely on such techniques, and is it not a time consuming technique?
Ma'am, actually, there are so many articles supporting this particular topic, ma'am. There is a lot of research going on, and still there are so many merits of it, ma'am. I can tell you so many merits of this. Because it is a completely non-invasive technique, which is a no-touch diagnosis, which is very essential nowadays because of this COVID infections, and it is most economical, and it doesn't need any patient education, and it is 100% safe. Like other investigations, like X-rays and all, there will be a little of differences.
Yeah. Sorry to interrupt you. Apart from this type of diagnosis, are there any adjunctive like parameters we can take? Clinical parameters?
No, ma'am. No, ma'am. It is nowhere related to clinical, ma'am. Completely, it is just we can talk about the condition of the patient, completely depending upon the fingerprints of the patient.
It is used as an initial diagnosis purpose.
Yes, ma'am. It is used as an initial diagnosis, ma'am. You can use it as an alternate for the other investigations, ma'am. It is not the only investigation, ma'am. We can just use it.
Sorry to interrupt you like this. Suppose if the patient is a HIV patient, you mean to have dermatoglyphics.
Yes, sir.
You can see how you can diagnose the patient based on dermatoglyphics. These lines are formed. What is the reason for the formation of these lines?
Sir, yes, sir. When we are in embryonic stage, sir, there are many reasons of forming this because of
Then you mean to say at the womb only you
twisting
are
of our
finding
hands.
having periodontal
Yes, sir.
gingivitis directly. You are correlating it directly like that, sir.
Yes, sir. Yes, sir.
That's a different presentation.
Yes, sir. I can explain you, sir. Because
So sorry to interrupt.
yes, sir.
Can we move on to the next this one, sir? We have exceeded the time limit.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Carry on.
Can we have the poster number 131?
Yes, sir. Am I
And
audible?
I request all the participants to keep their mics muted. Only during the presentation they are supposed to unmute. Yeah. Can we have the poster number 131 presenter, please? Go ahead, please.
Yes, sir. So, good morning, everybody. So, the topic for today's presentation is personalized periodontal therapy. So, according to Bartow et al. In 2018, he defined the personalized periodontics as a separation of patients into different groups with clinical decisions, practices, and the products being customized to an individual patient. And in this model, we often use diagnostic testing for selecting the appropriate treatment plan for the patient based upon their molecular, cellular, and other genetic analysis. So, in the normal, the commonly used method of clinical diagnosis is only after tissue clinical destruction is evident. That is only after clinical tissue destruction is evident. But by using personalized periodontal therapy, we can assess even the subclinical tissue destruction, and hence we can see that there is a transformation from reactive periodontology to predictive periodontology. So the diagnostic testing we use commonly belong to the point of care testing, and they are of two types, that is test for disease prediction and the test for disease diagnosis. And in the test for disease prediction, we use PerioPredict, which tests for the interleukin 1 alpha and 1 beta. And in test for periodontal disease diagnosis, we use there are of two types, that is biochemical test and the microbiological test. And in the biochemical test, we have MMP DIP test, and which tests for MMP 8 levels. And according to Tonanti et al. In 2018, according to the greater than 30 nanogram of MMP 8 levels is correlated with the grade C rapidly progressing periodontitis, and other kits that are available are PerioGuard, which checks for the AST levels, and Perio 2000, which checks for the volatile sulfur compound levels. And the microbiological tests include OMIG, which is a DNA probe system for assessing the Porphyromonas gingivalis and Provotella intermedia, and Evaluate, which is a membrane-based immunoassay kit which evaluates for all the three putative periodontal pathogens, and BANA test, which includes which is a test using the peptidase test. And here in the BANA test, we use Porphyromonas. We can test for Porphyromonas gingivalis, Temporal forcente, etc. And but the major limitation of all these tests is that the patients with periodontitis often, most of the time, they belong to the lower socioeconomic class, and hence the affordability is very less. That is, they are less likely to seek care for this personalized medicine. And what we can do is that we can customize the oral hygiene therapy for this patient, and we can allow the patient to take responsibility for their periodontal health by allowing them set a goal, plan a behavioral change, and monitor themselves. Thank you.
Doctor, what are the organisms that are detected in BANA?
Yes, sir.
What are the organisms that are detected in BANA?
The major disadvantage? Are you asking disadvantage of BANA?
What are the organisms? What are the organisms detected in BANA?
Tenarella forcynthia, Porphyromonas gingivalis, and Eponema denticola.
Still anyone more other than these three?
No, sir.
Fine.
Any other diagnostic kits, which can be included in this chart? Can you hear me, Malvika?
I can't hear you, ma'am.
Dr. Malvika, am I audible? Okay, no problem.
I'm sorry, ma'am, I can't hear you, ma'am.
Actually, your voice is audible. I think she has some net connectivity. I'm able to hear your voice.
Okay, sir, no problem. Let her conclude. Thank you.
Ma'am, can we move on to the next poster?
Sure, sure. Move to next.
Can we have poster 132? Presenter for poster number 123. 132, are you there? Presenter for poster number 132.
Yes, sir. I'm here, sir.
Yeah, you can go ahead.
Good morning, everyone. The topic of my poster is decision tree for periodontal regeneration of intrabony defect. In general, intrabony defect is defined as a periodontal defect within the bone, which is surrounded by 1, 2, or 3 walls, or a combination thereof. Historically, we have classified intrabony defect as 1-wall defect, 2-wall defect, and 3-wall defect. And the decision for making any regenerative procedure to continue, we decided as we have certain protocols according to which we decide if we want to go with a regenerative procedure or any other procedure. In cases in which we have to avoid a regenerative procedure include intrabony defect, which is usually less than 3 millimeter. There's an exception in maxillary anterior aesthetic region where we can go with a regenerative procedure. When the probing depth is less than 5 millimeter and there is no inflammatory component, there's favorable prognosis with conservative treatment, and or the probing depth in which the probing depth is more than 5 millimeter, which can be managed with other surgical treatments. In situations like intrabony defect more than 3 millimeter, or there is possibility of endodontic and orthodontic treatment, we can go with a regenerative orthodontic procedure. There are certain factors which needs to be considered before making a decision. Certain factors, like we have patient-related factors, we have site-related factors, and the intrabony defect architecture. Patient-related factor, most important, we have the compliance of the patient, patient's any systemic or any other condition which needs to be controlled, any behavioral issue like smoking. Site-related factors, we have mobility of teeth, gingival biotype, and in the intrabony defect, we have to determine the intrabony defect, which include we have to determine the configuration of the intrabony defect, whether it's 1-wall, 2-wall, or 3-wall defect. The angle of intrabony defect is a crucial aspect in making a decision for regenerative procedure. Coming on to the procedure, we have if we have 3-wall defect or a circumferential defect, we usually it has a good prognosis. So we usually go with bone graft procedure or GTR membrane or biologics or a combination of all the three. When it's 2-wall defect, the prognosis is fair to average. We can go with reinforced GTR membrane, bone graft, GTR membrane, or bone graft plus biologic. We have to also consider aesthetic risk, low aesthetic risk or high aesthetic risk. Low aesthetic risk, we have to see the smile line. We have to look for the ability to control the secondary occlusal trauma, if the width of attached gingiva, and in high aesthetic region like high smile line, excessive gingival exposure, thin or minimal zone of attached gingiva, papilla loss if there is more than 6 millimeter tooth contact interproximal bone distance. In these patients, we have the regenerative procedure. We have to explain the patient accordingly, and we can go with the regenerative procedure. And after all the treatment, the supportive periodontal therapy is very crucial. All the treatment is the success of all the treatment of all the procedure that we do. It's basically it is also it is important. The outcome is very important after the patient's compliance and how the oral hygiene is maintained after the treatment. Thank you.
That was a nice presentation, Doctor. Most common in all the 4 defects, 1-wall, 2-wall, 3-wall, or what are the most common defects?
So I didn't get the question.
What is the most commonly seen defects? One wall or two wall or three wall or what do you want to see? Which is the most commonly seen defect?
So we
Most
commonly
commonly seen.
two wall defects, two wall or three wall defects we mostly encounter.
Say one, not two wall or three wall?
So two wall defects.
What's the name of it?
So two wall defects are usually called craters. They are. Yes, sir.
Very good. Okay, nice.
Yeah, my question to you is,
Okay, nice.
yeah, thank you. My question to you is, how do you classify these defects? On what basis these defects are classified, and which defect has got a better prognosis?
Ma'am, the classification of the intrabony defects is basically on the number of walls remaining. The three wall defect, three walls are remaining, and two walls defect, the two remaining wall, and one wall defect, the one remaining wall. And the best prognosis is for the three wall defect now.
Okay, good. Thank you.
Thank you. Can we move on to the next poster? Poster number 133. Can we have the presenter on the screen for poster number 133?
Yes, sir. Am I audible, sir?
Yeah, clear. Go ahead, Doc.
Yeah. Good morning, everyone. So today's my topic for poster is the laterally closed tunnel technique. It was given by Dr. Anton Scullion in 2018. So gingival recession, basically by definition, is the exposure of root surface resulting from migration of gingival margin, which is apical to CEJ. We often encounter patients who complain of compromised aesthetics, which is due to recession. So why is the recession treatment so necessary? Foremost, to prevent the further loss or progression of recession, and secondly, to prevent tooth hypersensitivity, and thirdly, to enhance the aesthetics. So the conventional approaches for recession coverage are free gingival graft, subepithelial connective tissue graft, pedicle autografts, coronally advanced flaps, and some more. But in cases of deep isolated recessions, especially in the mandibular anterior region, tension-free coronal displacement of flap is difficult, and in such conditions, due to excessive tension, there is increased risk of flap dehiscence and also decreased vestibular depth. But with deep isolated recession, the main motto is to increase the soft tissue thickness to facilitate plaque control and to prevent further breakdown or root caries. So in 2018, Dr. Anton Scullion developed laterally closed tunnel technique, which is designed specifically for deep isolated recession, which is present in mandibular anterior, in which along with the tension-free coronal and lateral mobilization of soft tissue margins, complete root coverage is achieved, resulting in no scarring after healing. The steps for the laterally closed tunnel technique are intracellular incision using microsurgical blade given, vertical preparation of the tunnel is done, mobilization of interdental papilla, enabling tension-free lateral movement, adaptation of soft tissue margins to cover the greater part of exposed root, palatal subepithelial connective tissue graft harvested and soaked in 5 to 10 minutes soaked for 5 to 10 minutes in EMD. The donor site is closed with mattress sutures. Root surface conditioning is done with 24% EDTA followed by saline rinse. Graft, the subepithelial connective tissue graft is fixed with sutures mesially and distally, and suturing of the tunnel margins is completed. Advantages of this technique is there is no scarring after healing, wide mesiodistal and apical mobilization of tunnel, tension-free movement of flap to cover the graft and recession. So hence I conclude the laterally closed tunnel technique is a novel surgical approach for recession coverage, especially in the deep isolated recession areas, resulting in complete root coverage.
That was a nice presentation, Doctor.
Thank you, sir.
What are any other techniques other than what you said and the lateral tunnel technique? Any other techniques which are most commonly used for the covering of single root coverage procedure?
Sir, semilunar flap technique can be used FGG
in the mandibular anterior.
for pouch and tunnel technique can be used.
Most commonly used technique for lateral. I put the answer
FGG is used most commonly for mandibular anterior recession pouch.
Okay.
Yes, sir.
Dr. Ishani, can you hear me?
Yes, ma'am.
What type of blood supply you will have in this technique, and how advantageous it is to the regeneration?
Ma'am, the blood supply is mostly from the adjacent gingiva, alveolar mucosa, and the host bed. And the regeneration is the healing is due to primary intention. So regeneration is expected in like 8 to 10 days.
Thank you, Ishani.
Thank you.
Thank you. Can we move on to the next poster? Poster number 134.
Yes, sir. Hello.
Yeah, go ahead, Doc.
Good morning, respected delegates. It is well said that preservation of health is easier than the cure for disease. So, topic for my poster presentation is from resorption to preservation partial extraction therapies. Partial extraction therapy is a method of rich preservation by retaining tooth roots and its attachment to bone, thereby maintaining bundle bone periodontal ligament complex with its vascular supply and in turn eliminating the resorption of hard and soft tissues associated with tooth extraction. It was first classified under a collective term by Gluckman et al. In 2016, and it is indicated in case of an unrestorable tooth indicated for extraction, absence of periapical pathology, teeth with healthy amputated pulp or root canal treated tooth, while it is contraindicated in teeth with external root resorption, root caries, and an existing endodontic periodontal lesion due to unhealthy root. The partial extraction therapy, it combines 4 different techniques such as the root submergence, socket shield, proximal socket shield, and the Pontic shield techniques. The root submergence technique was first introduced by Bijon in 1965 so as to retain the radicular portion of tooth in confines of alveolar housing to prevent the alveolar bone loss. This is a case where both central and lateral incisors were planned to be replaced by an implant-supported restoration, 2-1 being the submerged root, while 1-1 and 2-2 being the implant-supported prosthesis. Post-treatment radiographs showed that submerged root maintains an ideal mesodistal alveolar bone level. The second technique is the socket shield technique, which was introduced by Herzl et al. In 2010. Here first the tooth is decoronated to the gingival level, followed by the sectioning of root mesodistally so as to separate the labial and palatal halves of the root. The palatal fragment is then mobilized and extracted with the help of microperiotomes and microforceps. The socket is then prepared and thoroughly irrigated with saline, followed by immediate implant placement. The third technique is the proximal socket shield technique. It was first introduced by Kahn and Drumcharison in 2013 to manage the inter-implant papilla, mainly in the anterior implant aesthetic area. Here, the right maxillary central incisor was sectioned horizontally, that is buccopalatally, and the inner side of distal root fragment was prepared, while the mesial portion of the socket was debrided and integrity of the bone knee plate was verified, followed by an immediate implant placement. Post-treatment radiograph also showed preserved buccopalatal alveolar bone level. The last technique is the Pontic shield technique, which was also known as modified socket shield technique, which was introduced to preserve hard and soft tissues in Pontic area, similar to socket shield technique, but instead of placing an immediate implant in socket, bone grafting material is used to fill the socket. Here the socket shields were prepared at 1-2, 1-1, 2-1, and 2-3 with immediate implant placement at 1-2, 2-1, and 2-3, while socket grafting and soft tissue closure via CTG at 1-1. After 90 days of healing, with an additional 90 days of Pontic pressure, an anatomical soft tissue frame was developed to see final processes. Also, complete absence of buccopalatal collapse can be noted at site 1-1 due to Pontic shield. So to conclude, partial extraction therapies open new prospects of treatment options in this era of high demands and the ever-growing field of implantology. Also, they provide a conservative approach by preservation of root fragments and this help in maintaining the rich content. Thank you.
Nice presentation. It was really nice. What is the main drawback of socket shield technique?
Sorry, sir.
The main drawback of socket shield technique.
The main drawback is that it can cause exposure of the bony plate, and it can result in resorption of the tooth root also.
It can resorption bony plate. I didn't get you once again, please.
The main complications is the internal exposure of the internal exposure of the socket shield. That is due to the lack of adequate space between the coronal edge of the shield and the subgingival contour of the crown. Whereas the other second most complication is external exposure.
Okay, yeah. Right.
Are there any recent studies which they have used such techniques?
Yes, one of the studies which was conducted by Bowers et al. Examined 43 submerged vital roots in 9 patients and 6 months after submergence, and they also reported the alveolar preservance of the alveolar bone level in such case.
Your presentation is good, but it's like closed in time. That's the only drawback I found in your presentation. You should have closed in time. You exceeded your time.
Okay, thank you, Doc. Can we move on to the next poster 135? Can we have the presenter on the screen, please? Poster presenter number 135, are you there? You please unmute yourself.
Yeah. Hello.
Yeah.
Yes, sir. Yes, sir. I'm Dr. Monica Valle. The topic is a roadmap to the success of immediate implants. Immediate implants is the placement of implant in fresh extraction sockets, and the decision to extract the tooth and replace them with immediate implant. It has following factors that determines teeth restored with crowns, loose endodontic posts, advanced caries, unfavorable crown to root ratio, and the compromised tooth in the aesthetic zone. Okay. And for this, we have to evaluate the patient. Thorough medical and dental histories have to be taken. Clinical photographs, study records for the record matters, and radiographs. The CTs will provide a 3D visualization of the tooth concerned and the surrounding bone. The clinical procedure for immediate implant placement is the first step is tooth extraction. Tooth extraction, the extraction should be as automatic as possible. There should be efforts should be made to minimize the trauma to the alveolus. Specially designed instruments like mini surgical blade or periotomes are used. After the extraction is done, walls of the socket are thoroughly curated to remove the remaining period. When the implant osteotomy is done, second step, preparation of the extraction area and the apical bone for the placement of the implant. Once the osteotomy is prepared to the desired depth, the depth is 3 to 5 millimeters apical to the extraction socket. This gives an implant to bone contact to the in that extraction socket. An implant is placed in the prepared osteotomy parts of the implant, and the threads come in direct contact with the bone. This provides the primary stability. As it's the primary stability, it is also called as the mechanical stability. The third step is the implant to socket wall space. The close adaptation of this implant to the socket, it promotes greater osteointegration. If all the 4 walls are intact after tooth extraction and the circumferential defect is less than 1.5, implant can be placed without any grafts. But if the space is more than 1.5, defect is more than 1.5, then there is need for graft augmentation, and membranes are placed for to prevent the epithelial migration. Then next is post-operative management. A temporary prosthesis, either removable or fixed, can be placed over the implants. And soft tissue management, this is one of the critical factors. And gingival tissue is shaped and managed by the provisional prosthesis and by the provisional crown placed prior to the placement of the definitive crown. Now, after this, the implant loading is done. During implant loading, when a shortened loading protocols, clinician should follow. Amount of primary bone contact or primary stability. Like after the osteotomy, what stability we have achieved, that primary stability, if it's good or not.
You need to conclude. Time's up.
Okay, okay, sir. Yeah. Yes, sir. Yes, ma'am.
My question to you is, what are immediate delayed implants?
Ma'am, this is according to the time period when, like the immediate implants, they are placed in the fresh socket, and delayed implants, it is after, as we classify immediate, early, and delayed. The early is the one, the soft tissue healing is to be done. It is within a time period of 4 to 8 weeks is the early implants. Early implants are again into two: soft tissue healing without any bone healing, and the other one is soft tissue healing.
My question to you is, what is the duration to say it as immediate delayed implant? What?
The delayed implants, it is after the healing of the bone has been done, after the 6 months when the healing is done. Healing of the hard tissue is bone is done.
What is the space you said between the implant and the bone? You're saying there is space of 1.5, space of 1.5. What is that space called?
The jumping gap.
Jumping distance. Right. Okay.
Thank you. Can we move on to the poster number 120?
Thank you, sir.
Poster 120.
Am I audible, sir? Hello?
Yeah.
Hello, good morning, sir.
Can we have you on the screen, please? Can you keep your videos on? Yeah, please go ahead.
Am I audible, sir?
Yeah, clear. Go ahead.
Sorry for the inconvenience, sir. Good morning, everyone. As we all know that a famous quote by Lish McBride is, "The fear left which is unchecked can spread like a virus." The topic from my poster presentation is demystifying the viro-pero interrelationship. In this, the periodontitis is chronic polymicrobial inflammatory condition. It affects over the 30% of the adult population. Here, we know that there are 4 major viral families which are associated with the main viral oral diseases of adults. These are herpes viruses, human papilloma virus, picorna viruses, and retroviruses. These herpes viruses, there are 8 human herpes virus species, which includes HSV1, HSV2, varicella zoster virus, Epstein-Barr virus, human cytomegalovirus, HSV6, 7, and HSV8. Then papilloma viruses will induce the benign lesions of the skin and mucous membrane like warts and condylomas, epithelial malignancies like cancer of the uterine cervix, certain types of anal cancer, laryngeal cancer, and oral cancer. Type 16 papilloma viruses have been implicated in 1/3 of oropharyngeal squamous cell carcinomas. The picorna virus will consist of 9 genera and contain serious pathogens: poliovirus, hepatitis A, virus, Coxsackie-virus, ecovirus, poliovirus, and human enterovirus. Enteroviruses, they will manifest as enanthems, respiratory diseases, aseptic meningitis, and severe illness in newborns and compromised host. Also, it can also lead to some fatal outcomes. Then in retroviruses, there is a total of 7 retrovirus genera have been established. of which HIV and T lymphotropic viruses are the human pathogens. There are other oral manifestations of HIV virus as xerostomia, candidiasis, oral hairy leukoplakia. Then it can also lead to gingival edema and necrotizing ulcerative periodontitis, Kaposi's sarcoma and all. Then coming to the SARS-CoV-2, the ability of this coronavirus SARS-CoV-2 to spread is one of the determinants of the COVID-19 pandemic status. Asymptomatic patients with no respiratory impairment, these are believed to be responsible for more than 80% of the transmission. I've come across two studies by Sahni and Gupta in 2020 and Badran et al. In 2020 who have mentioned about this COVID virus. Sahni, Badran et al. They have said that pockets, periodontal pockets that can be a potential reservoir for SARS-CoV-2. And Sahni and Gupta have demonstrated the relation between COVID and periodontitis. To conclude, we have demonstrated that both the eukaryotic and the prokaryotic viruses within the subgingival plaque and the periodontal tissues that will affect the more established mediators of periodontal inflammation, putative periodontal pathogens, and the host immune response. In regard to the association of herpes viruses and periodontitis, the degree to which these viruses will directly aggravate the periodontal tissue, that damage still remains unanswered. Thank you. Thank you, sir.
So, nice presentation, Doctor. My question to you is, what is the other name for HSV3 and HSV4 and HSV5?
Other names for HSV, sir?
3, 4, 5.
HSV,
you said herpes simplex virus 3, 4,
also
5.
3 is also called as varicella zoster, sir. 4 can be Epstein-Barr virus, which leads to this lymphomas, Hodgkin lymphomas, and lymphoid lymphomas. And HSV 6 can is the human cytomegalovirus. 5 human cytomegalovirus. Yes.
Yeah, my question to you.
Who is the pioneer in this HSV virus and periodontitis? There are couple of authors who did a lot of studies in this.
Yes, sir. There are evidences regarding the role of in the etiology of periodontal disease. As in 1994, Contreras have they demonstrated the presence of cultivable HSV samples, HSV in the salivary samples of advanced periodontitis.
Yeah, my question to you is, what type of virus you see in localized aggressive periodontitis, especially in the active sites? Which type of virus is seen in studies?
In localized aggressive, ma'am, cytomegalovirus?
Yeah, correct. Cytomegaloviruses are more commonly seen in LAP. Okay, good. That's a good.
Thank you, ma'am. Thank you, ma'am.
Thank you. I think we have finished with almost all the presenters. So I think we would we'll conclude the session, sir and ma'am.
Sir, sorry to interrupt. One more presentation is there.
1, 2, 3. I think she's not there, ma'am. Then she's not there. I think she's not presenting the post, I suppose.
Okay, sir.
That's
so
why
we are concluding.
Yeah. Okay, sir. So on behalf of the Organizing and Scientific Committee of the 45th ISP National Conference Virtual 2021, I extend my heartfelt thanks to Dr. Lakshmi Tejaswin and Dr. Bhagya Lakshmi Banaki for taking out their time and judging the review poster session. I request the judges to email the completed evaluation sheets at poster.ispconferencepune@gmail.com. So thank you once again, sir and ma'am.
Thank you for giving us an opportunity.
Thank you, sir. Thank you, sir, for giving the opportunity, sir.
Thank you.
Thank you, sir.
सुना क्या? अच्छा था ना? वो गुड भी बोली वो मेरे को. साइटोमेगालो बोली और ईस्टर्न स्टेन भी था मैंने जस्ट.
A very good afternoon and welcome to the next session A warm welcome from us, all of us, from 45th ISP virtual conference to our judges and all the participants. I would like to welcome Dr. Ambili Swati and Dr. Ambili and Dr. Swati Agarwal. Is Dr. Ambili here? Ma'am?
Yes, I'm here.
Yes, ma'am. I would like to introduce everyone to Dr. Ambili, ma'am. Dr. Ambili R completed a BDS and MDS from Government Dental College, Trivandrum, and PhD in Faculty of Dentistry from University of Kerala in 2018. She's a fellow of Royal College of Surgeons and Physicians, Glasgow, UK. She's working as a research director and professor in the Department of Periodontics, PMS College of Dental Science and Research, Trivandrum. She has more than 16 years of teaching experience and currently guiding PhD students under Kerala University of Health Sciences. She has published extensively in high impact international journals and is a reviewer of many international journals. She had been invited for delivering guest lectures at various national and state level programs. Welcome, ma'am.
Thank you, Dr. Shijita.
Thank you, ma'am. I welcome Dr. Swati Agarwal. Ma'am, are you here? Dr.
Yes,
Swati Agarwal?
Yes.
Yeah, Dr. Swati Agarwal, ma'am, is currently working as reader in Department of Perio and Implantology at Kotiwal Dental College and Research Center. Ma'am has 16 publications in national and 14 in international journals to her name. Ma'am has her own private practice. She has been a guide and co-guide for PG students, internal and external examiner at various universities, and has presented various posters and papers at national and international conventions. She has also won a Best Paper Award in ISP National Conference, Bangalore in 2019. I would like to welcome everyone, and for the session, I would just like to brief that the session, each presenter will get around 3 minutes to present, and 2 minutes will be the question answer session. Let's stick to the time so that we could finish the session. We could follow the format and the timings properly. Welcome, ma'am. Should we begin with the first slide?
Sure.
Yes.
Sure. RPO 181, who will be presenting?
I will be presenting.
Yeah.
Good afternoon, everyone. Today, the topic of my poster presentation will be the role of nutritional supplements in periodontics in the period of COVID-19. Nutritional supplements, for example, the vitamins, minerals, and the trace elements, are the dietary supplements that are intended to provide nutrients that might not otherwise be consumed in sufficient quantities in our daily diet. Periodontal health is influenced by a number of factors such as the oral hygiene, genetic and epigenetic factors, the systemic health, and nutrition. Many studies have observed that a balanced diet has a positive influence in maintaining the periodontal health. Now, the periodontal disease is a complex process of infective and inflammatory process leading to production of reactive oxygen species or ROS, which in turn worsens the periodontitis. Similarly, in the cases of SARS or COVID-19, there is tissue damage leading to inflammatory factors, and oxidative stress enhances these inflammatory factors and tissue damage. Here, the antioxidants can reduce the oxidative stress, and reduce the oxidative stress relates to the reducing the inflammation in the tissues. Similarly, in periodontitis, antioxidants may provide a periodontal health and a better outcome for the periodontal therapy by reducing the oxidative stress by scavenging the reactive oxidant species. The human diet, now the SARS COVID-19, there is many studies, there is few studies, among them the Mauro et al. In 2021 have identified that the risk of COVID-19 complications are higher among the patients with moderate to severe periodontitis compared to those with milder or no periodontitis. This can happen in multiple ways. The periodontitis can can hamper the control in diabetes, obesity, and the cardiovascular diseases, producing mood oxidative stress, and that can cause more the cytokine that can precipitate the cytokine storm or increase in inflammation, reduce that is causing more morbidity to the COVID-19 patient with periodontitis. Our human diet contains a number of antioxidants in the form of vitamin A, vitamin C, vitamin E, glutathione, and the melatonin. It is well known that the vitamin D3, zinc, and vitamin C are being given to the patient in COVID-19 to reduce the oxidative stress and act as the antioxidant. The vitamin C and the iron helps in formation and the maturation of the collagen fibers there, and the deficiency of vitamin C can produce weak collagen. To conclude, there is a link between the nutrition and periodontal health. So a healthy diet and nutritional supplement may be beneficial to improve the periodontal health and reduce the COVID-19 related complications, and also helps in faster recovery. So our aim should be having a good nutritional status for this patient. Eat fresh and unprocessed food every day. Have less and moderate and oil and fat, less salt and sugar, and drink plentiful of water.
And the time is over. Sorry, could we go on to the question answer session?
Yeah, I'm concluded.
Yeah, okay. Ma'am, could you ask the questions, please?
Doctor, which are the vitamins that are given as supplement during COVID-19 infection period?
Madam, it is generally the vitamin C is being now produced, which maybe helps in the antioxidant, which maybe acts as the antioxidant to reduce the oxidative stress and hence the tissue damages.
And anything else is usually given during the infectious period?
Yeah, vitamin D3 may be also given. Vitamin D3 is hereby there's a known action, antimicrobial action of vitamin D3. It also has an effect on the ACE2 presenting cells in the host tissues.
Is there any other benefit for this nutrient supplementation for periodontal therapy as such, even if it's not regarding COVID-19 patients? Otherwise, is there any other benefit for giving this nutritional supplements for periodontal therapy?
Yes, madam. There the vitamin A, the vitamin or the zinc may be given. The vitamin C, the iron has some roles.
Okay, can you mention a recent study which has been published regarding the association between COVID-19 and periodontitis? Can you name the author, which is published very recently from India, actually?
Sir, this is Maru in 2021. He has done the study.
Okay, over to Dr. Swati.
I just want to know, is there actually any role of zinc, like you were talking about zinc and antioxidants? Is it actually proven? Can you give any facts?
Proven.
Nothing is proven.
Not.
Yes.
Nothing is proven yet.
Yes, and it may deteriorate the health also. Zinc also, if taken in excessive doses, which people did during COVID-19, it actually can deteriorate your health.
Yeah, the mucormycosis is somewhat found to be related.
Yes, so you should be cautious while using. So, okay, thank you.
Yeah.
Should we go to the next slide, please?
Am I audible, ma'am? Can I start?
Yes. Can you switch off your camera, please?
I have switched it on, ma'am.
Okay, okay, can see you. Yes, you can start.
Yes, a very good afternoon to everyone present here. Today, I'll be presenting my review poster on the title, The Whole Gamut of Dressings for the Palatal Donor Wound. To begin with, the advent of periodontal plastic surgery techniques has led to the increased use of soft tissue grafts obtained from the palatal mucosa. Post-operative morbidity is an important limitation of these procedures with an open secondary wound in the donor site. Conventional periodontal dressings provide an inner mechanical barrier assisting healing by prevention of external influences on the wound area. Biological dressings, on the other hand, may help to accelerate the healing process. So there were many materials which were introduced. To start off with traditional gelatin sponge. Gelatin is a thermally denatured collagen of bovine or porcine origin. Due to its remarkable hemostatic properties, it has been advocated as a standard wound dressing material. So next comes the platelet-rich fibrin, which is derived from the patient's own venous blood. It is a 3D network of fibrin and growth factors. It is reported to accelerate wound healing and reduce the post-operative discomfort by releasing various growth factors like transforming growth factor beta, platelet-derived growth factors, vascular endothelial growth factors, and insulin-like growth factors. By altering the rotational speed and the centrifugation time, various lineages of PRF can be obtained, and the one such is the injectable PRF, which is IPRF, and the activated or the APRF. So the advantage of IPRF is that it has a high cellular migration and total long-term growth factor release, and the advantage of the activated of the APRF is that it has enhanced neutrophil granulocytes on the distal part of the clot. According to a recent systematic review and meta-analysis by David Jonathan et al. In 2021, it was concluded that the use of PRF as a wound dressing for the palatal donor site after FGG has decreased the post-operative pain and induced earlier and complete wound healing, wound epithelialization. Next comes low-level laser therapy using the gallium, aluminum, and the arsenide lasers, which biostimulates and accelerates the wound healing by altering the cellular behavior of keratinocytes and fibrinocytes. Next comes the microcurrent electrotherapy, which uses conductive electrodes on the wound site, which leads to cytokine modulation and leads to early wound resolution. Amniotic membrane, which is the most internal membrane of the placenta. Studies have shown that the amniotic membrane induces reepithelialization, angiogenesis, has antibacterial properties, and contains growth factors like tumor necrosis factor alpha. So the last comes the alveogel, and a current study by Karim et al. In 2020 have used alveogel, which is a commercially available product, which is a mixture of butaben, iodoform, and eugenol. Butaben is a topically, which is an ester type of local anesthetic agent. Iodoform is an antimicrobial agent, and eugenol is essential oil with remarkable pain reduction properties. Hence, to conclude, all the above materials have led to early soft tissue healing, and it can be selected upon the individual treatment requirements. Thank you.
And question answers, please. You can start immediately after the presentation.
Okay, what is the term that is given when PRF is applied over the palatal wound area? There is a particular term coined for that.
A biomaterial, ma'am?
No. That is again from an Indian author. The term is coined for when PRF is applied as a palatal wound dressing.
Wound dressing.
Find it out, okay?
Yes.
Is there any difference between different types of PRF when it's applied as a wound dressing material? Is there any difference?
Maybe the consistency of the material, ma'am. When it comes to IPRF, which is a little liquid in consistency compared to the normal.
Will it alter the healing property, or one is superior to other? Do you have any idea regarding that?
In case of IPRF, the rotation time is only 3 minutes, ma'am, in which the trauma to the cells is less, and more amount of stem cells can be found in the last product.
Okay, Dr. Swati.
So can you just tell me like how low-level laser therapy acts in healing of the wound area?
It is stated that, ma'am, low-level laser therapy like stimulates the cellular activity of fibroblast and keratinocytes in the wound area, ma'am.
So like just doing one time, if you like the day you have operated, you have done triple LT.
Yes, ma'am.
And then you have to recall the patient, or just doing one time is enough?
No, ma'am, you have to recall the patient, ma'am.
How frequently?
Maybe once daily for 5 consecutive days, ma'am.
So do you have any supporting data for that?
In
But,
one study, I've read that they did it for like once daily for 5 consecutive days. They have done it, ma'am. Thank you, ma'am.
Yeah, thank you. Could we go to the next slide, please? Yeah, Dr. Ibrahim.
Good afternoon. Yes, ma'am. Am I audible?
Yes, you're audible. Can you switch on your camera?
Yeah, ma'am.
Thank you. You can start.
Good afternoon. The topic for today's poster of mine is pinhole surgical technique, a radical to conservative periodontics. As we know, reinstating a stable periodontium along with minimal trauma to the tissues is considered an optimal goal for periodontal reconstructive surgery. To achieve this objective, various reconstructive surgeries for root coverage procedure has been appointed over the years. At present, free connective tissue graft was appointed as the most common and gold standard procedure. However, it is associated with post-operative pain, swelling, and bleeding. So, to overcome these hurdles, a novel reconstructive minimally invasive technique is introduced. Hence, the aim of this poster is to review a new technique for the treatment of gingival recession. The pinhole surgical technique is a minimal invasive surgical technique which was given by Chow et al. This poster also illustrates that pinhole surgical technique also allows the repositioning of the gingiva quickly and easily with a very less invasive method and a shorter treatment and recovery time and very much less pain. Coming on to the methodology, 13 articles were reviewed for the preparation of this poster. The main outcome of this poster is that it reviews that PST is an conservative alternative to other reconstructive periodontal surgery. Coming on to the armamentarium, along with the other periodontal surgical instruments, a special set of instrument that is transmucosal periosteal elevator has also been used for this method. Coming on to the surgical method, as we can see in the picture, a pinhole is created. That is, a horizontal incision was given of 2 to 3 mm just apical to the recession site at the mucobuccal fold, and the transmucosal periosteal elevator is inserted into the hole all the way up till the base of the pocket. And for enhanced regeneration, any regenerative product can be used adjunct to this method. Also, the last picture, as we can see, it is post-operative 3 month, and most of the studies have done 6 months, but this a few studies which have said this is the post-operative 3-month picture. As to conclude, PST is one of such novel technique which is minimally invasive, predictable, time efficient, and cost effective procedure for recession coverage in Miller's class 1 and class 2 recession defects. Thank you.
Okay, Dr. Ibrahim, is it a case report or are the photos taken from an article?
Ma'am, I took at least 13 case reports and I did it together and I made it a review, ma'am.
The photos are from a review article, original article only?
Yes, ma'am.
Okay. So what is the name of that elevator?
Ma'am, what is transmucosal periosteal elevator, ma'am?
Is it periosteal elevator or something else?
Ma'am, in a few articles, ma'am, it has been mentioned transmucosal periosteal elevator, and in some articles they have been mentioned ma'am, it has been also called a transgingival periosteal elevator. Ma'am, periosteal word is there, ma'am, but
periosteal is there, but it's did you refer the original article by Dr. Chow?
Chow
it's a patented instrument actually, and it's called transmucosal papilla elevator, not periosteal
papillary elevator. Yes, ma'am. Actually, I came across this article, ma'am. Yes, ma'am.
Okay. Dr. Swati.
So can you tell me what could be a possible disadvantage for pinhole technique, especially when we are talking about regeneration? What could be the possible disadvantage of this? Like where we cannot perform this pinhole technique?
Ma'am, this surgical technique, ma'am, it has been used specifically in multiple recession defects, ma'am. So it could be, it could not be used at a site specific, ma'am, site specific recession area. It might be one of the factors, ma'am.
You should read it, okay?
Yes,
it is not, okay.
Thank you. Could we go to the next slide, please? Yeah, Dr. Parkavi, could you begin your presentation? Yeah. Could you begin your presentation?
Yes, ma'am. Good afternoon, everyone. Today's topic is on role of mouthwashes against COVID-19 in periodontal health. As we all know, SARS-CoV-2 is the name of the notorious coronavirus that put a stop to the world. And it has been demonstrated to show higher affinity for angiotensin converting enzymes. And AC receptors are found in oral mucosa such as gingiva, epithelium of tongue, and salivary glands. The proximity to the patient during dental care, higher generation of aerosols, and identification of SARS-CoV-2 in saliva has suggested oral cavity as a potential reservoir for COVID-19 disease. And one of the suggested methods to suppress the microbial load during dental procedure is pre-procedural mouth rinses using any antiseptic agents. So this coronavirus, it is an enveloped virus, that is, it contains lipid bilayer, and it also has spike proteins called glycoproteins that will help to interact with the host cells, and it will result in transmission of the disease. So this mouthwash will either disturb the microbial lipid bilayer, or it will modify the ability of the spike protein to interact with the host cells. So coming to povidone-iodine, it is the broad-spectrum antimicrobial agent with higher virucidal activity. So when it comes in contact with the tissue surface, it will release free iodine, and this iodine will neutralize the organic acids, nucleic acids, and destabilization of lipid bilayer. And recent studies propose that 0.2% of povidone-iodine mouthwash for about 15 seconds decreases the viral load. And coming to chlorhexidine, it is a bioanion, and Yonedon has conducted a study in 2020, and we have found that 15 ml of 0.12% of chlorhexidine mouthwash has a beneficial effect in suppressing SARS-CoV-2 virus for about 2 hours. And the antiviral property is because of the ethanol component of the chlorhexidine. And coming to cetylpyridinium chloride, it is a quaternary ammonium compound. So this is a positive charged agent that will interact with the negative charge of the viral cell membrane, and it will disturb the lipid bilayer. And the concentration is about 0.05%. 15 ml of cetylpyridinium chloride for 30 seconds reduces the microbial viral. And coming to hydrogen peroxide produces free radicals. The SARS-CoV-2 is vulnerable for patients. So these free radicals will disturb the microbial lipid membrane of the virus, and 1.5% pre-procedural rinse of hydrogen peroxide for about 1 minute has a beneficial effect in controlling the SARS-CoV-2. Can gargle mouthwash protect you from infection of new coronavirus? The answer is no. The World Health Organization has told that mouthwashes can eliminate certain microbes in our oral cavity for a few minutes, but it will not protect you from COVID-19 disease. Thank you.
Among the different mouthwashes you mentioned, which do you think is the most effective antiviral agent?
And povidone-iodine is having good antiviral.
Okay, you mentioned about the concentration as 0.23. Is it the normal concentration that we use in our regular mouthwash? Povidone-iodine?
Actually, concentration varies. But for COVID-19 patients, we are suggesting this concentration.
Okay, Dr. Swati?
Yeah, it's okay, ma'am. This was the only question that has.
Okay, we can move on to the next one.
Okay, sure. Thank you. Can we go to the next presentation, please? Dr. Yashwant? Can you be a little louder? Dr. Yashwant? No, we can't hear you clearly. Try to be a little louder. Judges may not be able to hear you.
To me, nothing is audible, ma'am.
Okay, okay. Try using a headphone. Maybe the mic would help you.
Good afternoon, everyone. Good afternoon, madam.
Yeah, this is better. Yeah, this is much better. You can start.
Good afternoon, everyone. Today I'm here to present my topic on impact of COVID-19 to periodontal lines. The coronavirus belongs to the family Coronaviridae in order of litovirales, comprising of single plus large stranded RNA. It has 4 genera: alpha, beta, gamma, and delta. Delta genera. Mostly alpha and beta genera infects the humans and the mammals. It mainly affects the respiratory, GI, and CNS systems. And alpha and the delta and gamma, they affect the birds. The coronavirus infection, it's present from the last 2 decades. In 2002 and 2012, there is an attack of SARS-CoV-2, SARS-CoV and MERS-CoV in Asian countries. This novel coronavirus 2019, the corona means it derived from the Latin word corona means crown. The nucleotide sequence which is similar to the bat which is present in the human provenance. It has three challenges we are facing to this transmission of the coronavirus, which is community transmission, asymptomatic, pre-symptomatic, and post-symptomatic transmission. The transmission can be occurred can occur by the droplet infection, aerosols, and contacts and foment transmission. For prevention, the proper hand sanitization or temperature check for every patient, and social distancing from the patients, and purified air, which is a HEPA filters, and complete sanitization procedure, and vaccination, and proper use of the PPE. When treating the patient, before the proper history taking is necessary by formulating the simple questionnaire like is the patient is infected with is the patient is in contact with the COVID patient previously from the past 14 days, and he is attending any mass gathering, and he is having experienced any respiratory problems, cough and any CNS problems during this last 14 days, and the vaccination has become a big boon to the for the prevention of the coronavirus. The dentist can be helpful in the disrupting the transmission chain in the prevention of the coronavirus. The proper use of the PPE and minimizing the use of the PPE is necessary for the as the aerosol spread can be which is more during the treatment procedures during the treatment. Thank you.
How long after COVID-19 infection you can provide a periodontal therapy?
After usually 3 months recovery, we can provide a periodontal.
Is there any problem associated with doing treatment, dental treatment, immediately after COVID-19 infection? What are the problems that can be associated?
as it affects mainly the respiratory problem. If the patient is not able to do the proper
Dr. Swati.
Can you please tell me, like you were talking about aerosols, can you tell me that in an order, like who is the most affected with aerosol, and then who all are the people, like supposingly in a setup, you are a treating doctor, you have a patient and you have an attendant. So who all are affected in what manner through aerosols? Who is affected the most? What place is affected the most? And who is the least? Is there someone who is not affected? Are all of them affected? Or is the only operator affected with the aerosols? Only patient is affected? What is the sequential order?
Mostly the dentist, the professional which is treating the patient will mostly affected. Less the hygienist who is assisting the way, and in the least the receptionist can be the least affected.
Actually, you are not understanding the question. There is a study which was published that through aerosols, who is most commonly affected? The patient's chest is also affected with the aerosols. So if you put a petri dish and you send it for culture, there is a proper study which is telling the sequential order who is the most affected, who is the least affected. You should go through that, okay? Once you are talking about aerosols, you should know that.
Okay, thank you. Can you go to the next presentation, please? Who will be presenting this abstract? Abstract ID 1163.
हाँ मैं आहे.
Aishwarya, are you presenting this?
Yes, ma'am.
Are you presenting this?
Yes, ma'am. I'm presenting.
Okay, then begin with your presentation.
Good afternoon, ma'am. My poster presentation topic is sonoporation, the ultrasonic sonoporation therapeutic ultrasonic waves. Coming to the definition, sonoporation is defined as the interaction of ultrasound with the ultrasonic contrast agent to temporarily permeabilize the cell membrane, allowing for the uptake of various substances such as DNA, drugs, and other therapeutic compounds from the extracellular environment. So how it works? So the mechanism of action of sonoporation. So sonoporation is worked by the following effects, such as the thermal effect, cavitation effect, induction of convective transport, and the mechanical effect. In thermal effect or the cavitation effect, in cavitation effect, there is a formation of gaseous cavities in a medium ultrasound exposure. And the primary causes of this cavitation is the ultrasound-induced pressure variation in a medium, and the cavitation involves the generation of oscillation of gaseous bubble in a liquid medium. While in thermal effect, there is absorption of ultraviolet medium, and material that possesses the higher ultrasound absorption coefficient won't experience several thermal effects as compared with the muscle tissue. In convective transport, the fluid velocities are generated in the porous medium exposed to ultrasound due to interference of incident and ultrasound in the diffusion cell. And in this way, the cavitation.
Aishwarya, there is a lot of disturbance on your side. We can't hear you clearly. We can't hear you clearly.
Hello, ma'am.
Yeah, now we can hear you.
In mechanical effect, at frequencies greater than 1 megahertz, there is density variation occurs so rapidly that a small gaseous nucleus cannot grow and cavitation effect stop. So in this way, this is the operation works, or this is the mechanism of action of sonoporation. So what are the applications of sonoporation? Sonoporation is mostly applied in the gene delivery by the osteoinduction, induction of the dental pulse cell differentiation into osteoblast, and the site-specific gene delivery or the DNA transfer. It is also used in the local drug delivery, targeted drug delivery, tumor cell killing, or the induction of apoptosis. So in this way, the sonoporation is a technique based on the ultrasonic waves that employs the acoustic cavitation of microbubbles. So it can also serve as a novel application of oral squamous cell carcinoma and for local drug delivery system in periodontal disease because of its non-invasiveness and potential to the deeper tissue in the body. It is used in the delivery of therapeutic agents, including the genetic material, proteins, monoclonal antibodies, and the chemotherapeutic agent. It is also as a very effective and a promising physical method for delivering drug, nucleic acid, and for gene therapy. So the sonoporation is the effect of ultrasound movement on the drug through the intact living thing and the soft tissue. It can increase the supermarket to various drugs, including hydrophilic or the lipophilic, which are large molecular weight compounds. Also in transdermal drug delivery, by using this sonoporation, the nuclear cavitation are mostly due to small bubbles trapped between the skin surface and transducer. So in this way, these are the applications of the sonoporation. So in future aspect, it is also used in the future aspect. In the field of sonoporation or ultrasound enhanced drug or the gene delivery during the past decade promises to radically change in the way which index the drugs to near future. As also this problem.
I swear your time is up. Could we go to the question answer session?
Yes, ma'am.
Okay, Dr. Aishwarya, are there any clinical studies regarding this sonoporation in periodontal treatment?
Yes, ma'am.
Is it a theoretical one, or have people started applying it clinically?
Yes, ma'am. People started applying the local drug delivery system in the periodontal disease, ma'am. But it can serve as a novel application of this oral squamous cell carcinoma, but also the local delivery system in periodontal disease, and also for the chemotherapeutic agent, monoclonal antibodies, or the proteins.
Okay. Dr. Swati?
Okay, ma'am. Actually, it was not very clear to me. Your presentation was very unclear. So this was one aspect, that whether it actually has some clinical applications or not, and what is the instrument that is used. Sonic wave is okay, but what is the actual name of that instrument that is used for this? It's okay, ma'am. We can carry on with the next.
Sure. Thank you. Can we have the next slide, please?
Hello, ma'am.
Yeah, is it Supriya?
Yes, ma'am.
Dr. Supriya? Yeah.
Yes, ma'am.
Yes.
Can I start?
Yes, you can start.
Good evening. I, Dr. Supriya Shirodkar, like to introduce my poster topic, Shining Light in Periodontology, that is photobiomodulation, PBM. So it has been around 15 years. You must have heard it by different names, such as the low-level laser therapy and many more. So it is called as in 2016, the group of experts gathered together to name it more accurately, it was photobiomodulation. Photo, because it is light, bio, it is the biological action, and modulation, it can stimulate or it can inhibit the action. So it is a type of non-invasive, non-thermal therapy based on the no ionizing light source, including laser, light-emitting diodes, and broadband light. Shown in second picture, the reaction is occurs inside the cell in the mitochondria, mediated by the cytochrome C oxidase, which is act as the primary photoreceptor, which is a result in increased level of the adenosine triphosphate, cyclic adenosine monophosphate, and the calcium and reactive oxygen species, and activate the transcription factor. This will result in the angiogenesis and the neovascularization, and as shown in picture third, which increases or accelerates the tissue healing in the injured one. It increases the appearance of the inflammatory mediators such as the neutrophil, macrophages, and the lymphocytes, which helps in decrease the inflammation. It helps in proper alignment and the remodeling of the collagen, which increases the tissue elasticity. It helps in nerve regeneration by the myelin formation and the neuronal sprouting. It increases the muscle regeneration and stimulates the osteocytes for the bone formation and the cartilage production. So there are a number of indications of the PBM that use in the periodontology, depending upon the reviewed literature, such as the anesthesia before the injection in the mucosa, then the single irradiation for the implant. It helps in reducing the post-operative pain, inflammation, and the edema. As it is used with the guarded bone regeneration to repair the bone, and it aids in reducing the edema, whereas the healing or the accelerated the wound healing. There are certain absolute contraindications for the PBM, such as the malignancy, pregnancy, pacemakers, and the irradiation over thyroid gland. And then the next chart shows the PBM with their clinical effects, such as the increased lymphatic flow, show the decreased edema. Then the reduction in the histamine helps in reducing the pain associated with the inflammation. The reduction in the conduction of C fibers result in reduction of the pain. And then the increased activity of the neutrophil and macrophage assists the modulation of inflammation and the tissue damage. The picture 8 shows the PBM device, which is roughly in size and shape of the composite curing light. Then, according to the Mark et al., which present the reviewed article, depending upon that reviewed article, the dose of the PBM for the healing, it is 2 to 8 joules per centimeter square. For the analgesia, it is 10 to 30 joules per centimeter square, whereas for the implant, it is 10 to 20 centimeters per square. So we can conclude that the photobiomodulation is newly erupting emerging field in the dentistry and the periodontology that combines the light energy with the lasers for the our therapeutic benefits. Thank you.
So what is the light source that is commonly used?
Ma'am, the wavelength, it is depend upon wavelength. So in the photobiomodulation, the wavelength ranges from the 630 to 980 nanometer, which comes in the visible red light to the infrared near red infrared electromagnetic spectrum, ma'am.
So is it the same laser as that we use for periodontal therapy, or is it a particular device?
Ma'am, it is a particular device, and if we compare with the other lasers, it uses a more this is the only soft tissue lasers that the penetration power is up to 2 to 3 centimeters. It cannot penetrate our bone. So the wavelength is more. If we consider the erbium or other neodymium or the NAC, the wavelength is more, ma'am, as compared to this.
What is the wavelength of diode laser?
Diode laser is in the range of, ma'am, again that 630 to 980 nanometers.
Dr. Swati.
So are there actually any studies yet done for photobiomodulation?
Yes, ma'am. The ICOL et al. They studied the clinical evidences that they use a photobiomodulation plus SRP and SRP alone, and the result shows that there is a clinical attachment gain, whereas also the reduction in the pocket depth and the bleeding on probing is also reduced as compared with SRP alone.
So what instrument you use? Can you tell and how much is it cost effective or not? Like what is the
yes,
cost?
Yes, ma'am. We can conclude the cost in disadvantages. Ma'am, yes, it is a cost effective.
It's what's the name? Can you tell the name?
Name of?
Like the instrument you use for light source. The light source what you used?
Photobiomodulation device. I don't know the instrument name. Sorry.
Okay. Thank you. Can we have the next presentation, please? Yeah, Doctor.
Am I audible, ma'am?
Yes, you're audible. You can begin with your presentation.
Good afternoon, ma'am. My first topic is periodontitis and COVID-19, cytokines from immunosuppression dysbiosis. COVID-19 is a pandemic viral disease caused by the severe acute respiratory syndrome, coronavirus 2, that is SARS-CoV-2, that initially occurred in Wuhan, China in December 2019, and since expanded worldwide. The inhaled virus propagates and migrates down the respiratory tract along the conducting airways, and a more robust innate immune response is triggered. Due to the more robust innate immune response, many pro-inflammatory cytokines are released, because of which there is cytokine storm. Now, coming to the proposed biological mechanisms behind the link between periodontitis and COVID-19. Local inflammation in the periodontitis can affect the body through three main pathways. That is, spillover of the locally produced inflammatory mediators to the systemic circulation, leading to systemic inflammation. Entrance of the bacteria or bacterial products and virus to the systemic circulation to the gingival sulcus. Aspiration of bacteria and virus into the upper and lower respiratory tract. These are the proposed mechanisms. Coming to the top left corner of my poster, there it is shown how the virus from the oral cavity, it is entering into the through oral cavity, through sulcus, it is entering into the bloodstream. From there to the vessels of the neck and the chest, the virus is entering into the heart, that is cardiovascular system. From the heart through the pulmonary artery, the virus and bacteria, these are entering into the lungs, and they are settling in the lungs, in the terminal peripheral vessels and in the alveoli, where they are going and attached to the endothelial angiotensin converting enzyme 2 receptor, which increases the angiotensin 2 production. The increase in angiotensin 2 production will lead to vasoconstriction, immunothrombosis, and vascular congestion, which will subsequently lead to more inflammation and release of more pro-inflammatory cytokines, which are again added to the systemic circulation. Now, coming to the top right corner of my poster, there it is shown how from oral cavity, the virus and bacteria, they are entering into the gut. In the gut, they are disturbing the local microbiota of the gut and causing inflammation there. And through the walls of the gut, this bacteria and virus, they are entering into the systemic circulation, causing inflammation and endotoxemia. Because of this, there is additional contribution of pro-inflammatory cytokines like interleukin 1, 2, 6, 17, interferon gamma, tumor necrosis factor, alpha C reactive proteins to the systemic circulation. Because of the flooding of this pro-inflammatory cytokines from various sources, many organ systems in the body are involved, which I have shown in the middle. Like now, coming to the cardiovascular system, in cardiovascular system there are palpitations, chest tightness, blood clots, and heart attack. Coming to the renal system, there is hematuria, proteinuria, and blood pressure, decrease in blood pressure. Coming to the microvascular circulation, there is endothelial dysfunction and hypoxemia. Coming to the central nervous system, there is headache, impaired consciousness, confusion, and cerebrovascular stroke. And coming to the respiratory system, that is lungs, there is cough, sore throat, dyspnea, increased fever, and there is because there is diffuse lung damage, there will be congested, damage, and leaky capillaries in the lungs, because of which there is a decrease in the blood oxygen levels, which will subsequently lead to acute respiratory distress syndrome. Which means,
excuse me, doctor, we are time is over. Yeah, we have the question and answer session, please.
Yes, ma'am.
Yeah, thank you.
So, how the cytokine storm will influence the dysbiosis? Are you talking about the interaction between periodontitis and COVID-19, or how periodontitis will increase COVID-19 cytokine storm? What is the message that you want to convey?
Two-way relationship, ma'am.
Two-way relationship. Okay.
Like how,
so, will it affect the dysbiosis of the oral cavity? In poster, you have shown dysbiosis of the gut microbiota.
Yes,
will it have any influence on dysbiosis of the oral microflora?
Yes, ma'am. Through systemic inflammation is increasing, systemic cytokines are increasing. They will influence the local microbiota in the periodontitis.
But in title, you have mentioned about immunosuppression also.
Yes, ma'am. Immunosuppression also I have mentioned, ma'am.
So how you can correlate this immunosuppression and cytokine storm?
Ma'am, in COVID-19, there is a increase in cytokines, ma'am. There is decrease in BMP cells, ma'am. Because of which some immunosuppression will be there.
So both are related to dysbiosis. That is your conclusion.
No, ma'am. You have asked the immunocompression. How there is immunocompression? That I am telling you how it is like.
What is the most recent periodontal pathogenesis model?
That I don't know. No.
Okay, Dr. Swati.
Yes. Can you tell me what dysbiosis is? What is dysbiosis?
Dysbiosis means altered microbiota in that area, ma'am. This biological microbiota will get altered. This thing in the local.
Okay, leave it. Okay, can you justify your statement that it is a two-way relationship? You told that COVID-19 and periodontitis both are both have a role over each other, means they have a two-way relationship. Can you justify it? How?
Yes, ma'am.
I think there are some network issues, ma'am.
Dr. Vijay, we can't hear you. Dr. Vijay?
Ma'am, can you hear me now, ma'am?
Yes, you can. Yes, you can answer my question.
Periodontitis is a low-level inflammatory condition, ma'am, from which it will release the inflammatory cytokines, which will influence the systemic condition chronically, ma'am. In the same way, systemic inflammation, it also influences the local periodontal environment, microbiota and local periodontal disease.
Okay, we can continue with the next.
Okay, sir. Thank you. Can we have the next slide, please? Yeah, number 189, who will be presenting?
Good afternoon, ma'am. I'm Dr. Tintu Natraj.
Yes.
I'm going to present the topic of the use of tuberosity connective tissue for root coverage and ridge augmentation. It's an alternative method to the palatal connective tissue harvesting techniques. By and large, many periodontists have been using this technique. I'm just going to a little more elaborately and emphasize the advantages of using the tuberosity connective tissue. The introduction of this the target is for how to harvest the tissue from the tube. Harvesting techniques, we are using the newer techniques of deepithelialization and graft trimming to effectively harvest appropriate dimension of connective tissue from the tuberosity region, so that sometimes there are distal pockets which are present, especially in younger individuals posterior to the second molar. So by using the tuberosity connective tissue, this distal pocket also can be eliminated. So it will be a dual purpose. So the methodology is you're obtaining the connective tissue harvest by distal gingivectomy or distal wedge technique. The distal gingivectomy is used when there is a lesser buccolingual dimension, and the distal wedge technique can be used when there is a greater buccolingual dimension. So with the distal gingivectomy technique, the graft is harvested with a 12 blade, and a single blade scalpel can be used. And the scalpel with a 1.5 millimeter separation, a split thickness approach where the blade is suggested. After the graft have been harvested with a 12 number blade, it can be further adjusted with a double blade scalpel. Fileting can be accomplished freehand or on a moistened gauze, so that by doing the fileting, the graft can be made into smaller portions, so that it will be accordingly it can be used for the multiple sites. And deepithelialization and graft ringing is accomplished using a book or butterfly technique. This technique has been given by Goddard and Todd et al. Along with Miller et al. And in the year 2018. So these authors have used this book technique, so that the connective tissue after harvesting, it is opened like a book, and then it is applied to the recipient site. Here in their paper, they have not more targeted about the recipient site, but how the trimming and deepithelialization they have given more importance. So when the initially harvested CTG is more than 7 millimeter thick, it can be sliced further into connected connective tissue graft in a snake or trifold configuration, or separated into multiple individual connective tissue grafts so that it will attain a 1 to 1.5 millimeter thickness. The advantages of the tuberosity connective tissue gives a denser lamina propria, which is of higher quality. There is a thinner epithelial layer, greater volume of connective tissue. There is no adipose or glandular tissue, and
excuse me, ma'am. Doctor, the time is up. Should we go on to the question and answer session?
Yes, ma'am.
Okay, what are the advantages and disadvantages of this technique compared to the palatal connective tissue?
compared to the palatal connective tissue, the patient-related centered outcomes, when we see the patient morbidity and pain, whatever the patient experiences, is a little reduced from than when we compare to the tuberosity. It is a remote area. The tuberosity is a remote area, so the patient will have during chewing and all, they will have less discomfort when the tuberosity, and as in this tissue is mostly it is more bulbous, and it is present in excess, in especially in young individuals. Those who are in the third molars are not erupted, and so when we use this appropriately with the right case selection for the patient, it is a very good alternative for palatal connective tissue graft.
Any anatomical limitations?
The greater palatal nerve is there, with only the branches of the greater palatal nerves can be seen, and we can also come along with the
okay, no. Dr. Swati.
Yes.
Ma'am, I'm unable to hear you.
Yeah, doc, you just told that patient feels discomfort in connective tissue graft, and no discomfort is less in this tuberosity graft.
Yes, ma'am.
So you are talking about connective tissue graft or free gingival graft? Because if you are harvesting a connective tissue, in any case you are not leaving the wound open, no? We are suturing it back. So how come that? In what ways the discomfort is there? Like, because in any case you are creating a second site, whether
it is
the tuberosity or you are taking it from palate.
Yes, ma'am. But it is here, if it gingival distal gingivectomy technique is used, it can be left open. Only if the distal wedge technique is used, it is sutured. So that is only by primary intention. But because of the palate is a more chewing area, compared to the tuberosity. So that's why I said like it is less. It will be less giving.
Like, because according to me, if we are doing a free gingival graft, then yes, okay,
yes, we have left
the
open. Yes.
But in connective tissue graft, like, anyways, harvesting from tuberosity is also not very easy. Yes. So it's much more simpler in cases of connective tissue graft, which can be easily harvested.
Yes, ma'am. Connective tissue has more genetic resemblance to that, but it's just an alternative. It is proposed. The gold standard technique is always a palatal harvest.
And this is your review article, or this is the case done by you?
Based on this article, we have done a case. We have attempted, but we have not done the follow-up. Thank you.
Thank you. Could we go to the next slide, please? Yeah, Dr. Nashma. Are you here?
Yes, ma'am.
Yeah. Could you just on your camera and begin with your presentation?
Sure, ma'am.
Can't hear you.
Ma'am?
Yeah.
Am I audible now?
Yes, you're audible.
Yeah, good morning to all the respected judges, ISP members, and my fellows, mates. Very good afternoon to one and all. My topic for today's review poster is sonodynamic antimicrobial therapy, which is a new kid on the block to combat periodontal pathogens. So let us go on to the historical aspect of sonodynamic therapy. Sonodynamic therapy is a technique which was introduced by Uemura and other scholars in the year 1989. And in 2009, a study conducted by Zuopeng et al. Stated that it would be a novel antimicrobial strategy. So let us see what it is. Sonodynamic antimicrobial therapy is a technique which relies on the ability of low power ultrasound to activate sonosensitizers as the chemical agents which are sensitive to sound waves and triggers the generation of reactive oxygen species to achieve cell death in microbes. There are two hypotheses which was put forward to support this therapy. It is a sonoluminescence hypothesis and a pyrolysis hypothesis. According to the sonoluminescence hypothesis, it is the emission of burst of light from imploding internally generated enlarged bubbles in the liquid media when excited by the sound waves. And the pyrolysis hypothesis states that there will be a production of temporary heat and reactive oxygen radicals in the surrounding tissues, which would
Dr. Nasma, we lost your voice.
I think she's disconnected.
Sorry, ma'am, there was a connection issue, ma'am. Am I audible now?
Yes.
Ma'am? Yeah.
Yes,
So
yes,
the advantages of this technique. Yes, ma'am. Yes, ma'am. So the advantages of this technique are excellent penetration properties. It's a non-invasive type of a treatment modality with less side effects and accuracy. The armamentarium required is a sonosensitizer, which can be an antimicrobial agent like levofloxacin or a dyes like hematoporphyrin user. And the clinical implications would be, it would be a potential synergistic antimicrobial effect along with different sonosensitizers. It has been tried in various zoological experiments, and it is reported that it could treat periodontitis mediated by hematoporphyrin monomethyl ether. And potential clinical applications would be, it can be used in depigmentation procedures if the periodontal aspect is seen. Because in the medical field, they have already tried it in dark pigmentation nidus. So maybe in future, we can try out in the depigmentation procedures in the periodontal aspect. So I would like to conclude that it would be a novel treatment modality. I mean, as an adjunct to the
Dr.
conventional
Nasma, I
treatments
think we will go to the question and answer session. We're already out of time.
Yes, ma'am.
Are there any particular equipments available to do this therapy?
Ma'am, it requires a simple armamentarium, ma'am. Ultrasound transducer, a sonosensitizer, which
Ultrasound,
can be an
how will
antimicrobial
you
agent.
transduce ultrasound? What is the equipment required?
It's a small ultrasound transducer, ma'am. The one which we normally use for ultrasound, the same equipment. Scanning, yes, ma'am.
Oh, is it cheap? Do you think it's cheap?
I
A
don't
very
know
simple
what the cost.
instrument you mentioned. What is the role of?
It's a very expensive instrument, ma'am. Actually, it's expensive.
What is the role of levofloxacin? You mentioned in the armamentarium, levofloxacin. What's the
Yes,
role
ma'am.
of
It's a sonosensitizer, ma'am. It's a antimicrobial agent which is sensitive to sound waves, ma'am. So it can be implanted in the area where we require treatment, ma'am. So that it would be, when we irradiate that area with ultrasound waves, it would be sensitive to that.
Okay, Dr. Swati.
Yeah, you just told we can use it in periodontitis.
Yes,
Okay?
ma'am.
We
Yes,
can
ma'am.
use it. So do we need to require, do we need to do scaling and root planing, or it's not needed? It's an adjunct to scaling and root planing, or it's a replacement for scaling and root planing?
Ma'am, according to the studies which have been carried out, it's only a monotherapy which was carried out, ma'am. Only sonodynamic therapy was introduced. They have not mentioned any scaling or root planing done prior, ma'am. They have actually done it on rats, ma'am, experimental periodontitis cases in rats.
And how?
They have put ligature wires on the first and second molar areas and caused the experimental periodontitis to occur in rats, ma'am. And then after 10 days, they have euthanized the rats, and then histological viewing was done, ma'am, to determine the alveolar bone levels and whether they could actually treat the periodontitis experimentally introduced.
Thank you. Could we go to the next presentation, please?
Thank you, ma'am.
RPO 191 who will be presenting this.
Good afternoon, ma'am. Richa Verma this side.
Yes, you can start.
Good afternoon, respected dignitaries, my seniors and colleagues. The topic of my presentation is periodontal and systemic health, the interrelationship. Oral and periodontal health impact systemic health and vice versa. Various studies have underscored the critical importance of oral health to systemic health. Proposed mechanisms that mediate this connection between oral and systemic health include precipitating and predisposing factors such as genetic factors, example gene polymorphisms, environmental factors such as stress, habits such as smoking, and dietary habits such as consumption of high-fat food or highly processed foods, microbial dysbiosis, bacteremias, and an altered host immune response. These associations exist within a framework of chronic bacteremias, systemic inflammation, and disturbance of immune system. Coming to the relationship between diabetes mellitus and periodontitis, the association between diabetes and periodontitis has been a subject of extensive research over the years. A bidirectional relationship has been proposed. The mechanism is thought to be as follows. In diabetics, high glucose, advanced glycation end products, reactive oxygen species and bacteria lead to an altered host immune response, which includes altered response of cells such as neutrophils and macrophages, which results in release of pro-inflammatory cytokines such as interleukin-1, interleukin-8, which causes inflammation and causes enhanced bone loss and altered bone coupling, which ultimately leads to periodontitis. Inflammation has been proposed to be the connecting link between periodontitis and diabetes. Coming to the relationship between cardiovascular disease and periodontitis, oral pathogenic dissemination into the bloodstream leads to onset of cardiovascular diseases such as atherosclerosis, myocardial infarction, etc. This systemic dissemination of pathogens can lead to inflammatory response, both locally and systemically. Periodontal pathogens can directly invade several organs and tissues, including cardiovascular system, and there have been reports that have demonstrated that periodontal pathogens are also able to invade the arterial walls and colonize the atherosclerotic plaque. Certain mechanisms caused by bacteria can lead to aggregation of platelets and thrombotic clot formation. For example, Performonas gingivalis can lead to activation of ICAM, PCAM, and P-selectin, thus causing aggregation of platelets. Coming to the pregnancy outcomes altered by periodontitis, oral dysbiosis and pathogenic periodontal bacteria are considered to be associated with adverse pregnancy outcomes. Oral microorganisms have the capacity to invade the fetoplacental unit by hematogenous dissemination or by an ascending route from genitourinary tract. These infections trigger a direct inflammatory reaction leading to different adverse outcomes. The indirect mechanisms are mediated by inflammatory mediators locally producing periodontal tissues, which once dumped into the circulation may directly affect the fetoplacental unit, or by reaching the liver, may trigger a systemic inflammatory state through the release of acute phase proteins such as C-reactive proteins, which then impacts the fetoplacental unit. Periodontitis has also been thought to link with periodontitis has also been linked with metabolic syndrome. Mechanisms potentially linking obesity and periodontal disease. Metabolic syndrome, by the way, is a triad of obesity, hypertension, and hyperglycemia. Mechanisms potentially linked to obesity and periodontal diseases are adiposity associated. Yes,
we are done with the time. Can we start with the question and answer session?
Sure, ma'am. Sure.
What is metabolic syndrome?
Metabolic syndrome is a triad of hyperglycemia, hypertension, and obesity.
So what is a branch of periodontology that deals with this interrelationship?
Sorry, ma'am.
You missed out one important systemic disease. What is it? That is not mentioned in the poster.
Osteoporosis, ma'am?
No. Anything else worth mentioning? Which is one important systemic disease which is having high evidence for association with periodontitis.
Cancer, ma'am. Oral cancer. What is
Dr.
it?
Swati? Dr. Swati.
Sorry.
This was my question only, ma'am. This was my same question.
I shall read, ma'am. I shall
Okay. You go and read. It's okay.
Yeah, sure, ma'am. Thank you, ma'am.
Anyway, it was a nice arrangement of the poster.
Thank you so
and
much.
it was a good topic also. Topic selection was also good.
Ma'am, I wish I could really complete it, but thank you so much, ma'am.
Thank you. Could we go
Thank
to the
you,
next presentation, please? Yeah, Dr. Vikas.
Yes, ma'am. Good afternoon.
Yes, you can begin.
Good afternoon, respected teachers. Today my talk periodontal therapy. Laser, a device that stimulates atoms or molecules to emit light at a particular wavelength and amplifies that light, typically producing a very narrow beam of radiation. Laser, an acronym for light amplification by stimulated emission of radiation, invented by Theodore Maiman in 1916. As we go in the historical background, in 1917, Albert Einstein gave a theory of stimulated emission of the photons under proper circumstances. In the 1959, the principle of measure Sheklow and Towns stimulated the emission of the radiation by the microwave at the microwave frequency. And in the 1960s, the synthetic Rabi laser by the Maiman is given, and so on the further theories were producing in the further study, and on the basis of the affected, the type of lasers are divided on the basis of the affected to soft tissue laser, hard tissue laser, and on the basis of the laser medium which is used, solid laser, gas, liquid, and on the wavelength it is divided into the UV, ultraviolet range, visible range, and the infrared range. The laser has a three portion: the optical cavity and the tube and the narrow laser beam light. The first part is the optical cavity laser, the medium which is used, the solid, liquid, or a gas, and the second is portion of the laser is the optical cavity. Optical cavity contains the two mirrors at the both ends. One is the totally reflecting mirror, and third is the partially reflecting mirror, and third is the external source which pumps or excites the atoms or the photons in the medium of the laser. Laser light is unique, that is, it is monochromatic light of one specific wavelength. The laser light is delivered in the form of the continuous wave and the gated pulse mode, which is at the, they are acting on the target tissue at a, as we can see here in the diagram, that when a light is incident on the soft tissue, it gets absorbed and it shows the effects like on the tissue, like photothermal, photochemical, and the ablation effect. Clinical application of the laser in the treatment, in the periodontal treatment, are laser assisted new periodontal procedures, gingivectomies and the gingivoplasty, gingival depigmentation, treatment of periimplantitis, and the fractonomies procedures. Done are with the help of the lasers. Advantage of using lasers in the periodontal therapy is the less pain, less need for the anesthetic, and advantage for the medically compromised patient: no risk of bacteremia, excellent wound healing, no scar tissue formation, bleeding is controlled, and usually no need for sutures, use of fewer instruments and materials, no need for autoclaving, or economically advantage, ability to remove both hard and soft tissues. With the coming on the conclusion, with the conventional mechanical instrument, complete access and disinfections may not be achieved.
Yeah, we are done with the time. Should we go to the question and answer session?
Yes,
Dr. Vikas, why you say that lasers are minimally invasive?
Okay, sure.
Why you say that lasers are minimally
invasive, ma'am, because today in
your
minimally invasive,
you know.
Yes, ma'am. Not heard properly.
Is it minimally invasive? Lasers are minimally invasive?
Yes, ma'am. I say it minimally invasive in the periodontal therapy, as we are using the laser surgery nowadays less in the treatment. Furthermore, we are advancing with the technologies, and laser helps in the minimally invasive periodontal, as conventional periodontal therapy does not remove the proper disinfections and the scaling and root planing, debridement of the tissues. As with the laser, we remove the so for bacteremia.
Is it the concept of minimally invasive surgery?
Yes.
Then you said it's economical. Do you think it's economical compared to the conventional surgical procedures?
No, ma'am, it's not so much economical, ma'am. It is costly treatment.
Okay, Dr. Swati.
So which laser you were talking about? Can you tell me which laser?
Ma'am, iridium and the NDYAG, neodymium, yttrium, aluminium, and the garnet laser, ma'am, and the CO2 lasers we are using in and the semiconductor diode lasers.
Those lasers can never be economical. If you are talking about,
yes,
and
ma'am.
is soft tissue laser? What is soft tissue laser? Or
Soft
diode
tissue laser. Ma'am, soft tissue laser is which is used in the minimal soft tissue, such as the degranulation, debridement of the tissue. Soft tissue used to help in the incision and the curatives. Soft tissue. Okay. Thank you.
Thank you. Could we go to the next presentation, please? Dr. Anshuma, yeah.
Ma'am, am I audible, ma'am?
Yes, you're audible. You can begin.
Good afternoon, respected judges. The topic that I'm going to present today is mechanism of increased mortality in hemodialyzed patient with periodontitis. Actually, as we all know, that the mechanism of increased mortality in cardiovascular patients has been already shown by Bexton. So this is a recent concept that has been put forward by Sadi et al. And Sionka and Sharma et al. So the central process leading to premature death lies primarily in an inability to eliminate bacteria and their metabolic products from the blood despite hemodialysis. So the P. gingivalis, which is a primary etiologic agent causing chronic periodontal disease, has a capacity for multimodal adherence, intercellular invasion, secretion of gingipins, cystine proteases, and intracellular invasion into the gingival epithelial cells, phagocytic cells, dendritic cells, fibroblasts, and endothelial cells, which leads to focal infection, bacteremias, and sepsis. The weak immune response of the CKD patients triggered, but is unable to prevent endocarditis or sepsis, having been rendered inefficient by the presence of the local infection in the periodontal pocket and persistent degradation products from the bacteria and macrophages. Also, renal insufficiency, even during dialysis, lead to inability to eliminate bacteria and their metabolites from the blood. This leads to change in fluid dynamics and deterioration of the blood rheological parameters with increased shear stress, shear rate, yield stress, red blood cell deformity, and leukocyte endothelial cell adhesion. This all leads to aggregation of the blood elements, increasing whole blood viscosity, disturbed capillary lymphatic dynamics. Also, as we have seen that certain markers like C-reactive protein, serum creatinine levels, and pro-inflammatory cytokine levels also are affected, which affect the nutrition by inducing proteolysis in the muscles, increase energy expenditure, and inhibiting appetite, leading to decrease in serum albumin and ferritin. All this leads to worsening of the concomitant cardiovascular disease such as atherosclerosis, thromboembolic disease, ischemic heart disease, peripheral vascular disease, hypertension, vascular disease, or cardiomyopathy. All this leads to increased mortality in hemodialyzed patients. So the ultimate, what's the conclusion is, it's not only the periodontitis, but it's a combined effect of the multiple factors, or periodontitis actually act as a risk factor, which get aggravated in some special cases, which leads to increased mortality in hemodialyzed patients. That has been shown by different authors like Sionsis and then Sharma et al. And latest review in 2021 has been given in which they have clearly shown that the different mechanism has lead to increased mortality in CKD patient or chronic kidney disease patients. Thank you, ma'am.
Are there any original studies done in the topic other than the review articles?
Yes, ma'am. Actually, latest, ma'am, Delbobby had done the meta-analysis regarding the CKD and periodontitis, and they have clearly shown that after doing the scaling and root planing, even even if you are not doing the surgical treatment, only scaling and root planing will reduce the chances of or worsening of the CKD effects by more than 20 to 30%. Also, they have shown that the different type of markers like HSCRP, serum creatinine and pro-inflammatory cytokines has been reduced. It has been shown that the glomerular filtration rates readings has been decreased after doing just 2 or 3 visits of SRPs. It has been shown that their effect remains for a short time only, like for only 3 weeks only. But if we are going to continue it for a longer duration, then this will surely shows a long-term benefit for these patients. This is a modifiable type of risk factor.
What all precautions you will take when you perform periodontal therapy for a hemodialysis patient?
Yes, ma'am. Actually, in these patients, if a patient is already going for dialysis, then usually they are the blood stoppage won't be there, because usually during dialysis, patient is usually treated with heparin. So in these patients, we have to tell the doctor who is doing dialysis not to give heparin during that particular session for which we are going for SRP. Also, in these patients, the chances of getting calcium deposition is more as the deposition of the urea increased, as the presence of more urea in the blood of these patients, the increase of calcium leads to rapid deposition of calculus in these patients, ma'am.
It may not be possible to stop dialysis in a patient with kidney disorder just for periodontal therapy. Which is the best time that is advisable to do periodontal therapy after dialysis?
Ma'am, it's always better to go for periodontal treatment after dialysis, because then the patient's different signs like nitrogenous waste products or other toxic products get decreased. So it's always better to get it done after going for dialysis, because if you are going to do it before, already toxic products has been increased, and if you are going to do SRP during the session, before the dialysis session, then chances of bacteremia and sepsis get increased.
There is one more danger with doing periodontal therapy immediately after dialysis. What is it? Other than what you mentioned, there is one more. That is the most important thing. Patient may be in under medication, so you have to modulate.
Yes, ma'am. There is one more point, ma'am. Because of the drugs that are being taken by the patients, masking of the signs and symptoms of the disease usually occurs. So patient won't get the signs and symptoms of the disease because of the certain type of drugs therapy or immunosuppressive drugs, or the removal of the toxic products from the body. So it happens usually, ma'am. The masking of the signs and symptoms usually occurs. So patient will come to know about the disease in later stages, ma'am.
What about anticoagulants?
Yes, ma'am. Yes, ma'am. Patient is already taking. Yes, ma'am.
That is the point I want to make clear. Dr. Swati, any more questions?
I think we can continue with the next one. It's okay. It was a good presentation, though.
Thank you. Thanks a lot, ma'am.
Yeah, thank you. Can we go to the next slide? Dr. Samiksha?
Yes, ma'am. Am I audible?
Yes, you're audible. You can begin with the presentation.
Good afternoon, everyone. My topic of today's presentation is hyperbaric oxygen therapy, that is healing with pure oxygen. As we know, hyperbaric oxygen therapy may be defined as the therapeutic administration of 100% oxygen at an environmental pressure greater than 1 atmospheric absolute. It is indicated in skin grafts and flap, osteomyelitis of jaw, acute necrotizing ulcerative gingivitis and aggressive periodontitis, osteoradionecrosis, and as an adjunct therapy for the placement of the implants in the irradiated jaws. There are 2 types of chamber used for this therapy. One is monoplace. This is designed for single occupancy and constructed of acrylic, having pressure capability of 3 atmospheric absolute, and it is compressed with 100% oxygen. Second one is multiplace. In this, 8 to 12 patients can be treated at one time. It is having pressure capabilities of 6 atmospheric absolute. Now its effects on periodontitis. It will help in pocket reduction, reduce the periodontal pathogens, promote the periodontal healing, fibroblast proliferation, increase leukocyte oxidative killing. In implants, it will help in angiogenesis, stimulate effective bone formation, and have positive effect on osteointegration. Now the mechanism of action. First one is hyperoxygenation, that is increase in dissolved oxygen in plasma. This can be used to treat crush injuries and compartment syndrome and graft salvage. Second one is decrease bubble size, as according to Boyle's law, when we increase the pressure, the volume can be decreases, so it can be used to treat gas embolism. Third one is generation of oxygen free radicals, as hyperbaric oxygen therapy generate oxygen free radicals which having bactericidal and bacteriostatic effects on periodontal pathogens. Next one is angiogenesis. Hyperbaric oxygen therapy enhance angiogenesis by increasing vascular growth factor, vascular endothelial growth factor, which will help in angiogenesis. Last one is enhanced fibroblast function, which will help in wound healing. Now, there are various complications by this therapy. First one is oxygen toxicity. Oxygen toxicity having two effects. First one is effects on central nervous system, and second one is on lungs. Second one is barotrauma. It will cause barotrauma, that is trauma because of pressure in the middle and internal ear. And third one are ocular defect, that is myopia and cataract growth. There are various ways for providing oxygen. Number one is monoplace, as we already discussed, that is monoplace chamber. Second one is gas mask, and third one is topical.
Doctor?
Thank you, ma'am.
Yeah. Can you go to the question and answer session?
Yes, ma'am.
Is it possible to apply hyperbaric oxygen in a clinical setting?
No, ma'am, there is a special settings required for this.
So is it cost effective?
No, ma'am, it is not.
Dr. Swati.
How will it play a role in treating periodontitis?
Ma'am, at the base of the pocket, there are anaerobic microorganisms. When we treat it with hyperbaric oxygen, it will create oxidative radicals, which will kill the anaerobic microbes by oxidation of protein and membrane lipid oxidation and damage DNA.
It's okay, but do you really feel it's good for a clinical? It is good for clinical practice. Like when dentists.
Ma'am, it can be used as an adjunct with scaling and root planing.
When you have to do scaling, see. So only thing is that we can use our hands. We can do scaling and root planing. We are removing the etiology. Then I think adjunct are many other things which are cost effective. We can use it as an adjunct. Why to go for hyperbaric oxygen therapy? So it's just my view. Many authors can say like, okay, you can use it. It's a newer technique, but when we are doing proper scaling and root planing, if we do proper scaling and root planing, firstly, adjuncts are rarely needed. And then for adjunct, we have many other things also. So why to opt for hyperbaric oxygen? That's the clinical application for this is actually a big question mark.
Yes, ma'am.
Yeah, thank you. Can you go to the next presentation, please? Dr. Neha? Dr. Neha? Will be presenting this. Dr. Neha, Dr. Shreya here. I don't think anyone is here. So should we go to the next slide?
Yes, doctor.
Okay. Dr. Garima? Dr. Garima? Next slide, please. Dr. Trina?
Good afternoon, ma'am.
Yeah, you can begin with your presentation.
Ma'am, am I audible?
Yes, you're audible. You can begin.
Okay, ma'am. Good afternoon, everyone. Today, my topic for poster presentation is a very common problem which is seen in our developing country like India. It is bad breath or halitosis, what we also know as oral malodor. It is a condition which is characterized by unpleasant odors emanating from the oral cavity, which is linked to the presence of volatile sulfur compounds. The conventional treatment methods include toothbrushing, tongue cleaning, use of chemicals like chlorhexidine, cetylpyridinium chloride. Modern treatment approaches are, as mentioned in this poster. Among this, the most advanced is the photodynamic therapy with laser or with dyes. Photodynamic therapy involves the use of a non-toxic light-sensitive device known as photosensitizer, which is combined with a visible light at a wavelength coinciding with the absorption spectrum of the photosensitizer, which then reaches a state of excitation after absorbing a photon and reacts with the oxygen of the medium to produce reactive oxygen species, which destroys the bacterial cells. The other approaches include probiotics, where living microbes are used, like lactobacillus. There are various chemicals which are also used, like chlorine dioxide, ozone water, propolis, licorice, and curcumin. Also, herbs like green tea, which contains catechins, aloe vera, tulsi, clove, all these are used. So, we can conclude from all this that the recent treatment modalities on combined approach with the conventional treatment modalities are effective in reducing the volatile sulfur compound level and thereby reducing the halitosis significantly. Thank you.
Dr. Trina, what is the dye?
Yes, ma'am.
Bixa ornella. You have mentioned Bixa ornella in photodynamic therapy. What is the dye?
Yes, ma'am. Ma'am, it is basically a plant found in Brazilian area. From the leaves of that plant, a dye is extracted, and that dye is used in the treatment of this halitosis.
And
in the
what is the
drug
advantage
form or
of
in
that?
powder.
What is the advantage of that herbal molecule in
Ma'am,
treating malodor? Are there any specific advantage for this herbal compound in treating malodor?
ma'am, it is basically to see the effect of herbs combined with photodynamic. Photodynamic can be with laser or can be with dyes. Just to see the effect of this dye, any natural product can be used for
Okay, where will you
this
apply
treatment.
this product?
Ma'am, it is with the photodynamic or with laser. I
Okay,
can use
that I understood, but where will you apply it?
Yes.
In photodynamic therapy for treating malodor, where will you apply this dye?
Oh,
In picture, what you have shown is application for the tongue.
Yes, ma'am.
Are there any particular sites where you can apply?
Yes, ma'am. On the palatal aspect also it can be applied.
Okay. Dr. Swati?
It's okay. I'm thorough with this question. Can you tell me your UID? It's 197.
Yes,
Tina.
ma'am.
Okay.
Yes, ma'am.
It's 197.
Good. It was good.
Thank you, ma'am.
Yeah. Thank you. Can you go to the next presentation? Dr. Dikshita, RPO 198. You're not, we can't hear you clearly. No, there is some disturbance from your side. No. We can't hear you clearly.
No, Dikshita, Dr. Dikshita, you are not audible. There is too much disturbance from your side.
Dr. Dikshiti, sorry. Dr. Dikshita?
Yes, ma'am, I'm audible.
We can't hear you. There's a lot of disturbance.
Dr. Dikshita, you can change your network connection. And I think, ma'am, if we can...
I think we will go to the next presentation and we'll get back to Dr. Dikshita later.
Yes, ma'am. Yes.
Yeah. So can we have the next presentation? PO199. Dr. Sharma, are you here? (199). Dr. Sharma, are you here? Let's go to the next presentation.
Hello, ma'am, am I audible?
Again, there is disturbance on your side.
Am I audible?
Yeah, now you're much better. Yeah.
Okay. Good afternoon, everyone. In this presentation, I have tried to summarize the recent advancements in the field of implant dentistry, which will help us to handle the implants more effectively and efficiently. Like in the diagnostic imaging, technologies like dynamic navigation have been developed, which uses real-time tracking technology that tracks the dental drill and the patient position throughout the implant placement procedure. Then Simplant is a software program that helps us to create a custom guide that will aid in the precise placement of the dental implants. Then advancements in the computed tomography includes multi-slice helical CT, which offers a higher resolution and accuracy of images. Then microtomography, it also provides a higher resolution of images, but with a slice distance of only 4.4 to 11 micrometer. Then in implant materials, zirconia have been used as an alternative to titanium, especially in the anterior aesthetic region, as it is a cream or light gray in color, so it is aesthetically more pleasing. Then carbon fiber reinforced composites are also used, and its density is close to the bone, so it is it helps in the better stress transfer and act as a shock absorber. Coming to the surface modifications, bone morphogenetic proteins and hydroxyapatite coatings are done to enhance the osseointegration. Then ligaplants, it is a new approach, which is a combination of the pedial ligament over the implant biomaterial. So it mimics the natural tooth, and it gets firmly integrated without the interlocking and without being in direct bone contact. Then in the implant designs, mini implants, they are fabricated with a reduced diameter of less than 3 mm and a shorter length. Transitional implants are also developed to support the provisional fixed restoration during osseointegration phase of the definitive implant. And short implants, they can be used in cases of atrophic alveolar ridges. Riva implants they are designed with an inner sealing screw that could serve as a drug delivery system or a possible endoscope. Then in the surgical techniques and the implant planning, zygoma implants, they are used as an alternative to the bone grafting in the extremely resorbed maxilla, and the densa bud, they are used for the densification that condenses the soft tissue laterally and apically, leading to the higher bone density and finally implant stability. To conclude, with the recent advancements, the success rate of the dental implant have been steadily improving, making it more acceptable by the patient and the clinician. However, more long-term studies and the clinical trials are needed. Thank you, ma'am. Hello.
Okay. Dr. Farheen, what is the advantage of liga plants?
Ma'am, it mimics a natural tooth. So it will prevent the recession and the bone resorption that usually happens around the conventional implants.
What type of attachment you are getting in case of liga plants?
Ma'am, in one of the studies which I have read that it was done on the rat tibia, they have found that there was a pedial formation, ligament, proper pedial ligament formation, and even a tissue, cemental tissue was also seen around the liga plant.
So does it give any added advantage compared to the usual osseointegration that's happening when you have a PDL?
Yes, ma'am. If it is a PDL, there won't be a direct transmission of the masticatory force to the bone, and thus it will prevent the resorption.
Okay. Dr. Swati?
Yes, Dr. Farheen, it was a nice presentation.
Thank you, ma'am.
I think you have covered most of the aspects. So good. It was good.
Thank you, ma'am.
Thank you.
Thank you. Can we go to the next presentation? Yeah, can we go to the next presentation, please? Yeah. Dr. Rita?
Yes, ma'am.
Yeah.
Am I
Can you
audible?
begin? Yes, you are audible. Can you begin the presentation?
Yes, ma'am. So, good afternoon, everyone. My topic for the review presentation is salivary biomarkers in periodontal diagnosis. So, early detection of a disease plays a crucial role in a successful therapy. Periodontitis is one such disease that can cause a serious destruction of a periodontium, for which early detection can be key to a better outcome of the treatment. But unfortunately, all the clinical findings and detection were detected after major destruction has already been occurred. So, to overcome these challenges, researchers are devoted to find biological markers. Those will reveal a hidden lethal threat before it's gone too far. So why saliva? Because it's a reservoir of potential biomarkers for periodontitis. And coming to its advantages, it is easily accessible and there is no issue with the availability of saliva. Moreover, it requires is an easy non-invasive procedure of collection. It can be collected by a passive drilling method in a graduated pre-wet vial, or by using a cotton swab, cotton roll, gauze, or filter paper, etc. Then the collected saliva is centrifuged and the supernatant part was extracted for analysis using proteomic and transcriptomic analysis. Now, coming to the biomarkers present in the saliva, they can be classified into broadly into specific and non-specific. Specific are those the presence of which determines specifically the present condition of the periodontium, like the immunoglobulins A and G, IgA and IgG. In studies, it has been seen that they particularly increase in presence of bacteria from the red complexes like P. gingivalis, Treponema denticola, and Acomitans. And there are also various enzymes present in the saliva, like lysozymes and peroxidases, that can also be an indicator of the periodontitis. Now, coming to the inflammatory derivatives of the soft tissues, like the prostaglandin E2, interleukin-1 beta, interleukin-6, occult blood, MIP-1 alpha, etc., are also there, which can indicate ongoing periodontal status. And also the specific ones that are present in the alveolar, that are derived from the alveolar bone, are the MMP8, 9, and then pyridinoline cross-linked telopeptide 1. Then sclerostin is also a recent one that has been discovered, and there are also some non-present, like the mucin, lactoferrin, and different growth factors like vascular endothelial growth factors, etc. So to conclude, saliva possesses a concentrated pool of biomarkers that can revolutionize the next generation of the diagnostics with due course of time in future. Thank you.
Dr. Rhythm, can you mention some point of care devices for salivary diagnosis?
Ma'am?
Can you mention the name of some point of care devices for salivary diagnosis? Am I audible?
Point of yes, ma'am. Ma'am, I didn't get much the name actually.
What is LOC?
Ma'am?
LOC? LOC? Okay. Dr. Swati?
Ma'am, I was about to ask what is lab on chip, and then okay, so I think you should be aware of all these things, and actually what are the commercially available brands for all those things. You should know. Okay. Okay. Thank you.
Thank you.
Thank you. Can we go to the last presentation, please? And then we will get back to the earlier two. Dr. Shweta, are you here? Dr. Shweta? 202? Dr. Shweta? RPO 202, are you here? I thought I just saw her name here. Dr. Shweta? Dr. Shweta? RPO 202? Okay, RPO 198. Who was presenting that?
I'm Dikshita.
Dikshita, are you back with a good network? So do you want to do your presentation?
Yes,
Can
ma'am,
we
yes, ma'am.
have 918, please? Yeah, thank you so much. Yeah, begin with your
Am I audible,
presentation.
ma'am?
Yes, you're audible now. You can begin.
Okay. Good afternoon. So today's poster presentation is on the topic of titanium dental implants, a boon or ban. So the use of dental implants in the treatment of complete and partial edentulism has integral treatment modality. Titanium, it is a metal with good biocompatibility and most frequently used biomaterial for construction of dental implants. This is because of the formation of titanium dioxide layer, which is high resistance to corrosion. But despite of the high resistance and biocompatibility, corrosion of titanium implants can still occur in the oral environment. Corrosion process leads to physicochemical alterations on implant surface, which disrupts the titanium dioxide layer, and this may facilitate dissolution. So there are number of factors associated with dissolution, like there may be bacterial colonization, low pH, presence of anions, cations, amino acids in the saliva, which will increase the dissolution process. Also, high temperature, poor oral hygiene, smoking habits, and acidic food products will aggravate the process. On implant placement, there are many immune responses like inflammation, epithelial cell necrosis, DNA alteration, fibroblast activity alteration, and bone resorption. So chronic inflammation will slowly lead to progressive osteolytic process with loss of bone around implants. On the other hand, titanium and its alloys are sensitive to tribocorrosion. Iron particles released as a consequence of wear or friction is called as tribology. So when this corrosion process occurs in combination with the tribological process, that is called as tribocorrosion. And when this tribocorrosion occurs in a biological system, that is in the human body, it is known as biotribocorrosion. So in the last few years, zirconia dental implants has emerged as an alternative for titanium implants. There are some beneficial effects of zirconia, like it is white in color that will mimic the natural tooth. Also, bacterial colonization around zirconia is found to be very less as compared to titanium. and zirconia is found to be more biocompatible as compared to titanium. Also, we can test for titanium toxicity or allergy by MELISA test, where patient blood samples are collected and allowed to react with the allergen. This test measures the hypersensitivity to numerous metals by placing the metal with contact with the WBC of person being tested and then monitoring the reaction. Hence, to conclude that although titanium has great success rate, but titanium toxicity, corrosion and allergy are also not very rare. So zirconia can be considered as better alternative, and it is more biocompatible and aesthetically pleasant. Thank you.
Okay, Dr. Dikshita, what are the problems associated with titanium toxicity?
Ma'am, there will be dissolution of the titanium ions, and there will be debris which will be collected in the peri-implant tissues, and this will lead to osteolytic process. There will be mucositis, and also there will be peri-implantitis.
Other than that, will it have any systemic effect?
Yes, ma'am. There is a systemic effect like yellow nail syndrome. So basically, the nails, it is a syndrome. There are three diseases which makes this syndrome. The first one is there will be lymphadenopathy, and then there will be respiratory problem, and there will be yellow nail. The nails become brittle and more prone to fracture, and it will be very painful condition.
Okay, how is MELISA done?
Ma'am, actually the patient blood samples are collected and they are centrifuged and stored for 5 days. Then the patient WBCs are collected and they are allowed to react with the metal. The number of proliferating lymphocytes are measured by two methods, by two methods like microscopic examination or by radioisotopic examination.
So is it zirconia an advantageous material in terms of this toxicity? You said
Yes.
the color is actually aesthetically pleasing. It's more
Yes, ma'am.
biocompatible, but what about the toxicity?
Ma'am,
Is there any chance
zirconia,
for toxicity for zirconia?
no, ma'am. As compared to titanium, zirconia is less toxic.
Are there any studies like that? Comparing this toxicity level of zirconia with titanium?
Yes, ma'am. I found out one study by Olimedo et al. Who told that zirconia is more biocompatible.
Okay, Dr. Swati.
First of all, I would like to say it was a nice presentation, Dr. Dikshita. I just wanted to ask one thing, like you said peri-implantitis. Okay,
Yes,
is peri-implantitis actually related to material? Like you were talking about titanium and zirconia, okay? So peri-implantitis is related to material or is it related to something else?
Ma'am, it is also related to bacterial colonization, poor oral hygiene, and also the debris products of the titanium.
It is mostly related to it. So I think in relation to peri-implantitis, the material doesn't make too much of difference, whether you use titanium or you use zirconia. So
yes, ma'am.
It was a nice presentation too.
Thank you, ma'am.
Thank you. Now, who was presenting 199? Are you here?
Yes, ma'am. Am I audible, ma'am?
Yes, you're audible now. So can we have poster 199, please? Yeah, thank you. You can begin with your presentation.
Yes, ma'am. Should I begin?
Yes, begin with your presentation.
Okay. Good afternoon, ma'am. So I would like to introduce my topic, ligaplant, new dimension in implant dentistry. So in the recent years, we've seen that the replacement of the missing tooth with implant have gained immense popularity. And as you know that the natural tooth is connected to the bone through periodontal ligament. But when it is replaced by implant, it becomes directly connected to the bone by osseointegration. So this means that implants are functionally ankylosed to the bone without periodontal ligament support. This transfers excessive stress to the
We've lost your voice, doctor. There is some connectivity issue probably. We can't hear you.
Am I audible, ma'am, now?
Yes, now you're audible.
Okay, ma'am. As the osseointegrated implants, they transfers excessive stress to the surrounding bone, which results in marginal bone resorption. So to resolve all these problems, how about a periodontal integrated implant? That is an implant that is suspended in the socket through periodontal ligament.
We've lost your voice again. We can't hear you.
Ma'am, is it fine now?
Yes.
Okay, I'm sorry for the interruption. Ligaplant, it is the combination of the periodontal ligament cells with implant biomaterial. So the first study here under clinical trials, we can see that ligaplants are implanted in the premolar region in dogs, and on its ground section, it was observed that a periodontal ligament-like tissue had formed with the perpendicular fibers between the implant and the alveolar bone. Also, onto the right, the arrow shows a new layer of a dense collagen covering the ligaplant. Now, on the second study, we can appreciate in the radiograph, there is a root fracture to respect to 3/4 and a bone defect mesially. So, this was extracted, followed by the implantation of ligaplant. 42 months after implantation, we can appreciate that the periodontium has partially reconstructed with a fairly regular desmodontal space and reinforced bony demarcation around this space. So the other studies also showed similar results, indicating that the anchoring occurs via a functional periodontal ligament and not via osseointegration. So we can, the main advantage is that it mimics the natural anatomy of the tooth. Also, the presence of a periodontal ligament around implant, it allows a proprioceptive mechanism and also enhances the repair and regeneration of bone defects. Now, how do we exactly get this ligaplants? For the preparation, tissue engineering of the periodontal ligament cells are done. So basically, we extract the cells by scraping the middle third portion of extracted tooth root and culture it in a bioreactor. After that, we coat the cells onto a hydroxyapatite coated titanium implant. But still further research and long-term studies are required to uplift this development. But we can conclude that ligaplants could be the beginning of a better future and lead to a new dimension in implant dentistry. Thank you.
Okay, it was a good presentation, Dr. DAY-3.
Okay. Thank you, ma'am.
What is the prerequisite for doing a ligaplant? As of now,
usually,
do you require anything? Can you do it in every case?
Yes, ma'am. We can do it in every case, and it is usually preferred if there is any bone defect present, because in the normal conventional implants, we have to first fill the bone defect and then go for the implants. Whereas in ligaplant, it induces the bone regeneration as well. So you can directly place into the areas of bone defect and get the advantage of the periodontal tissue around implant, also the defect fill.
You're not getting my question. Can you do it in a staged implant placement or in a later stage implant placement where you get the patient with edentullousness? Can you do it?
Yes, ma'am. Yes, ma'am.
Where will you get the periodontal ligament from?
Ma'am, it can be cultivated in a laboratory environment. Like, it is not necessary that it has to be obtained from that person itself. It can be like, as it is a lab process. So from any extracted tooth, we can isolate the periodontal ligament cells, culture it, and then coat it in the titanium implant.
Okay, it's not autologous periodontal ligament. Then what are the problems associated with that?
Ma'am, it's not necessary. Yeah. Yes, ma'am.
Are there any problems associated with taking periodontal ligament cells from other patients, other individuals?
Ma'am, as of now, all the clinical trials showed, ma'am, host defense mechanism could be a problem, but as of now, the clinical trials showed positive results.
Okay, Dr. Swati.
Yeah, so the clinical trials you came across were of the same, the PDL derived from the same patient, or have you gone across any case report in which the PDL cells have been obtained from some other patient and transplanted into a different patient?
Yes, ma'am. Ma'am, both studies are available. The studies which I have shown, one of the study in the fourth study, which is the radiograph, here it was obtained from other patient, and other studies are autologous.
So it was an Indian study, or?
No, ma'am. No, ma'am. No Indian studies are done till now.
Okay, thank you. Good presentation.
Thank you, ma'am.
Thank you. Now, could we go to the last one, 202, the last presentation? Yeah, Dr. Shweta, are you here? Dr. Shweta, 202?
Yes, ma'am.
Yeah, could you begin with the presentation, please?
Yes, ma'am.
Yeah.
Respected chairpersons present, I'm Dr. Shweta. My topic, polymeric nanoparticles in drug delivery system, nanomedicine in periodontics. Periodontitis is an inflammatory disease affecting the alveolar supporting structure, leading to the bone loss and the soft tissue loss. So routinely conventional and chemical treatment, what we are giving has many drawbacks of burst release of the drug or damage to the cells or poor therapeutic effect at the released site. To overcome this, excellent auxiliary methods of local drug delivery system using polymeric nanoparticles has been used in inaccessible areas. Nanomedicine uses nanotechnology to improve human health at a molecular scale. Nanoparticles are very small, with having large portions of atoms, molecules per unit per mass that may increase the biological activity. A good nanoparticle is designed to obtain a desired function at an appropriate site at appropriate time and to produce a good therapeutic response. Nanoparticles, polymeric based, are available in the form of natural or synthetic. Natural available is chitosan, whereas synthetic it is available in the form of polylactide, polyglycolide, and various other structures. Polymeric based drug delivery systems, they use carriers for the release of the drug, and these carriers are in the form of hydrogels, liposomes, microparticles, nanoparticles, nanospheres, conjugates, dendrimers, and etc. These vehicles carry the drugs, the various antibiotics, vaccines, then we have peptides, antibodies, enzymes, which are targeted at the location and provided accurate.
Doctor, we've lost your voice. We can't hear you. Dr. Shweta? Dr. Shweta, are you here? Dr. Shweta? Dr. Shweta?
Ma'am, I think she has lost her connection, ma'am.
Oh, she's back.
Sorry for the disturbance, ma'am.
Yeah, continue.
fibers, gel, strips, film, solution, paste, vesicular system. These are the deliveries which have been used. And chitosan, which is a polymeric natural available, this contains antibiotics. It contains then aceclofenac. These are anti-inflammatory agents which are helpful in the regenerative process. The various forms like gold nanoparticles, quantum dots, these are used in oral cancer management. Oral cancer management.
Then dendrimus hydrogels, they're used in the periodontal for regeneration. Solid lipids, they're used in the oral cancer management. Sorry for the disturbance, ma'am. And on the the implant surface,
There is
it is
lot of
been
echoing. A lot of
yes, ma'am.
echoing with your voice is
Am I audible, ma'am?
There is echoing of your voice.
Yes, ma'am.
Can you adjust your mic accordingly, please?
Now I'm audible, ma'am. Am I clear, ma'am?
Yes, much better. Finish
Yes,
off
ma'am.
before
On the
this goes
implant
back.
surface, yes, ma'am. The implant surface is again coated with the polymeric nanoparticles, which again provides an antimicrobial property. It provides good adhesion properties and helps in the peri-implantitis also. So through this, I could conclude that still researches are needed for the polymeric drug material to be used clinically. Thank you. Sorry for the disturbance, ma'am.
Dr.
No
Shweta,
issue.
what
Yes,
is
ma'am.
the major problem associated with nanoparticles?
Ma'am, nanoparticles, the major problem which are overcome is the device carrier size. For a particular site, it has to be manufactured accordingly, ma'am, and based requiring the site of the pocket measurement and as such, the geometry of the polymer can be manufactured and that can be delivered, ma'am.
Are there any chances of systemic problem as a result
No,
of
ma'am.
nanodrug delivery?
No, ma'am, there is no systemic toxicity as such. Why? Because it is a locally delivered and it is as it is in a nanoscale, the material will be dissolved there and the accurate therapeutic effect is seen, ma'am, without any systemic toxicity or adverse effects.
Okay, because of the size, that is a problem. It can
Yes,
be easily
ma'am,
absorbed into the blood
nanoparticle.
circulation.
Yes, ma'am, yes, ma'am,
Not
because of the
locally
geometry,
limited.
size, shape. Yes, ma'am, because of the geometry of the nanoparticle.
Okay, Dr. Swati.
Can you tell me what is the source of chitosan? You have mentioned chitosan. So what is the source?
Ma'am, chitosan, it is a naturally available polymer, ma'am. This polymer can be copolymerized or it may be cross-linked with metronidazole, then minocycline, doxycycline, tetracycline, aceclofenac to provide a good periodontal regeneration or periodontal therapy, ma'am. And it is also helpful in reducing the inflammation and it is helpful in the bone regeneration also, ma'am.
No, chitosan is used alone or it is used along with.
Ma'am, it can be cross-linked with aceclofenac, doxycycline, metronidazole, and can be used, ma'am, in the form of hydrogel, ma'am.
And chitosan, it is a natural product or it is a synthetic product?
Ma'am, chitosan is a naturally available polymer, ma'am. Thank you, ma'am.
Thank you.
Thank you.
Yeah, we are at the end of the session. I thank Dr. Swati and Dr. Ambili ma'am for their valuable time, and thank you to all the participants.
Ma'am, just one thing, ma'am, 195 and 196, are they absent, ma'am? We have to mark them absent.
Yeah.
They weren't there, madam. We announced.
They have not presented 195 and 196.
Yes.
Subhida madam, do we have them in the list?
Yeah, they were then in the list now, 195 and 196.
Yeah, but they haven't.
They
weren't
haven't
present.
presented.
I think that time.
They haven't
Yeah.
presented.
They weren't present.
So we can put absent in their column.
Yes.
Okay.
195, 196, are you all present? Because they weren't there. These last three were there, but they had network issue.
Okay.
Okay. That is okay.
I think you can announce again 195, 197. Are you all there? I think they're absent.
Yes, so ma'am, we should mark them absent only. No?
Yes, yes.
Okay.
Okay.
Thank you,
so
ma'am.
much.
Thank you
Yeah,
so much
Thank
for
you,
giving this
Ambali ma'am, and
opportunity. Thank you.
Thank you for sparing time and being here.
Thank you,
so
Dr.
much.
Swati, for being.
Thank you, ma'am. It was nice judging
Yeah.
with you, sharing with you. Yes, ma'am.
Yeah, it was a nice experience. Thank you, Dr. Swati and Dr. Chitita.
Thank you,
Thank you,
ma'am.
ma'am.
Thank you.
Good afternoon, everyone.
Hello.
Yes, am I audible?
Yes, sir, you are.
Okay, good afternoon, everyone. We'll be starting with the preventive research paper presentations. I welcome the moderators, Dr. Purushottam Rakhevar, Professor and Head of Department Periodontics, SMBT Dental College, Sangamner, Maharashtra, and Dr. Girish Suragimath, Professor and Head Department of Periodontics, Krishna Dental College, Karad, Maharashtra. I welcome you, sir, and we can begin with the session, with the presentations. Thank you.
Excuse me, do I have to present my thing, my presentation, or will there be the video will be playing?
Ma'am, the video is supposed to play. I'll just confirm with the
Yeah. Thank you.
Very good morning. Today my presentation is on assessing two indices against the gold standard, which is better, CPS or CPI. Now, periodontitis is defined as inflammation of the periodontal tissues resulting in clinical attachment loss, alveolar bone loss, and periodontal pocketing. Now, how do we find out whether we have periodontitis? We have clinical signs and what the patient says, and then we have qualitative ones. Now, qualitative ones are indices. Now, what is an indice? Indice is a measurement of is a quality of measurement in epidemiology and clinical studies. The research hypothesis is to generate evidence to validate CPSS against universal index, that is community periodontal index, and the gold standard clinical attachment level or clinical attachment loss. Now, the sample size for this study was 152 patients with chronic periodontitis. In each patient, clinical attachment level, community periodontal index, and community periodontal sum score was taken. That means in all the 152 patients, this was done. The selection criteria was inclusion was age of the patient should be between 35 to 65. Patient should be systemically healthy, and patient should have generalized periodontitis. Exclusion criteria was patients with systemic disease were excluded, having any kind of drugs for the past 6 months, patients receiving any periodontal therapy preceding 6 months, post-menopausal females, pregnant and lactating females, and patients who are not willing for follow-up or giving consent for the study. Now, how did we, the severity of periodontal disease is calculated by clinical attachment level, that is mild periodontitis is 1 millimeters. Medium periodontitis is 3 to 4 millimeters, and severe periodontitis is 5 millimeters or more. Now, this is according to the old classification. According to the new classification, which was published in 2018, we have 4 criteria. That's mild periodontitis, medium, severe, and severe. The last one, which is severe, with additional tooth loss. Now, scoring criteria for CPI was given in the oral health surveys in 2013, and these are the scoring criteria. The sextants that were used were 17 to 14, 13 to 23, 24 to 27, 47 to 44, 43 to 33, and 34 to 35. That is the tooth numbering system. And the calculation was done as number of score divided by number of dentate participants. Once the CPI score was established, the groups were to have them to be able to have a how should I put it? They were classified according to the CAL criteria, so that comparison could be done between the 3 groups. So mild periodontitis was taken as 0 score, medium periodontitis was taken as score 1, and severe periodontitis was taken as score 2, 3, and 4. Now, clinical periodontal sum score was given by Metilla in 1993, in which the cumulative sum score included pocket probing depth more than 4 mm, gingival sites with bleeding on probing, suppuration that was visible, and furcation lesion. And these all were taken in all 6 sites, that is mid-buccal, mesial distal, mid-palatal, mid-lingual, mesial distal. Now the results show that we had done a receiver operator characteristic curve, that is ROC curve, was done, and we found out cutout rates for severe periodontitis and mild to moderate. Why we couldn't differentiate between mild and moderate was because there were less cases of mild periodontitis that has come. So the cutoff point was at severe and moderate periodontitis. So we have more than or equal to 127.5 is our 125 is our severe, and less than that is our moderate periodontitis. And this was statistically significant, highly statistically significant. The sensitivity of this test was 85.3, specificity was 81. Positive predictive value was 78.4 and negative predictive value was 87.2, and the accuracy was 82.9%. And the kappa statistics. So the study shows that the relation between CPSS and CAL was better with CPSS with the gold standard as compared to the universal or the global standard, as 0.47 was more than 0.409. Now we're coming to the discussion in which CAL is considered as a gold standard by all the periodontists, and examiner training was done for all the 3 groups 5 days before. Reliability for CAL was 0.60 according to one of the national health surveys. Validity is also good of clinical attachment level. Now, in this study, reliability, intra-examiner reliability was done. As I said, it was calibrated for 5 days. Internal and external calibration was done. And we found out that the specificity and sensitivity also was above 80%, which is good. The accuracy was about 80 to 90%. There are other studies that have been done with CPSS and cardiovascular disease. CPSS was started with a cardiovascular disease study by Metilla. And there have been studies that have been done on diabetes mellitus, rheumatoid arthritis. Rheumatoid arthritis was done by Rujita et al. In 2018, and further studies have been going on in my department. So basically, this study gives the cutoff points for severe and moderate periodontitis, and further study has to be done for mild periodontitis. So the clinical implications of this study was CPSS, that is cumulative periodontal sum score, is a reliable and easy to use. It takes into consideration all features of periodontitis, hence it's a valid index in assessing the disease. This is the first study that is done to validate CPSS and to get the differentiation between moderate periodontitis and severe periodontitis. And it is a beneficial tool in recording periodontal disease status. And it is similar to, it shows that it is similar to clinical attachment level. These are my references. Thank you.
Yes, madam. Good afternoon. This is Dr. Rakhyar Purushottam. Madam, I am audible to you. This is
Yes,
Dr. Rakhyar. Yeah.
Yes.
Yeah. Madam, how you have selected the sample size?
So whatever chronic periodontitis cases came with the inclusion criteria, I mean, following the inclusion criteria, I just took all the patients. I did not, I just went according to my inclusion criteria. I just needed periodontitis cases, and that's how I included it in my study.
Okay. Madam, which type of periodontitis you have chosen for this study?
Sir, I just needed generalized, now chronic periodontitis terminology is not used anymore, but when I started my study, of course, it is generalized chronic periodontitis cases. The age group is 35 to 65 years. That's how I included it in my study.
Okay. Any criteria you have selected for choosing a
Yes,
patient?
sir. Actually, when I started this study long time back. This is a part of my PhD study.
Okay.
So in that, I had to choose pocket depth more than 4 millimeters and clinical attachment level more than 2 millimeters.
Okay. Last question. Why you have selected these two indices? Other indices are also good for to measure the periodontal diseases.
Sir, actually CPSS, like I said, it is a part of my thesis. So in this, my PhD thesis, in which I am doing on cardiovascular disease. Like I mentioned in the CPSS, the first person who actually talked about oral infection or dental infection was Metella in long time back, like 2 decades back in 1993. So I thought I'll use this, and we're doing a lot of study on this. So I thought I'll include it. And as we know, CL is our gold standard because no indice literally compares with it. And then CPI is our universal standard. If you see any survey, almost all of them at a WHO level, they all do CPI-TN or CPI. So that is why I chose the
But
gold
madam,
standard.
CPI-TN generally we use for treatment needs.
Sir, CPI-TN we use for treatment needs, then it has been changed to CPI-TN now. Now, if you see, not many people use CPI-TN. They use CPI most of the time.
Okay, okay, right. Over to Girish sir. Girish sir.
Thank you, madam. It was a nice presentation. But how relevant is your study? I am still wondering how relevant is your study to the disease diagnosis and treatment planning?
Sir, actually, this is since it is easy to calculate. One, this is an index. It is an index that will help me calculate. Actually, a lot of studies have been done, not just my study. There are a lot of other studies that have been done with systemic diseases. So one of it is CVS, of course. Like I said, there are studies on rheumatoid arthritis and all, and it doesn't take much time. So this study was basically to see that does it compare well to either the global standard or our gold standard. That's why this study was done.
Okay, madam. Anyway, nice. Thank you, madam. Thank you.
Thank you.
We can proceed for a next
next presenter. Exactly.
Yes.
Thank you.
Morning all, I am Dr. Anita. My topic is awareness, knowledge and attitude of patients towards dental implants as a treatment modality visiting BMS Dental College, Salem. It's a cross-sectional study. My number is PRPA002. So coming to the next slide, introduction. As we all know, face is considered as a window into one's personality, and the teeth plays an important role in the maintenance of one's positive self-image. Once the tooth is lost, it adversely affects the individual's life. So it has been found to have an emotional impact affecting one's self-confidence. The use of dental implants as a treatment modality for partially or completely edentulous patients is increased for ever since the concept of osseointegration has been accepted. So most of the patients appear to maintain a dangerous misperceptions about the dental implants. Thus, we can see that dental implants are not one of the most preferred ways to restore the lost teeth. This is mainly because of less awareness of patients regarding dental implants. This study is being conducted to deduce the reason as to why dental implants are not being chosen in spite of their longevity and clinical performances. The aim of the study is to explore the knowledge, awareness, attitude regarding the dental implants as a treatment option for missing teeth among the patients visiting BMS Dental College, Salem. Objectives to assess and determine the knowledge, attitude, awareness of patients and Salem population regarding the implants. Coming to the materials and methods, a cross-sectional survey was conducted among 200 patients, and with a self-constructed explanatory questionnaire. The study was approved by Institutional Ethical Committee and the Research Board. So the sample size of 200 subjects has been included, and the inclusion criteria, it is the subjects willing to participate in the study, male and female ratio is 1:1, and subjects with the age group of 15 to 55 years, they are being included in the study. The subjects who are not willing to take this test, they have been excluded from the study. So coming to the results, so out of 200 participants in the study, 117 were male and 83 were female. Again, the males are dominating. The maximum number of participants belong to the age group of 26 to 35 years. And the subjects were of different age groups, and qualification numbers is maximum counted for the schoolings, that is 113. The statistical analysis was done with the student t-test and ANOVA test, and the significance of the data was assessed. So demographic, this is the demographic structured data. Coming to the records, number of participants and the percentage. So this is a chart one depicting the gender, with the 59% of male participated and contributed for the study, and the female of 41%. Coming to the chart two, that is age in years, that is I've categorized into 4 groups: 15 to 25 years, 26 to 35 years, 36 to 45 years, 46 to 55 years. And the age group between 26 and 35 years, they have contributed around 36%. Coming to the qualification, I've categorized into school goer, they have of school, UG, PG, undergraduate, postgraduate. Of this, the participants, majority, they have 57% contribution was within the school level. So chart 4 depicts the missing teeth. That is, among 200 responses, 62% where people, they have a missing teeth. So chart 5, it depicts awareness of dental implants. That is 59% of the people, they are aware what a dental implant is, and a very saddened part is 41% of the people, they don't know what a dental implant is. The chart 6, that is the scared of dental, that is around 84% of the participants, they are scared of dental implants, their surgical procedures, and the term surgery, etc. Coming to the chart 7, 71% they resist the treatment due to the high cost of dental implants. Coming to the source of information, that is chart 8, majority of the participants, they receive their source of information from friends and relatives. That accounts for 44%. Sadly, the dentist, we were put in second place, that is 32%. The statistical analysis, the master chart was created in Microsoft Excel, and the software of SPSS version 15 was used. And the student t-test and ANOVA t-test, the significance value of P less than 0.005. Coming to the table 1, knowledge and attitude of patient towards dental implants as an option for replacement of the missing teeth, according to the gender using student's t-test. In this, the male, actually 117 have participated and contributed for the study with the mean value of 1.35 and the standard deviation of 0.49. And it is statistically significant p-value of 0.001. The table 2, we have categorized the age groups, and the age group of 26 to 35 years, 72 members have participated with a mean value of 1.22 and the standard deviation of 0.4, and it has a statistically significant p-value. Table 3, that is according to the qualification, we have used ANOVA test. In this, the UG category, 65 members have participated with a mean of 1 and standard deviation of 0.0 and a statistically significant of 0.001. Coming to the discussion part, we all know around 1 million dental implants are inserted each year worldwide. However, information which is available to the patients regarding the procedure and its success is often fragmentary. This problem is more compounded in the developing nations like our country. So in the present study, the awareness of implants were restricted to only 59% of participants, which is very, very less when compared to other studies done by Zimmer et al. And Tepper et al., in which they have shown a 77 to 72% of level of awareness respectively. It was found that the dentists were not a main source of information in my study, whereas in Johnny and Chowdhury et al., they have proven the dentist the main source of information. Whereas Zimmer et al.'s study, the media was found to be a main source of information where the dentists were lacking. So this clearly indicates a lack of efforts by the dentists and the governing bodies regarding taking necessary steps for creating the awareness among us, the people. When questions were asked regarding the constraints of the implants, most of them mentioned high cost as a major factor. So some patients think that implant is a major surgical procedure because of the use of the word surgery. So similar results are obtained with the previously mentioned studies like Johanny et al. And Tepper et al. So considering the influence of education, knowledge, attitude towards the dental implants, the scores increased from school level to the graduation level, and the similar findings have been observed in Syed et al. Study also. So in general, males had a better knowledge and attitude than the females, which was in contrast with the other studies of Kawamura et al. So coming to the conclusion, taking into consideration the present scenario, there is a need for incorporating the basic knowledge and awareness regarding the implants as an upgraded treatment option for replacing the missing teeth. Even though there is a positive attitude towards the dental implants, the treatment costs, the huge treatment cost, makes them to take a back step in choosing their option for missing teeth replacement. Furthermore, as this survey was conducted in a limited group of people with a limited amount of information extracted, for the larger scale studies are needed to assess various problems encountered by the patients. So these are all my references. So I would like to conclude with a saying, a journey of 1,000 miles start with a single step. Let's start before it's too late. Let us give awareness and knowledge about the dental implants and a positive attitude to inculcate in the patients who visit to us in our dental clinic or in our dental colleges. Thank you.
Yes, madam. Good afternoon, madam.
Good afternoon, sir.
Yeah. Madam, can you please tell me the selection criteria of a patient? What selection criteria? Yeah.
So patient aged 15 years and above, they have been selected for this study, sir. And the randomization is also, it is of, we didn't randomize, sir, because there is no groups in that. After collecting the responses, I've divided the groups, age groups and all that.
Randomization is necessary for the such type of study, I think so.
That is okay. So there is no comparative evaluation here, so that's why we didn't randomize.
But okay, you have selected a edentulous patient or a normal patient who visited to clinics?
Yes, a normal patients who visited to our department, because it is about knowledge and awareness that they should have. That's why I've selected all the patients who are visiting our department, sir.
Then you used the purposive sampling method.
Okay.
It is called a purposive sampling because you used it on for your purpose.
Yes, sir. Yes, sir. This is a purposive sampling technique.
Okay. Okay, sir.
Yeah. Anyway, what is your take-home message for the
sir,
dentist and periodontist or whomever you want to convey a message?
Yes, sir. Since in our present scenario, I can see many patients, they are visiting the dental clinics or the colleges. They lack, there is a paucity of information regarding the dental implants and their use.
So it is our duty as a dentist, it is our duty to improve the patient awareness, knowledge, and we should tell them what the pros and cons of each option, replacement option, so that they can choose accordingly, because the patients, they rely on their dentist to provide more reliable information and the services they provide. So we should have, inculcate all the positive attitude about the dental implants to the patients.
Okay, madam. Anyway, chalo. Thank you for the answer.
Okay, ma'am. Thank you, ma'am.
Thank you, sir. Thank you.
The next presenter can start.
The topic of my presentation is, thus betel quid chewing, areca nut, masala and tobacco lead to periodontal breakdown. It's a pilot survey. Betel quid chewing is a part of many religious and cultural ethnic groups within the Indian subcontinent. The style varies between communities and individuals and is termed as pan chewing. Main components of betel quid is a leaf, a nut of areca catechu, pan, lime, which is chuna, extract of wood of acacia catechu, which is kattha, may contain tobacco leaf and masala, which is nothing but a combination of coconut powder, ginger, and cumin. Normally, chuna, acacia, supari extract are smeared on betel leaf, which is then partially folded into a funnel shape and kept in the mouth, chewed or sucked for a long time. The habitual chewer may keep a chew in his or her mouth from 15 to 30 minutes. This study is designed to determine whether the habit of betel quid chewing with additives is a contributing factor to the rise in the incidence of periodontal disease among the population studied. In addition, the dose-response effects, the frequency and duration of habitual betel quid chewing were examined. A total of 402 subjects, 293 males and 109 females were screened, and the subjects were divided into 5 groups on the basis of quid chewing habit in different forms that I'll describe later. Information was collected on duration and frequency of chewing and smoking habits. The exclusion criteria was if any person was having systemic diseases affecting periodontium, like uncontrolled diabetes or cardiovascular diseases, pregnancy, or if the individual is taking immunosuppressant drugs. The questionnaire was completed on the habit of betel quid chewing, on the number of units used per day and the number of years of consumption, usage of additives, tobacco and masala, history of smoking habit was also recorded. Clinical measurements of all permanent fully erupted teeth excluding third molars were examined under artificial light with mouth mirrors and manual periodontal probe. Periodontal status was examined at 6 different sizes per tooth. Probing depth were measured with the help of a probe tip parallel with the long axis of the tooth. Measurements were made to the nearest millimeter and the lowest value was recorded where doubt existed. Clinical attachment level was recorded at the distance from CEJ to the base of the clinical pocket. This was calculated by measuring the distance from the CEJ to the gingival margin and subtracting this value from the periodontal probing depth measurement. Gingival bleeding on probing was recorded at percentage positive sites of whole mouth. The presence of plaque was also recorded according to plaque index. The number of missing teeth were also recorded. The statistical analysis, the mean values of probing depth, the clinical attachment loss, the bleeding on probing, and percentage of missing teeth were compared in different subgroups using one-way analysis of covariance along the t-test, adjusting for the smoking habits. The groups were divided into Group 1, areca nut, Group 2, which had the habit of taking areca nut with masala, Group 3, areca nut with tobacco, Group 4, masala, and Group 5, people who were taking tobacco only. So basically when we see in the Group 1, the areca nut group, the bleeding on probing was most significant, 22% sites. In Group 2, which had areca nut and masala, the probing depth was found to be 1.2, the clinical attachment level loss was 2.15, and the number of missing teeth were also maximum, 4.54. In Group 3 with areca nut and tobacco, the plaque index was found to be the greatest, 1.76, and nothing significant with groups who were taking masala only. The p-values were adjusted at the bleeding on probing significance of less than 0.001. The duration, as we see, as the number of subjects, like 326 who were consuming masala and areca nut for greater than 3 years, it was seen that bleeding on probing was maximum. Again, the probing depth was maximum, clinically significant attachment loss, p-value less than 0.05. Then the plaque index was also more, 1.48, and missing teeth were again 2.24, less than, so the p-value was amounting to less than 0.05. Frequency per day, the number of subjects who were consuming areca nut were like 55 or greater than 10 years. Bleeding on probing was again found to be significant in the frequency, wherein the patient had the habit of greater than 10. Bleeding on probing was 0.22. However, the significant p-value was achieved when we talk of the plaque index and the number of missing teeth over the years. Smoking, when we talk of the subjects who smoked, was like 62. The bleeding on probing was found to be more, significant p-value less than 0.01 in subjects who were not smoking. The clinical attachment loss was greater in people who were smoking, with the p-value of less than 0.01, and the clinical attachment loss of 1.36. Also significant finding was the smokers had more number of missing teeth, averaging out to be 2.03. Coming on to the discussion, the epidemiological studies have clearly shown an association of betel quid chewing habit with an increased risk of oral cancer and oral submucous fibrosis in the Indian and South Asian countries, as is seen by the study done by Ko et al. In 1992 and Richter in 1996. Studies have also shown a significant relationship between the presence of periodontitis and betel quid chewing habit in India, as was seen in the study conducted by Chowdhury et al. In 2003. Chowdhury et al. Reported that betel quid chewing leads to poorer periodontal health as a result of presence of Helicobacter pylori among dyspeptic subjects. Mehta et al. In 1955 reported the darkening of the tooth surfaces from betel leaf chewing because of the deposits of lime on teeth. Another possible reason for the harmful effect of betel quid on periodontal health is the cholinergic effect of betel quid together with calcium salt in the saliva, because of the hypersalivation causes calculus deposition, and again this deposit destroys the gingival tissue and periodontal attachment, as was seen in the study conducted in 2006 by Chatri Chai-Vaitana. Additionally, erecholine has also been shown to inhibit cell-to-cell attachment, cell spreading and migration, and to decrease cell growth and collagen synthesis in human cultured periodontal fibroblasts, as was seen in the study conducted by Chang et al. And Trivedi et al. In 2002. However, these reports did not provide any information about the detrimental effects of betel quid additives on the periodontal health of betel quid chewers. Chewers of betel quid with masala showed higher mean values of periodontal parameters, including mean periodontal depth, clinical attachment loss, and missing teeth. Increased percentage of sites with bleeding or probing were found in betel quid chewers without any additives. Tobacco chewing causes vasoconstriction of the gingival vasculature, thereby impairing the gingival blood flow, leading to less bleeding on probing percentages. Impaired gingival flow suppresses the normal gingival inflammatory response to plaque infection and consequently conceals the actual level of gingival inflammation in tobacco chewers and smokers. Masala again is a commercially available product containing cardamom, grated fresh coconut, cloves, ginger, and some sweeteners. And all the clinical parameters examined in chewers of betel quid with areca nut and masala were significantly higher than those in chewers of tobacco or masala only. Therefore, masala, despite the fact that it has little direct effect on the periodontal health, might synergistically enhance the detrimental effect of areca nut on periodontal disease progression. Masala has been found to have mutagenic properties, although the mechanism remains unclear. Because there are few subjects who used masala only, the results from larger number of subjects might reveal the direct effect of masala. In the present study, the periodontal parameters became higher according to both the increase in frequency and duration of betel quid intake in the total participants. Smoking is a confounder in this database and may be an effect modifier. The present cross-sectional study indicates that betel quid additives are positively associated with established periodontal disease. The dose-response effects, however, the frequency and duration of betel quid chewing were also observed. Longitudinal community-based studies are needed to confirm these findings. In addition, new avenues of research should include the qualitative assessment of attitudes to betel quid additives and betel quid chewing, and effective ways to inform those concerned about its possible health consequences.
Good afternoon, madam. This is already known now, the effect of tobacco on periodontal disease or the periodontal health is a known topic as far I agree to you. What was the new in that you saw in this study, madam?
Why I got interested in this topic was the subjects that I had included in my study. They had this thing called masala, areca nut and masala in the quid. And even though if you've seen in my groups, the number of people who consume areca nut and masala are less. The number is only 13 out of 402 cases that I have taken in the study. And with that also, the significance of clinical attachment loss, the probing depths, the clinical attachment loss is found to be highest in this group and not in the group that had areca nut with tobacco, or for that matter, tobacco alone or masala alone. So that is why this small number kind of made me choose this study, sir. And also, I could only collect the sample size of 4, not 2. I would still want to add more sample size and do further research into this, sir. Because even they have not been able to prove the effect of masala. So like in one of the studies that was done by Trivedi et al. In 2002, they said that they might have some mutagenic properties, but how they are having the additive effect along with supari per se. So that is what got me interested, sir, in this study.
Anyway, nice, madam. I think the masala that is added has, I think, chemically prepared. Maybe some chemical ingredients are involved in the more destruction.
Sir.
Purushottam, sir.
Sir.
Yeah, yes, sir. Madam, why you have taken 3 indices only? Whether any studies there which state that the betel nut can increases the mobility or affect the mobility of the tooth?
No, sir, I did not come across this study, sir, but I referred to one of the studies that was done by Chaudhary et al. In 2003, sir, where they had taken this indice, wherein because of the deposition of lime and lime on the tooth structure, and also because of the cholinergic effect of the betel quid, so because there is more production of saliva that can aid in more calculus deposit and attachment loss. That is why I had considered taking missing teeth, and I had individually asked in the question whether the tooth was extracted because of mobility or was it extracted because of decay, sir.
Thank you, ma'am. Thank you.
Sir, thank you, sir.
Thank you. Sir, we can proceed for next presentation.
Today's paper is going to focus on the knowledge, the attitude, and the periodontal management for the patients who are undergoing radiotherapy for head and neck cancer. The study is a questionnaire study. It's a questionnaire study which was done for understanding the oral complications of radiation therapy for head and neck cancer, which is associated with a significant decline in the oral health quality of life. An abundant amount of research has been done regarding the incidence and the management of dental caries, candidiasis, osteoradionecrosis, xerostomia, mucositis, etc. following cancer therapy. However, there is very less focus on the gingival and periodontal diseases as well as its management preoperatively, during and post-cancer therapy, and hence There is a variability in the knowledge and the practice among the dentists regarding the periodontal management of the patients treated using radiation therapy. Hence, the objectives of my study are to assess the knowledge, the attitude, and the practice of dentists regarding the gingival and periodontal management of patients undergoing radiation therapy for head and neck cancer. A questionnaire study with a convenient sampling method, and the questionnaire was given to dentists working in a hospital-based setup. The questionnaire was sent by email, the response was recorded using the Google Forms, descriptive analysis of the data was done, and charts were prepared. Around 72.5% of the study participants were postgraduates and who had been working in a hospital-based setup for more than a year. And we received around 43 response rates. Coming on to the knowledge domain, first of all, the question was the oral health of the patients must be optimized. And 81% of the respondents believed that it has to be optimized prior to, during, as well as post-cancer therapy. And comprehensive oral evaluation must be done. And this must be done as soon as possible so that all the treatments may be completed and the healing may be achieved. This was agreed upon by around 45% of the patients. They also believe that the oral care of the patients undergoing radiotherapy was an integral approach of the treatment. And pre-treatment evaluation should not only include hard and soft tissues, but also appropriate radiographs. This was agreed upon by 51% of the participants. The participants also said that the oral problems that were pre-existing, such as periodontitis, caries, failing restorations, ill-fitting dentures, etc., increased the chance of infection for a patient undergoing radiotherapy, while the poor oral health status is mostly due to xerostomia, mucositis, as well as a shift in the oral microbiota. Around 51% of the participants believe that a reduced vascular supply and remodeling capacity of the jaws and the bone, as well as the soft tissues, led to increased risk of progressive and uncontrolled rampant periodontal destruction, while 42% of them believe that it was a radiation-induced hypersalivation and the concomitant increase in the plaque accumulation that led to this. Coming to the attitude domain, the question was, do you think there will be sufficient time to provide complex dental care before cancer treatment commences? Around 53% were not very sure about it. And about the question whether a dentist should be a part of the treatment team, then they said that 95% should be a part of the treatment team, whereas they believe that a periodontist, an oral medicine radiologist, as well as an oral and maxillofacial surgeon should be a part of this team. Regarding the attitude towards implant placements, they said that placement of implants in irradiated bone requires a very careful assessment, and this was agreed upon. And they said the failure rates were most commonly in irradiated bone. A few of them said it is more common in the maxilla, where a few of them said that it is higher in the mandible as compared to the maxilla. And they also were having a mixed response in terms of the osseointegrated implants, facilitating effective oral rehabilitation prior to radiotherapy. Regarding the mucositis practice, benzodiazepine was the most commonly prescribed mouthwash to the patients suffering from mucositis, and LLLT has been tried by around 58% of the doctors for the resolution of mucositis. The participants did not believe that placement of dental implants should be done before radiotherapy. There was a mixed response. Around 50% of them believed that it should not be done before starting radiotherapy, whereas the complications regarding the treatment of head and neck cancer, around 37% had mucositis, whereas only 11.8% had extensive periodontal diseases, while 9.8% of the patients had some form of gingival enlargement. So the soft manual toothbrushes was most commonly recommended for patients. And in case of gingival enlargement, they believe that oral hygiene instructions and a phase 1 therapy resulting in adequate removal of plaque should be enough to reduce the need for gingivectomy during the treatment protocol. Hence, radiation therapy may have dramatic effects on oral health. Therefore, the prevention of the acute or chronic infections as well as their treatments is a necessity. the changes in the vascularity, cellularity, and the fibrous content in the connective tissue leads to reduced capacity of the periodontium to remodel, resulting in an increased susceptibility to infections. And a rampant periodontal destruction may be present in the absence of good oral health. The systemic antibiotic prophylaxis may decrease the exacerbation of the pre-existing periodontal or gingival diseases, and a mixed bacterial infection with minimal inflammatory signs due to the immunosuppression makes the detection of this pre-existing diseases difficult. Thus, the oral preventive care with reduced bacteremia, decreased severity of mucositis, and decreased gingival enlargement can be accomplished. And chlorhexidine remains yet the most commonly used mouthwash for the oral preventive care. To conclude, the periodontal infection may exacerbate during cancer therapy, resulting in oral pain and infections, causing morbidity or mortality in some cases. Hence, the study was done to assess the knowledge, the attitude, and the practice among dental professionals working in a hospital-based setup who might mostly encounter such cases. Dental care providers for the patient have to be a teamwork, including both medical and dental professionals, especially an oral maxillofacial surgeon, a periodontist, as well as an oral medicine and radiology specialist. I thank you for the opportunity to be able to present during the ISP conference. Thank you very much.
It was a nice presentation, nice topic to discuss, madam.
Thank you, sir. I am Dr. Vidya. Actually, I could not introduce myself.
It's okay, madam. It's okay. I am interested in the paper. What I was interested in is, you should have include oncologist or some medical practitioners, dentist asking dentist about oncology, which is not their field, does not yield any result. Actually, as far as I see.
Actually, sir, my dentist the people that I chose as dentists were mainly working in a hospital-based setup, in a medical hospital-based setup. They were not working in a dental college or in a dental clinic. Okay. So that was a slight difference. And there have been studies which have been done on oncologists already, and it has been established that they do not consider including a dental professional in their team at all. So I thought that working on find out whether dentists feel that they are actually a part of the team or not would have been a nice study, and hence I targeted those dentists who are working in a hospital-based setup, sir.
Okay. Rakeshwar, sir.
Yes. Madam, what are the periodontal finding in the radiotherapy patients?
So usually periodontal findings are very minimal because sometimes head and neck cancers have a combined chemo and a radiotherapy. So some amount of gingival enlargement and some amount of periodontal disease has been noted in those patients. So I felt that it is important to treat because it serves as a pre-existing disease, and it could be due to plaque accumulation, it could be due to xerostomia, it could also be because of the inherent capacity of the tissues to repair and remodel is decreased. So I thought that more care in terms of phase 1 therapy as well as their education, patient education and motivation is very important, and that is something I think only a periodontist is able to look into that viewpoint. And that viewpoint is usually not included upon by oral surgeons or any other dentist, the importance of phase 1 therapy. So therefore, I went in ahead with this kind of studies.
Okay. Thank you, madam. Thank you.
Thank you so much, sir. Thank you.
Next presentation, please.
I think.
Ratings. The number of individuals with special health care needs is enormous, and so are the unmet dental needs. Now, periodontists as experts in preventive care can play a role in supporting this particular cohort. And this survey was conducted to assess the perception of preventive periodontics in special care dentistry among periodontists in Tamil Nadu. So the study sample consists of periodontists registered in the ISP in Tamil Nadu, and we received 116 responses, and the questionnaire was validated by face value by a team of periodontists, public health dentists, and specialists in special care dentistry. And it had 16 questions on a Likert scale, which recorded the demographic details, the knowledge and knowledge of the periodontists on special care dentistry, their willingness to treat, and what were the barriers and the solutions to the same. And of this group, 44% were academicians, 25% clinicians, and 35% PG students. 71.6% were females, and the age group ranged from 23 to 63. Now, special healthcare needs is an umbrella term for anyone with activity limitation or impairment and participation restriction. So it was reassuring that 72.4% of respondents were aware of the categories of people who fall into the special healthcare needs. So that included physical, sensory, intellectual, mental, medical, emotional, or social impairment. So this was known. And special healthcare needs individuals exhibit significant oral health inequality related to their disability and the complex healthcare needs. There was a consensus on this, with 79.3% of respondents agreeing on the poor oral hygiene prevalence and 88.8% agreeing on the prevalence of periodontal disease among this group of people. The oral health needs of this heterogeneous population is complex and diverse, and this adds to challenges faced by these individuals in accessing dental care and preventive therapy. Inability to receive adequate personal and professional oral health care and oral health education is agreed upon by 80% of the respondents. Now, there is a dearth of dentists who practice special care dentistry. Children with special healthcare needs get the necessary attention from pediatric dentists, but this doesn't happen as they undergo transition into adulthood. So who will bridge this lacuna? Prevention can be primary and secondary, and we know that periodontists as experts in preventive care can play a role, and this was agreed upon by 86% of the respondents. And this could be because periodontists can develop innovative health education methods and aids, which was also agreed upon by 87% of the respondents. Now, there are dentist-related factors that do play a role in the oral health care of the special healthcare needs, and multiple health conditions, the knowledge on it, the comorbidities, ability to see beyond the obvious is very important, and training was also another factor. So this is a definite mountain to be blown up, and 75% of the respondents agreed on this. Now, curriculum designing is very important for the postgraduate students in periodontics to train them in this area. So 90% of the respondents observed the same. So concordance was observed, and comprehensive clinical training and behavioral management techniques are considered to be the most pressing matters. Now, when a question was asked on whether they had treated patients, 65.5% of the respondents agreed, and there was a significantly more number of academicians and clinicians who've been practicing special care dentistry than the postgraduate students. And when the one 0.8% of the people said they were comfortable, 20.7% said they did feel uncomfortable treating this particular group of people. And coming on to the willingness to treat, when they were asked, 87% of the response to willingness to treat the physically disabled also. But there was a slight dip with 72.3% of individuals showing a positive attitude to treat the intellectually disabled. This could be because of the greater spectrum of need and the lesser cooperation. 87% were willing to treat medically compromised. This could be because of the adequate training that is received in the dental institutions, as well as the comprehensive medical attention that could be availed in the academic institutions. 64.6% of people were willing to treat people with infectious diseases, and a similar consensus was observed among all the groups, and a similar trend was observed with 63% expressing willingness to treat people with psychiatric problems. Now, what are the factors which determine the willingness? When asked, 78.5% of them said communication, 78.4% said behavioral problems, and 62% spoke about the increase in time that needs to be given, and 69% on patience. This could be because you need more time to communicate and more time for them to comprehend and to gain cooperation. In terms of willingness to attend continuous professional development program, 82.8% of responders expressed interest. A clear treatment pathway is essential to address the needs of the special healthcare needs people. So we require a special workforce, and this was accepted by 67.4% of our respondents, that we need a special healthcare dentistry group. And periodontists, we can cater to the oral care needs of this special people. Special skills, knowledge, patience, willingness, empathy, and motivation are the necessary elements to take on the reins to address the needs of this particular special care group. Thank you.
Hello. How is it?
Sir.
Okay, maybe my mic was off. Okay. Anyway,
Yeah.
What geriatric dentistry? Basically, the periodontist is the one person who has to treat them. In the end of the story.
Yes, sir. It's the entire umbrella of people, sir. Even people with intellectual problems and other psychiatric problems also fall under this category of special healthcare needs. So there is a lot of hesitation in treating people with intellectual disabilities and psychiatric problems, adults with these issues.
So you mean to say we should include in our curriculum to cater these people?
Yes, sir, of course.
Some changes have to be done in the curriculum. Then only it can be implemented, na?
Yes, sir. Extensive training is required in this. Behavioral therapy training is also required.
Yes, no,
it is not we don't get it as periodontists.
No, not any. Even the dentist also, we don't learn anything related to this point.
Yes, sir.
Okay, nice. Okay.
Madam, good afternoon, madam.
Yeah, good evening, sir.
Yeah. Madam, how much is the sample size?
116 respondents were there, sir.
Okay.
116.
Madam, to conduct any survey, how much sample size is needed? How you calculate the
sample size is quite less, sir. I had to
so
take
how can we say this is a survey or this?
It was more of a pilot study, sir, actually, for a larger survey that I'm working on.
Yeah. Actually, it requires, and there is a method to calculate a sample size for a survey, to conduct any kind of a survey. Right?
I just convenience sampling for a pilot study, sir. I have to do the internal consistency and other things with the results that I have got, sir. And then go ahead with a larger survey, sir.
Okay.
That I'm planning on among periodontists.
Thank you, madam. Thank you, sir.
Thank you.
Yeah.
Thank you, sir.
Then the next presenter.
Very warm greetings to one and all. My paper presentation topic is correlation of leptin in myocardial infarction patients with chronic periodontitis, a case control study. Introduction. The term periodontal medicine, as first suggested by Offenbacher, is a broad term that defines a rapidly emerging branch of periodontology, focusing on the wealth of new data establishing a strong relationship between periodontal health or disease and systemic health or disease. Myocardial infarction patients had a significantly worse dental health than did controls, according to Matila et al. Chronic infection inherent in periodontitis may be associated with cardiovascular events as stated by Loesch et al. 90% increased risk of cardiovascular events in individuals with periodontitis, according to Janket et al. And according to D. Stefano et al., subjects with periodontitis had a 25% increase in the risk for coronary heart disease. Leptin, a product of the obese gene, is a 16 kilodalton non-glycosylated peptide hormone synthesized mainly in adipose cells to regulate weight control via its cognate receptor in hypothalamus central. It has been classified as a cytokine because it shows structural similarities to the long-chain helical cytokine family, which includes interleukin-2, interleukin-12, and growth hormone. Leptin also stimulates the immune system by enhancing pro-inflammatory cytokine production and phagocytosis by macrophages. Therefore, during infection and inflammation, leptin expression is modulated in a manner similar to the cytokine response to infection and injury. Karthikeyan and Pradeep showed that a rise in serum leptin concentration attributable to periodontal disease could act as one of the risk factors for cardiovascular diseases. And neovascularization of atherogenic plaque. Furthermore, it induces calcification of arterial walls in which the walls lose elasticity and become stiffer, which reduces blood flow and increases the heart exertion, which in turn increases the workload on the heart, contributing to various forms of cardiovascular diseases. Aim and objectives. The aim was to correlate periodontal clinical parameters, that is, plaque index, gingival index, probing depth, clinical attachment level, and serum leptin levels in myocardial infarction patients with chronic periodontitis. Objectives: correlation of periodontal clinical parameters and serum leptin levels in myocardial infarction patients with chronic periodontitis, that is, cases. Correlation of periodontal clinical parameters and serum leptin levels in myocardial infarction patients without chronic periodontitis, that is, controls. Comparison of periodontal clinical parameters and serum leptin levels among myocardial infarction patients with chronic periodontitis and myocardial infarction patients without chronic periodontitis, that is, comparison between cases and controls. Material and methods. It was a case control study. The sample size was 60 participants equally segregated into two groups, that is, cases which had myocardial infarction patients with chronic periodontitis and controls which comprised of myocardial infarction patients without chronic periodontitis. The inclusion criteria for the participation were as follows: age 30 to 70 years, subjects who have not received periodontal treatment in previous 6 months, dentition with minimum 20 natural teeth, hospitalized indoor patients diagnosed for myocardial infarction, and patients with chronic periodontitis. The exclusion criteria for the participants were as follows: patients having any systemic disease other than cardiac disorders, anomalies of the immune system, pregnancy and lactation, patients with the habit of smoking and alcoholism, and patients with aggressive periodontitis. The diagnosis of acute myocardial infarction was based on sinus tachycardia, fourth heart sound and increased jugular venous pressure, electrocardiographic changes with broad and deep Q waves, tall and pointed T waves and ST segment elevation, and release of cardiac troponin T according to World Health Organization criteria 1994. The diagnosis of chronic periodontitis was determined based on clinical attachment loss greater than 1 mm and or probing depth greater than 4 mm at 3 to 4 sites for more than 4 teeth in each quadrant, according to Karthikeyan and Pradeep et al. Leptin analysis. 3 to 4 milliliters of venous blood was collected into EDTA containing blood collection tubes from the antecubital fossa by venipuncture using a 24 gauge needle with a 5 ml syringe and immediately transferred to the laboratory. The samples were assayed for leptin levels using an enzyme-linked immunosorbent assay. The assays were conducted according to the instructions of the manufacturer, and a highly sensitive ELISA kit was used to detect the leptin levels in the sample. Coming to the results, Table 1 shows the demographic data. In this study, cases comprised of 8 females and 22 male patients, and the controls comprised of 6 females and 24 male patients. Pearson chi-square test was used for analysis. The p-value was 0.542. That means it was statistically not significant. Table 2 shows the intergroup comparison of plaque index, probing depth, clinical attachment loss, and body mass index. According to the independent t-test, the p-value was highly significant for plaque index, probing depth, and clinical attachment level, comparing the cases and controls. Whereas the body mass index, the p-value was greater than 0.05, meaning it was statistically not significant between the cases and controls. Table 3 shows the intergroup comparison of gingival index and serum leptin levels. Mann-Whitney test was used for evaluation. The gingival index and the serum leptin levels amongst the cases and controls was statistically highly significant. Table 4 shows the correlation of serum leptin to plaque index, gingival index, probing depth, clinical attachment loss, body mass index, and age. In the case group, leptin showed a strong correlation with body mass index and a good correlation with probing depth. In the control group, leptin showed a good correlation with body mass index. Spearman rank correlation coefficient test was used to evaluate the correlation of leptin with various periodontal parameters. The conclusion was that elevated serum leptin concentration is correlated with increased body mass index in both the groups and with probing depth in the case group. The rise in serum leptin concentration in myocardial infarction patients with chronic periodontitis and increased BMI may be considered as risk factors for myocardial infarction. These are the references. Thank you.
Good afternoon, Dr. Ankit.
Good afternoon, sir. How are you?
I am fine. Oh, I was only wondering, this leptin, we did a study on periodontitis with leptin and after treatment, pre and post treatment. We found leptin levels in saliva increased before, after the treatment. Do you understand?
Yes, sir.
In your case, we have taken serum and leptin levels were higher in the disease. It was vice versa in case of saliva when we used leptin in saliva. I think this was also proved even in GCF.
Yes, sir.
Karthikeyan study in GCF.
Yes, sir. Yes, sir.
I think if you have referred the Karthikeyan study, even there they found that it was increased after the treatment.
Yes, sir.
After post-treatment.
So there they have hypothesized, sir, that in GCF leptin plays a protective role, and thereby when there is more inflammation, the level of leptin in GCF is reduced. In case of inflammation, it is reduced, and when the inflammation increases, the GCF leptin level goes down, which is exactly opposite to that of present in the serum.
So that is what I was trying to tell you. So leptin as a biomarker is not a good indicator of a relationship to myocardial infarction and the periodontal disease, as far I see it as a from. What is your take on this?
Sir, I feel that as far as if we could talk about serum leptin levels, then it is a good indicator. If we exclude the possibility of GCF and saliva, if we just concentrate on serum leptin levels, because serum leptin levels have increased, even the CRP levels, which denote inflammation, they have also increased in case of myocardial infarction patients as well as periodontitis patients.
Rakeshwar sir.
Yeah. Good afternoon, doctor.
Good afternoon, sir.
Can you tell me which confounding factor should be considered while taking such type of study?
Sir, confounding factors like we can say stress. We can also say about smoking history, because smoking is adversely affecting both. Also, age can also be a good confounding factor, which can be affecting both myocardial in case of myocardial infarction as well as periodontitis. So these are some of, and also diabetes.
That you have not considered in your study.
I have considered, sir, because I have excluded all smoking and alcoholism patients. I have also excluded patients who are having any systemic illness other than cardiac. So I have also excluded diabetic patients because they are also confounding factors. Also hypertension patients, which can be confounding factors.
What are the normal leptin levels in healthy patients?
Sir, normal leptin levels in healthy patients is like up to 1 to 2 picogram per milliliter, we can say.
Okay. This is increase in gingivitis also or periodontitis also?
Sir, there was a study conducted in my college itself. The study was like healthy patients versus gingivitis and periodontitis. So there were 3 study groups: healthy, gingivitis, and periodontitis groups. So they have seen that whenever the inflammation increases, the serum leptin levels used to increase, whereas the GCF leptin levels used to reduce. So in gingivitis, it was increased, but not as that much as we see in case of periodontitis. But it was definitely increased compared to the healthy patients in gingivitis.
Thank you, doctor.
Thank you so much, sir. Thank you.
Yes, next presentation.
Very good morning. Today I will be presenting a paper on oral health status and oral hygiene habits of patients on dialysis. Chronic renal failure is a progressive impairment in kidney function associated with deterioration of nephrons, mostly occurring as a consequence of diabetes, chronic glomerulonephritis, and hypertension. Chronic renal failure leads to various changes in the oral cavity, including periodontal manifestations. The periodontal manifestations of renal disease include increased salivary urea levels because of the increase in the pH of saliva, and this could induce calculus formation. Chronic renal failure results in uremic syndrome. Uremia results in immune dysfunction, including defects in the lymphocyte and monocyte function. This is the cause for increased inflammation in this population. Alterations in calcium homeostasis leads to secondary hyperparathyroidism, and spongy bone is less mineralized. There is loss of lamina dura and tooth mobility. Thus, it is important to assess the periodontal status of these patients and to increase their awareness regarding dental care. The object
Organizer, just I think it has gone a bit hang.
Hello, I think there is some technical issue. Organizer, please see it.
Organizers, can you check this? Something is gone wrong.
Yes, Dr. Salman.
Yes, sir. So just trying to coordinate with them.
Okay.
It will become hang ho gaya something.
Yes, sir. They are working on it. I'll just let you know.
Okay. Salman?
Sir, they are working on it. There's some internet issue from that side. So they're not able to present it. So they are working on it and they will upload it as soon as possible.
Very good morning. Today I will be presenting a paper on oral health status and oral hygiene habits of patients on dialysis. Chronic renal failure is a progressive impairment in kidney function with deterioration of nephrons, mostly occurring as a consequence of diabetes, chronic glomerular Chronic renal failure results in uremic syndrome. Uremia results in immune dysfunction.
Introduction. The term periodontal medicine, as first suggested by Offenbacher, is a broad term that defines a rapidly emerging
Patients between the age of 30 and 70 undergoing either hemodialysis or peritoneal dialysis in a specialist nephrology center were the source of data. Informed consent was taken. The method involved first a mouth mirror and a probe. Oral malodor was assessed by self-examination method, wherein a toothpick was smelt after introducing it in the interdental area. Next, an oral hygiene index simplified as given by John C. Green and Jack R. Vermillion was taken. The following questionnaire was administered, which had demographic features, a medical and dental history component, and oral findings and oral hygienes component, and dental awareness questions, which were awareness that in patients with kidney disease, gingival disease could further harm the health, and also awareness regarding importance of dental care. The results were most of the patients were in the age group of 60 to 70, while the next predominant age group was from 40 to 49 years. And one of these patients smoked, while 4 of these patients chewed tobacco. Most of these patients were educated above the high school level, and the economic status of most of the patients was also good. Medical history showed that 9 out of 25 patients was hypertensive and 1 was diabetic. And many of them had multiple systemic disorders. Not found. Oral hygiene teeth remaining, and bleeding on probing was seen in 23 out of 25 patients, gingival overgrowth in 3 out of 25 patients, oral malodor in 7, but oral ulceration was not found. Oral hygiene status ranged from fair to poor in most patients. Brushing frequency, majority of the patients brushed only once in a day. And when it came to awareness, it was found that none of them was aware that renal disease can cause periodontal problems, and only 10 were aware about the importance of dental.
Very warm greetings to one and all. My paper presentation topic is correlation of leptin in myocardial infarction patients with chronic periodontitis, a case control study. Introduction. The term periodontal medicine, as first suggested by Offenbacher, is a broad term that defines a rapidly emerging branch of periodontology, focusing on the wealth of new data establishing a strong relationship between periodontal health or disease and systemic health or disease.
Yes, sir, I'm informing her that only that this
Myocardial
is
infarction
over.
patients had a significantly worse dental health than did controls, according to Matila et al. Chronic infection inherent in periodontitis may be associated with cardiovascular events as stated by Loesch et al. 90% increased risk of cardiovascular events in individuals with periodontitis, according to Janket et al. And according to D. Stefano et al., subject
Very good morning. Today I will be presenting a paper on oral health status and oral hygiene habits of patients on dialysis. Chronic renal failure is a progressive impairment in kidney function associated with deterioration of nephrons, mostly occurring as a consequence of diabetes, chronic glomerulonephritis, and hypertension. Chronic renal failure leads to various changes in the oral cavity, including periodontal manifestations. The periodontal manifestations of renal disease include increased salivary urea levels because of the increase in the pH of saliva, and this could induce calculus formation. Chronic renal failure results in uremic syndrome. Uremia results in immune dysfunction, including defects in the lymphocyte and monocyte function. This is the cause for increased inflammation in this population. Alterations in calcium homeostasis leads to secondary hyperparathyroidism, and spongy bone is less mineralized. There is loss of lamina dura and tooth mobility. Thus, it is important to assess the periodontal status of these patients and to increase their awareness regarding dental care. The objectives of our study was to evaluate the oral health status and oral hygiene habits of dialysis patients and to evaluate awareness in these patients about the periodontal implications of renal disease. The materials and methods are 25 patients between the age of 30 and 70 undergoing either hemodialysis or peritoneal dialysis in a specialist nephrology center were the source of data. Informed consent was taken. The method involved first an oral examination was carried out to assess the number of teeth present, gingival bleeding, gingival overgrowth, and oral ulceration. This was done using a mouth mirror and a probe. Oral malodor was assessed by self-examination method, wherein a toothpick was smelt after introducing it in the interdental area. Next, an oral hygiene index simplified as given by John C. Green and Jack R. Vermillion was taken. The following questionnaire was administered, which had demographic features, a medical and dental history component, and oral findings and oral hygiene component, and dental awareness questions, which were awareness that in patients with kidney disease, gingival disease could further harm the health, and also awareness regarding importance of dental care. The results were most of the patients were in the age group of 60 to 70, while the next predominant age group was from 40 to 49 years. And one of these patients smoked, while 4 of these patients chewed tobacco. Most of these patients were educated above the high school level, and the economic status of most of the patients was also good. Medical history showed that 9 out of 25 patients was hypertensive and 1 was diabetic. And many of them had multiple systemic disorders. The medical history showed that most of the patients were undergoing dialysis since less than 1 year. And the dental history showed, this is the shocking part, that patients were referred to the dentist during dialysis were only 7, and patients who got regular dental checkup was only 1 out of 25. Oral findings showed that majority had more than 20 teeth remaining, and bleeding on probing was seen in 23 out of 25 patients, gingival overgrowth in 3 out of 25 patients, oral malodor in 7, but oral ulceration was not found. Oral hygiene status ranged from fair to poor in most patients. Brushing frequency, majority of the patients brushed only once in a day. And when it came to awareness, it was found that none of them was aware that renal disease can cause periodontal problems, and only 10 were aware about the importance of dental care. When we did statistical analysis, a correlation of the oral hygiene index with the awareness about importance of dental health was determined by using chi-square test. And a level of significance of P is equal to 0.0277, which implies a statistical significance was found. So conflicting data exists on the effect of chronic renal disease on the oral health status, and recent studies have reported the presence of poor oral hygiene and attendant gingival inflammation in this population. The oral hygiene index, as assessed was found to be poor in 30% of the patients and fair in 57% of the patients. These findings suggest that these patients do not receive adequate periodontal care. The results are consistent with those in a study done by Attila et al. In 2008. The reason could be 61% of the patients brush only once in a day. Only 4% use interdental aids. Only 4% go for regular dental checkup. 28% of the patients have been referred to the dentist during dialysis. All the dentate subjects that we assessed showed bleeding on probing, indicating the presence of gingival inflammation, as gingival bleeding is the most common signs of the same. This is in accordance with studies done by Darby et al. In 1998 and Attila et al. In 2000. Oral ulceration, gingival overgrowth, and oral malodor were seen in 0, 13, and 30% of the subjects, respectively. Uremic fetor, bad odor, is caused by the presence of urease-splitting microorganisms which metabolize urea and thus elaborate ammonia. Potential confounding variables in the population include systemic diseases such as diabetes. In our study, we found 68% of the patients had hypertension and 40% had diabetes mellitus. None of the subjects was aware that the presence of renal disease could influence the periodontium, and only 39% were aware about the importance of dental care. On analysis, a statistically significant relationship was found between patients who lacked awareness and patients with poor oral hygiene. Thus, increasing the awareness is necessary to improve oral health in this population. The decreased awareness may be due to minimal interaction with a dental practitioner, as only 4% regularly visited a dentist and only 28% were referred to a dentist during the period of dialysis. So, the present study revealed all patients showed gingival inflammation. Oral hygiene maintained by these patients is inadequate. The patients are unaware of the influence of renal disease on the oral cavity, and the patients are not motivated to visit the dentist regularly. So, in conclusion, dialysis patients may benefit from regular dental examination and education programs planned together with the nephrologist right at the start of dialysis. Further studies are required to assess the alterations in bone, as well as longitudinal studies with larger sample size and age and sex matched controls to validate our findings. Thank you all.
So good afternoon.
Yeah, good evening, ma'am.
Good evening, sir.
Madam, what is the rationale of doing such, conducting such study?
So actually, a lot of these patients who undergo dialysis, they have a lot of periodontal problems and they're not maintaining adequate oral hygiene, sir. And because of uremia, they have an increase in calculus because of the increased pH. And they also may have mobility because of the effects on the spongy bones, sir. And also they have a lot of other oral ulcerations, and because of the drugs they are on, because they may be hypertensive, they have gingival enlargement, which further increases the chance of calculus and plaque buildup. But nephrologists are not telling them about their oral health, and they are as such not aware of their oral health either. So we wanted to know how many of them are aware of their oral health, how many of the nephrologists are informing about their oral health, so giving referrals to the periodontist so that that part also will be taken care of.
Madam, can you please label some few studies, previous studies?
So there were studies done by Darby et al. And Attila et al. Where they have checked the oral hygiene status and the gingival inflammatory status in patients on dialysis. And both of them have agreed that oral hygiene status and gingival inflammation is predominant in patients on dialysis.
So you have taken only one index, that is the oral hygiene status of a patient, and mala odor. Why you have not taken periodontal indices?
You're right, sir. I have this is only a sorry, sir. So this is an incomplete study. What you're saying is right, sir. Because there is mobility, I think a mobility index should have also been included because spongy bone is affected, and hence even that probably we should have included. Maybe a Miller's mobility index or GERT index we could have included in the sample to check that component also. Or maybe a Ramford's periodontal index could have also been included. So maybe in future studies we should include these.
Or a radiological examination would help, madam.
Sir, actually radiographic would help. This was done in JNMC campus, sir. When in patients who came there, I think we should have called them to the dental part and examined them. This was not done. This was
And one
conducted
more
only
thing,
in the medical
the
center.
sample size is 25. It is too small to, I think, as far as I see, madam. How did you come to the sample size of 25, madam?
So I agree. This is a smaller sample size. This was just a pilot study to see whether there is a future scope for more studies in this population, and it is required to do further studies, sir. I agree with what you say completely.
Okay. Nice.
Okay, so thank you.
Madam. Thank you, madam.
Thank you, sir.
Thank you. Next presentation. Yes.
Hello everyone, I'm Dr. Pradna Mai. Title of my paper presentation is Knowledge, Attitude, Oral Hygiene Practices and Experiences of the Oral and Periodontal Health among Pregnant Female. While introducing this topic, it has been always noted that dental health is the mirror of the general health and well-being. Dental health is influenced in pregnancy due to hormonal fluctuation. Hormonal changes in pregnancy combined with a neglected oral hygiene tend to increase the incidences of the oral diseases like gingivitis. Pregnant women have a special oral health needs due to the hormonal fluctuations, which have a strong influence on the oral cavity and the periodontium. Pregnant women have been shown to have a higher incidences of the gingival inflammation and than non-pregnant women. The higher estrogen level in pregnant women is always responsible for the periodontal inflammation and edema, high sensitivity, and tendency to bleed easily, and can cause the pre-existing gingivitis to worsen considerably if plaque is not removed. To our knowledge, very few Indian studies addressing the extent of the mother's knowledge regarding the association between oral health and pregnancy outcome have been published. Therefore, the aim of the study is to evaluate the knowledge, attitude, oral hygiene practices, and the self-perception of the oral and the periodontal health among the pregnant women in and around the Pune city. Aim and objective in this questionnaire-based cross-sectional study to evaluate the knowledge, attitude, oral hygiene practices, and experiences of the oral and periodontal health among pregnant females, and to correlate demographic status with knowledge, attitude, hygiene practice, experience, and also to assess and compare the oral hygiene knowledge as well as the oral hygiene practices and attitude among pregnant female based in the Pune and surrounding. Methods. In this self-interviewing questionnaire-based cross-sectional descriptive and analytical study, we have proceeded with the study after approval from the ethical committee and from the gynecology department of Srimati Kashibai Nogli Pune Hospital. Study conducted in 2018 and finished within 3 months from Jan to March. Participants involved in this study were signed consent form for involvement in this study. Questions were categorized into 5 different categories: socio-demographic data, the knowledge, attitude, practice, and experiences of the pregnant woman. Study involves the 340 participants were handed the questionnaire and the self-interview. These are the results. Result includes the table number 1 about the knowledge. We can see here, do you know, the first question shows that do you know that cavities and gum diseases are caused by infection in the mouth? You can see the answer don't know is 158. Same, are you aware that the gum diseases are related with the premature labor and low birth weight babies? And the don't know is a 262. Do you know the calcium will be drawn from the teeth developing for the developing babies? That don't know answer is 179 and so on. This is another table regarding knowledge about incorrect and correct answers. P-value is 0.00. Attitude, P-value is 0.00. Attitude table, practice table 1, P-value 0.00. Practice table 2, P-value 0.00. And experiences which are uneventful, P-value 0.00. Socio-demographic characteristics of the 340 respondents we have divided into age, ethnicity, education, and job status. Now, discussion on the basis of data we have collected, we can say participants have a very poor knowledge about the pregnancy-related dental care and diseases. Responses to the questions in attitude category help to decide that most of the participants are uncertain about the question and question answers. Looking at the practices, 306 participants didn't visit dentist during the pregnancy, but they have twice brushing habit, which is good in the sense of the maintaining oral hygiene. Participants also encountered about their past experiences of the dental treatment in which their experiences was uneventful. But the knowledge intervention in this area might be necessary. In comparison with the postnatal survey conducted in Australia, 26.4% of the pregnant women did not receive dental care at least twice yearly. Majority of the pregnant women, 96.8%, agreed that the woman should have dental checkup during pregnancy, but only 55.9% had done it for the current pregnancy. In the postnatal survey done in Australia, only 30% of the women attended a dental clinic during pregnancy. This raises serious concern as pregnant women. Conclusion: majority of a pregnant woman has good knowledge and information about the general health, but not about the dental health. But they have limited knowledge and awareness regarding periodontal disease and its effect on the pregnancy and adverse pregnancy outcome. Most pregnant women need more information about oral health and prevention of gingival and periodontal diseases. Longitudinal studies are needed to assess the long-term effect of the oral health education programs and maternity care centers on a dental health knowledge and attitude pregnant women. Long-term studies are required to determine if there is a strong correlation between pregnant diseases, periodontal diseases, and premature labor. Also, further studies are required to check whether periodontal therapy or prevention can reduce the risk of premature labor. This study provides basic and important dental health knowledge, attitude, oral hygiene practices, and experiences of the oral and periodontal health among pregnant females based in Pune and surrounding. More awareness programs, dental checkup camps should be conducted to improve their concern about oral and dental health, and finally, pregnancy outcome. These are my references. Thank you.
Good evening, madam. Because we conducted a study and we found out that no matter whether you give treatment to the pregnant lady, periodontal treatment, or don't give treatment, the pregnancy outcome did not change. Do you understand what I'm trying to tell you, madam? The pregnancy outcome does not change whether you give treatment or no treatment. So what is your take on this message, madam? There are already studies regarding this.
Sir, actually, this is regarding the awareness and improving the knowledge that during pregnancy, patients should not land up with the dental problem. So routine checkup will avoid the dental emergency during the pregnancy trimesters.
So you're not interested in the pregnancy outcome, you're more interested in the mother's health, oral health.
I am interested in both, but the thing is like it is about the knowledge, attitude, practices, and experience. Both things are related. So we are in this study, actually, we are focusing on both. Obviously, this is a proven, but we are also focusing on the knowledge attitude. So actually, I was trying to do that.
Okay. It was a nice presentation anyway.
Thank you.
Sir.
Yeah. Good evening, ma'am.
Good evening, sir.
Yeah. What dental treatment you consider during the pregnancy?
So routine checkup will avoid routine scaling, and routine checkup will avoid the bleeding gums and patient landing up with the any abscess formation, anything related with the gingival problem, periodontitis. That is your concern, and which will avoid the severe loss of the tissue and the periodontium tissue loss.
Okay. When generally this treatment is done? Which trimester?
Sorry, sir. Sorry.
When this treatment modalities are considered?
like you mean to say, like which trimester we should provide the treatment? Like after the 3, like whenever patient conceive, that time patient understand that she should regularly visit the dentist, and the treatment, if required, she should go for the treatment, and we avoid the treatment in 3rd trimester.
Okay.
Thank you.
Thank you.
Hello, myself Dr. Shubhangi Rajbhosh. Today my topic for paper presentation is knowledge and attitude among gynecologists regarding oral health and association between periodontal disease and adverse pregnancy outcomes in Pune. Introduction. As we all know, in pregnancy, estrogen and progesterone levels are increased. These increase in these hormones can lead to increased gingival vascularization as well as decreasing immune response. Moreover, studies have also found that microorganisms like Prevotella intermedia also increase during pregnancy, and these microorganisms have a tendency to increase gingival bleeding and worsen the gingival oral health during pregnancy. Several clinical and experimental studies have concluded that subclinical infections in pregnant women are the most likely, they are most likely, and they are the frequent cause of lower birth weight. Jeffcoat et al. In their study concluded that more than 300 pregnant female subjects with generalized periodontitis had a 5-fold increased risk of preterm low birth weight 35 weeks before, and 7-fold increased risk of delivery before 32 weeks of gestation compared with women without periodontitis. An estimate for the risk of having preterm and low birth weight infants in mothers with periodontal disease was seen as 2.83 compared to the mothers without having periodontal disease. Gynecologists play an important role in the welfare of the mother during pregnancy. Their awareness regarding association between periodontal disease and adverse pregnancy outcome is extremely important in recognizing the modifiable periodontal disease risk factors associated with pregnancy. Also, incorporation of the periodontal care into gynecologic management may improve the pregnancy outcomes, and early intervention may reduce the microbiologic load on oral tissues during pregnancy. Hence, the aim of my study is to assess the knowledge and attitude of gynecologists regarding preterm low birth weight cases and periodontal disease among pregnant women. And the objectives were to assess and to correlate knowledge and low birth weight cases and periodontal disease among pregnant women. Materials and method. The study was a cross-sectional questionnaire-based study which was conducted among gynecologists in Pune city. The necessary ethical clearance and permission was obtained, and a total of 200 participants were included in the study. The inclusion criteria were the participants who were MBBS and MD, that is MD in gynecologist, they had completed, those were included, and who were willing to take part in the study and fill the informed consent form. The study participants were given a questionnaire to fill the questions containing based on their knowledge. Based on their knowledge and attitude towards the periodontal health among pregnant female. The questionnaire were also sent through email and WhatsApp using online Google Forms for those who were not available. A questionnaire consisting of 10 questions. First 5 questions was based on the knowledge of gynecologists about the periodontal health and related changes in pregnant females, and this other 5 questions were based on the attitude among gynecologists towards the periodontal health in pregnant female and its treatment needs. The first 5 questions of knowledge, they were for that a scoring criteria of 2 to 0, that is yes, no, and don't know was used. And for second part, for attitude, Likert scale ranging from 1 to 5 was used. Results. Data analysis was done using SPSS ISP-2021 version software, frequency analysis and chi-square test for proportion was used, and Pearson's correlation coefficient was used to correlate the data. A total of 200 participants responded, and among them male were 41.5% and female gynecologists were 58.5%. The mean age of the participants was between 40 and 41 years. The mean years of their work experience was between 10 to 11 years. The frequency of responses given by the participants according to the chart for question 1, where the question 1 was whether periodontal disease is not a risk factor for systemic complications. 68.5% answered yes to this. While for the second question, whether the periodontal disease is not a risk factor in preterm low birth weight deliveries, 90.5% participants answered yes. For question 3, which was periodontal disease can be a risk factor for preeclampsia during pregnancy, 81.5% participants answered no. And for question 4, which was microorganism levels, does it increase in the periodontal disease during pregnancy, 83% of the participants answered no. And for the fifth question, which the safest trimester for dental treatment in pregnant women, for that 100% answer was for the second trimester. This is the table. This is the frequency of the percentage of correct and incorrect answers for the of the participants for the knowledge questions which was asked. This is the frequency of the responses for the attitude, the questions based on the attitude. The first question for the attitude was whether the gingival changes observed in pregnant women are always referred to dentists. 73.5% strongly agreed. While for the second question, whether the referral of gestational diabetes mellitus patients to dentist is always recommended, 39% of the participants answered they don't know. Question 3, advising patient to include periodontal evaluation as a part of their prenatal care, 46% answered don't know for this. And for question 4, whether pregnant women do not need additional periodontal health care during gestational period, 48% answered they agree. And for last question based on attitude, the question was knowledge regarding periodontal changes during pregnancy is essential for gynecologists. 62.5% of the participants agreed. So this is the table for the responses, frequency of responses for the attitude questions based on attitude. And this is the chart showing the correct and incorrect responses of the participants for attitude questions. Discussion. Now here in this study, 68.5% of the participants responded that they didn't consider periodontal disease as a risk factor for systemic disease or condition. Similarly, 90.5% of the participants did not regard preterm low birth weight deliveries, and 81.5% participants for other pregnancy outcomes like preeclampsia as a risk factor for periodontal disease. So this may be due to the lack of awareness as well as the lack of current research material which is available, and it is proven for only few conditions and diseases like diabetes mellitus and cardiovascular diseases. Also, the association regarding periodontal disease and rest of the systemic diseases and conditions are still being under research. 83% of the gynecologists responded no increase in the level of microorganism in periodontal disease during pregnancy. Most of the participants responded incorrectly, indicating that basically there is poor knowledge regarding periodontal disease and its risk factors during pregnancy. Hence, efforts can be taken to conduct awareness programs in medical hospitals regarding dental and mainly periodontal diseases and its associated risk factors. The overall attitude of gynecologists was good. 73.5% of gynecologists agreed that gingival changes and disease complaints among pregnant females needs to be referred to dentists for further evaluation and treatment. However, 39% were uncertain regarding referral of gestational diabetes cases to dentists. This shows that gynecologists are aware about the general dental problems and need to refer to the dentist, but the awareness regarding the risk factors and effects of periodontal disease in pregnant women is low. 46% of participants were uncertain regarding advising for periodontal evaluation as a part of the prenatal care among pregnant females. Similarly, 48% of gynecologists did not feel the need for advising pregnant women for additional periodontal health care during gestation period. According to a study by Nudalapati et al., the referral to an oral healthcare professional was low among gynecologists, and referral was based mainly on the complaint of the patient and not to the awareness of the gynecologist about the possible relationship of periodontal disease and delivery outcome. However, 62.5% of the gynecologists agreed regarding upgrading their knowledge for periodontal changes during pregnancy and its usefulness. Bassett et al. In their study reported that 32% of the gynecologists mentioned scientific journals were the main source of information about the prevention of oral diseases, while 87% expressed that there is a need for further information about the prevention of oral diseases. So hence, in the conclusion, it can be concluded that the overall knowledge and attitude of gynecologists regarding association of risk factors for periodontal disease among pregnant female and referral to a dentist is moderate. A positive attitude of gynecologists regarding upgrading their knowledge was also seen. Hence, efforts can be taken for interdisciplinary approach among medical and dental fraternities, and awareness programs can be conducted in medical and prenatal care units regarding risk factors associated with periodontal disease and its prevention in pregnant women. These are the questionnaire which was used. And these are my references. Thank you.
Good evening, madam. It was a nice presentation. Are you able to hear me, madam?
Yes, sir.
I was wondering, why did you choose only 10 questions when you could have, these are educated people, you could have used more questions to elaborate more better results. No? Why took only 10 questions?
Sir, actually, gynecologists are very busy people. Like, they are the busiest health professionals. So, like, they don't give much time. Most of them were not able to even give time also for these questions, 10 questions also. So that's why I was trying to minimize how much less I can ask and get how much information I can get through those questions.
Basically, questions is based on the knowledge of the person. If a more knowledgeable person can be giving if they're ready to give time, it can be more elaborative as such. Anyway, it was a nice study, madam. Take care. Sir, what's up, sir?
Yeah. Good evening, ma'am.
Yes, sir. Good evening, sir.
Yeah, you have mentioned that there are changes in the oral microbiota, right, in a pregnancy. Can you please tell us about this? What changes are seen?
Increase in the like anaerobic bacteria, mainly the Prevotella intermedia, because of the hormones. Then even they have seen Tenarella forsythia and P. gingivalis levels also more increased in these pregnant females. These
what is the preferred
microorganisms are more seen.
What is the preferred antibiotics in pregnancy?
Amox is the most like safest, they say. Amoxicillin.
Why?
Amoxicillin is the safest for pregnancy.
This was the one of the question in your questionnaire.
No, not antibiotics, sir. Regarding the microorganisms, whether it was whether the level increase and whether it affect the periodontium, like that was the question. Like, do you think will it affect the pregnancy outcomes, microbiological levels? Like that was the question, sir.
Yes, next presentation.
Warm greetings. Today I, Dr. Nancy Srivastava, will be presenting my paper on the topic A General Dental Practitioner's Point of View on Periodontal Treatment, a Survey. Epidemiological research indicates that periodontal disease are a global pandemic, and evidence shows a prevalence of 50 to 100% in geographically diverse Indian subcontinent. A predominant urban population with higher occurrence of periodontal problems visits private dental clinics across India. The liability to first examine and evaluate the need for periodontal diagnosis rests solely in the hands of a general dentist. However, a typical scenario in dental clinic around us is that only patient symptoms are addressed to, but periodontal disease do not show much symptoms unless it has reached an advanced stage of destruction. An early diagnosis assumes an utmost importance that we can prevent periodontal disease before it reaches an advanced stage. So there is a need to evaluate the attitude and perception of a general dentist towards periodontal treatment. Hence, the study aimed to identify the various aspects of periodontal treatment provided at a general dental clinic. The material and methods. This was a survey conducted on 100 registered dentists in the city of Jaipur. All the dentists with BDS and MDS dentist degree with working in their own dental clinic were included in this study. However, those general dentists who were not registered with Dental Council of India, or those who are having master's degree in periodontics, or those who were practicing for less than 5 years were excluded from the study. After taking a prior appointment and their verbal consent, a self-administered closed-ended questionnaire with 15 questions was personally handed to them. Coming to the results and discussion, the gender ratio in the study was 55:45 in favor of males, which I hope will shift more towards the female in the future. About 60% were holding MDS degree, while only 40% were BDS degree, which is obvious as Jaipur, being a big city, has more doctors with a master's degree. This is in collaboration with the study by Vidya et al. And Smita et al. Similar results were found in them also. Now coming to the questionnaire, mobility of teeth and gingival recession were the main factors which were considered as a sign for assessing the status of periodontium. Signs like bleeding on probing, pocket probing, furcation involvement, gingival enlargement, and trauma from occlusion were not given the priority. Only 5% of them did scaling and root planing for their patients with gingivitis and periodontitis, and rest all did scaling. This is understandable as root planing requires more skill, efforts, and time. More than 80% dentists used a calibrated probe or straight probe for assessing periodontal pocket, which is a very good practice. Periodontal disease was the most common cause of tooth mobility and not trauma from occlusion. Now, this can be due to less trauma from occlusion cases or less skill to assess trauma from occlusion. Only 11% said that they have checked furcation involvement in molar. This is unfortunate as early detection of furcation involvement can drastically improve the prognosis. Moreover, in those 11%, only 15% used probe for its diagnosis. Rest either used radiographs or clinical observation of gingival recession, which again is not an ideal method. Similar trend is also seen in observing the mucogingival defect. Only 28% did it. In those 28% also, more than 60% just checked for gingival recession. Rest factors like adequacy of attached gingiva, abnormal frenal attachment, interproximal papilla loss were rarely detected. This again is not a good practice, probably due to lack of awareness, knowledge, and skill. Only 30% of the dentists referred or consulted their patients to a periodontist. The 70% did the periodontal cases themselves. Now, the reason for this was not asked, as this can be due to the non-availability of a specialist or a simple financial decision. In a study by Jadhav et al. In Ahmednagar, similar results was found. There, the main reason was given the lack of patient motivation, whereas in a study by Smita et al. In Karnataka, in rural areas, the main reason was given the non-availability of the periodontist. On asking those 30% that in which cases do they recall the periodontist, the most common causes were recession and gingival enlargement. This is similar to the other studies where periodontists were consulted for gingival recession. Cases of bleeding gums, mobility, pocket, or abscess were being treated by general dentists themselves. Now, whether this is a good or bad could have been known only by asking the success rate of these treatments, which we missed. More than 80% said that periodontal retreatment was required in their cases. But on asking that, what did they think was the reason for the recurrence of the disease, more than 70 said that it was due to the patient factors and not the operator factor. This could be true or false, as the patient factors are important for the success of periodontal treatment. But as already seen in most of the general dentists, are doing their periodontal treatment by themselves and not calling a specialist, so operator factors cannot be ruled out. Regarding the cost effectiveness, more than 70% said that it is both beneficial for both the parties. This is in contrast to the study by Vidya et al., where dentists mostly said that periodontal treatment was unaffordable by a large section of the society. Now, the answer to this question, in my view, depends upon the paying capacity of the patient. In a city like Jaipur, high paying capacity can be expected. Now, less than 15% of the dentists were seen attending the CD programs regularly. Moreover, less than 10% were attending any course on periodontology. This shows that there is a lack of continuous appraisal of the knowledge and skill sets of graduated general dentists. These factors may lead to a decline in the overall quality of the practice. This was similar to the study done by Straub and Moran, where similar results were found. To conclude, I would like to say that the field of periodontology has grown in all dimensions. Same is now not reflected in the way periodontal diseases are managed in the private dental setup. In urban areas, the patients are aware of the importance of oral health and seek treatment. The management of the disease in general practice depends upon the knowledge, attitude, and practice of the dentist towards the importance of periodontal treatment. The general dental practitioners first should be able to make an early diagnosis of the periodontal condition, motivate their patient. Then they should provide timely treatment to the patient and refer them to a periodontist. Through this study, it was found that most of the general dentists have a positive attitude towards periodontal treatment and are mostly treating the patient themselves. But the problem arises due to limited knowledge, skill of the operating dentist, moreover the lack of the interest to learn more through CD-like programs. In my personal view, we have to increase the practical knowledge of the general dentist in periodontology. This can be achieved through two ways. First is by organizing more CD programs, workshops on periodontal procedures and motivating the dentist to attend them. Second and more effective one is making changes at a graduation level itself. The BDS course, the knowledge of periodontal disease and treatment is given just in the third year and final year. Moreover, the students are just exposed to scaling with no preclinicals in second year like conservative and prosthodontics. So there's a need to add preclinical portion in periodontics and add operative procedure training in clinics and not limit them just to scaling. With this, I would like to thank you all for your patient listening.
Very good evening to the respected judges.
Very good evening.
Yes, sir.
Madam, I am one interested.
Yes, sir.
Do you think there should be practice for a practitioner to get more knowledge rather than attending CDs? Why not make a compulsory exams or something like that, like USA, wherein you every 5 years you need to give exams to continue practicing?
True, sir. True, sir. That is a very good suggestion, sir. I think we need all of us should need to sit and make a cohort, and suggestions like this is going to definitely improve the field of periodontology. We all are into the in academics, and we are actually the guiding force for the future generation. So, sir, this study, why I was interested is because most of the general practitioners, when I visit, then we see that there is a very limited knowledge regarding periodontal therapy. So it is actually very true, sir, that your suggestion is very true, that if we take an exam or do some more of the workshops for them, or add some operative procedures even during their graduation days, that is going to develop more interest in them for the subject, and as well as it is going to improve their clinical skills for them to practice in their clinics.
Sir.
Good evening, ma'am.
Good evening, sir.
Madam, when to refer the patient to periodontist?
Sir, actually, sir, actually, it depends upon the case. So, like according to me, if the clinician is aware about the signs and symptoms, like if he sees that there is gingival enlargement or there is inflammation of the gingiva, or there is recession or mobility, then at that time, instead of intervening by himself and doing scaling by themselves, they should call a specialist, so that a better comprehensive view of the entire situation could be achieved and they could provide a better treatment plan to them.
Okay. Thank you. Thank you.
Madam, there is a ADA guidelines for this.
Yeah.
When to refer to the periodontist.
Yeah.
Okay, sir. So I'll go through it.
ADA guidelines, there is a guidelines given by ADA about how to or when to refer periodontist. Anyway, nice.
Thank you, sir. Thank you.
Sir, this was the final presentation. Sir, I would like to end this session by thanking Dr. Purushottam and Dr. Girish, our moderators, for their valuable time. Thank you, sir.
We would like to thank Dr. Sangeeta Madam, Dr. Mahesh Ahir, and the organizing team of ISP 2021.
Yes, sir. Thank you, sir.
Even from my side, I would like to thanks all the organizing committee, Sangeeta Madam, Mahesh Ahir, and you also.
Yes, sir. We'll catch up sometime, sir.
Yeah.
Okay,
Yes.
Chiro, take care, sir.
Thank you, sir. Sir, we'll end the session.
Okay, Chiro. Rakeshwar sir, bye.
Yes. Bye, sir. Bye, sir. Bye.
Take
Thank
care.
you. Thank you, sir. Thank you, sir.
जल्दी भेजने के लिए बोल रहे हैं.
Right.
Okay, sir.